thickness of dermis is completely damaged. There may be additionally damage to the subcutaneous bed of fat in the underlying tissues. The management of such injuries is surgical, which entails completely damage and resurfacing. There may be additionally damage to the subcutaneous bed of fat in the underlying tissues. The management of such injuries is surgical, which entails completely damage and resurfacing. There may be additionally damage to the subcutaneous bed of fat in hospitals where I have been working. The management of such injuries is surgical of rehab medicine, Islamabad, Pakistan, and resurfacing. Jackson model of damage has been the most powerful guiding force, which helps us to understand the pathophysiology of deep rehab medicine as it guides the management. According to this model, the burnt skin has three zones: the zone of coagulation, zone of stasis, and the zone of hyperemia. In this 3D picture, this white area is the zone of coagulation which has been completely damaged. This is the skin which needs excision and resurfacing with a skin graft. The blue area shows the zone of stasis, which is the area where the blood flow is in jeopardy. If we rescue the patient and infection prevention, it has all the likelihood to become normal. Otherwise, it also becomes part of the dead skin. The zone of hyperemia is essentially the inflamed zone, which usually reverses when the patient is successfully managed. When we are dealing with patient, we are aiming to restore the anatomy or form. We are trying to restore function, our physiology, and to talk both of these. It's very important to understand that we are dealing with a psychologically traumatized patient, and his emotional and psychological well-being is very important. Let's see how do we manage deep burns at our institute. The data I'm presenting is based on a continually updated computer database. And what the patients which we manage, we take their photographs preoperatively, intraoperatively, and postoperatively. The data I'm presenting excludes the deep burns, which were less than 5%, we say, were suicidal burns and the inhalation burn injuries. These burns are deep, but their outcome as well as management outline is different than the rest of the burns, so they have been excluded. Majority of the patients were females. Why are they more prone to sustain deep burns needing surgery? Because they are more involved in the household activities, especially the kitchen care. And that's why they are more prone to have deep burns and need surgery. Majority of the patients were adults. Flame burns constituted the leading cause of burns that needed surgical management. Most of the patients which I'm presenting had a TB, say, of 20 to 30% involved. This slide is very important. The mean TB, say, of the included patients was 30. The mean operating time was 2 hours, 10 minutes. We are very particular to ensure a very smooth power play while performing surgical excision and grafting. We ensure that all the staff is tuned and there is a teamwork spirit. All the machines involved, such as dermatome and measures, are in place, and the disposable items which we need for surgery are available. This helps to ensure that the patient is not exposed to the risk factors, which are hypothermia, acidosis, and coagulopathy. If any one of these ensues, mortality is inevitable. And at the time of surgery, we are very conscious about prevention of hypothermia, acidosis, and coagulopathy. Transfusions are very important in cases of excision and grafting. Before we move on with the excision, we ensure that the patient has a hemoglobin of no less than 12. And we have a rough idea that 10% TB, say, excision involves a loss of 1 pint of blood. So We try to compensate for the losses and to be sure that the patient doesn't have low hemoglobin post-operatively. The mean hospital stay of these patients was 12 days and there was no mortality. Here are a few representative cases. This unfortunate lady was newlywed and probably she went to the kitchen for the first time. She sustained deep burns to the front of the trunk and the adjoining parts of the hands and thighs. The face was also burned, and at the very outset, the looks were horrible, and we had to rescue her with aggressive resuscitation, aggressive infection prevention protocols, ensuring good nutrition, preventing metabolic derangements. And once she was stabilized, we proceeded with excision and we resurfaced the raw areas with the skin graft, which was harvested from her own body. We try to address all parts which are affected in one go because there is no infection initially, and we get a good chance for the patient to recover. This is how she presented, and she was fortunately rescued, and she was okay just 4 weeks down the line. This unfortunate child presented with deep burns involving the frontal part of the body. She was doing some kind of birthday celebration in her school. We stabilized her and we excised all the involved skin. We resurfaced it with skin graft and we tried to address all the involved areas, and she went home absolutely fine. This unfortunate lady came all the way from Afghanistan. The looks are horrible and it required a great deal of work. We stabilized her, we subjected her to surgery, and she was managed with excision and grafting, and she went home very happily, and she was fine. This
हाँ जी
unfortunate lady had the same story of sustaining burn injuries
पता नहीं
while
मुझे नहीं
cooking,
समझा मुझे
and
तो
we
मैं
had
तो
to
वो देख रहा हूँ
stabilize,
सारा
excise the burns,
हाँ
resurface
क्योंकि
the
मेरे
area
एंड पे तो मैं
from
तो सुन रहा
graft,
हूँ आपकी
and
सारी
she was
बात
fine. This
और ये
unfortunate
मुझे
lady
अच्छा मैं
sustained
मेरा
chemotherapy.
कैमरा शायद ना हो
She had
मैं
6 months of
कैमरा देख लेता हूँ अगर
pregnancy.
उसको
The challenge was twofold: to rescue the patient as well as the fetus. We stabilized, we resurfaced the areas, and she was okay, and the baby was also fine. This child was doing some kind of kiting, and he sustained flash burns from the high voltage electric wires. We excised the deep burns and resurfaced with skin grafts, and he was rescued, and we were happy. This lady had the same kind of acquisition history of flame burns in the kitchen. We excised and resurfaced with skin grafts, and she was fine. This child, because of being curious and inquisitive, they're more prone to sustain injuries. He jumped into a boiling egg of rice, and the deep burns were excised, and we had a good recovery. He is chef by occupation, and he sustained deep burns while performing his cooking activities. Excised the deep burns and resurfaced, and he was completely recovered. This child had deep burns involving lower limbs. We rescued with resuscitation and excision and resurfacing with her own grafts. She went home happily. This guy presented from Iran, and he sustained flame burns because of explosion with the petrol, and we manage him aggressively with excision of the dead tissue and resurfacing of the raw areas with skin graft harvested from his own spared areas. And he completely recovered, and we were happy to see him again. Deep burns, which are more than 20% TBC involvement, they are inevitably lethal. If we just leave them on conservative management with dressing, they die because of sepsis, because of metabolic derangements. In the acute phase, they don't survive for longer than 6 weeks. So we should excise the dead tissue to take off the septic emboli and to give them a chance to survive. When deep burns, which are less than 15 to 20% TB, say if they are managed with conservative approaches of dressings, they may survive, but they develop unacceptable physical deformities and margarine ulcers. Management of these problems is more difficult than the management of acute burns. So we should not ignore such patients. Here are a few examples of patients who were managed with dressings, and this guy presented with a wound which was managed with dressings for months and months, and he presented with margarine ulcer later on. Another case of similarly managed case of burns who presented with margarine ulcer, he needed much more extensive excision and reconstruction. Such kind of contractures are very common in our practice, and this is because of the initial mismanagement of deep burns. In the civilized world, such deformities and contractures are almost obsolete. Here is another case of contracture of the neck. It's so much humiliating to see such patients. Another case of similarly conservatively managed deep burns, and the deformities are very disfiguring. Hand is a very important organ of the body, and with respect to function, it is second to brain. And we manage it very aggressively and properly. And when such improperly managed deformities present to us, we do whatever we can do, but they cannot recover to the completely supple, soft, and functional hand. So this patient also has contractures, and it's very difficult to return them to normal function. So we should manage deep burns appropriately rather than with dressings. A stitch in time saves nines is the proverb which holds true when it comes to the management of deep burns. If we properly manage them, they don't develop deformities. If we fail to institute the correct management, they develop deformities. So a stitch in time saves nine. This is one of our research publication which has been cited by more than 100 papers, and it has been cited by the American ISBI guidelines and has been quoted by our standard textbook of Grabe and Smith also. Thank you very much. And again, I would sign off. Thank you.
Thank you, Dr. Saik, for this insightful presentation. I'm Professor Dr. Saira Sleem, working as Head Department of Breast Surgery at Medina Teaching Hospital. I would like to ask you one question, what measures you take to prevent hypertrophic scar that is very likely in deep burns?
Thank you, madam. Madam, hypertrophic scars are more common among children as well as women. And once we are done with the skin grafting, it doesn't finish the story. We have some certain rehab measures for the scar, especially the use of compression garments, which may be silicone coated or which may not be silicone coated. Similarly, regular massages are paramount. In addition to those, there are certain silicone-containing gels which we employ in our common practice. And despite of these measures, there is a small percentage of patients who still have a tendency to develop hypertrophic scars, and they're the ones who are then managed with intralesional Kenacort injections. In our recent practice, we have newer agents such as the tacrolimus, which we employ to address the severe hypertrophic scarring. I hope this...
Okay, thank you. And you advise some pressure garments as well?
Madam, routinely among children and women, we employ them the custom-made compression garments. which have a silicon coating on it. And the pressure which the garment should employ is 40 mmHg. And the silicon has a number of benefits, such as mechanomodulatory effects, the transmission of isoelectric charges to the scar. And there are certain unknown mechanisms through which it improves the scar.
Okay, thank you very much.
Thank you, madam.
Thank you, Dr. Muhammad Saik, for that impactful presentation. If
you.
anyone of the delegates have any questions, please feel free to ask.
Thank you so much, Dr. Muhammad Saik, for your insightful presentation. My question is that do you think early excision reduces biofilm formation significantly, or is that benefit overstated?
Madam, it does. When we ignore a patient with such large surface area, we encourage all kind of bacteria to have their activity and the development of biofilm. So this approach helps the likelihood of early infection as well as the formation of biofilm. So that is not overstated. It is correct that it does inhibit the formation of biofilm.
Thank you so much, sir.
Thank you.
Thank you so much, sir.
Thank you.
Sure, ma'am. Sir, we have another question
Yes.
from our worthy chair of this session, Professor Dr. Nabila Talat.
Assalamualaikum, Dr. Saik. A very well collected data with very well managed cases. Thank you for sharing with us. My question is that in our setups, especially in public sector, we face a lot of challenge of infection in all patients, especially in burns. So with deep burns in your case series, how much infection pre-operatively you faced and how you managed, and post-operatively after the excisions and grafts, what is the incidence of infection and how you manage those cases? What was the effect in the ultimate outcome of those patients? Thank you.
Madam, in one of our prospectively collected data and published data, there was a significant difference in the rate of infection among those who underwent early excision versus those who underwent delayed excision. The summary is if we delay a patient beyond 7 weeks, beyond 7 days, there is great likelihood of infection with Pseudomonas in particular. And the other skin flora, such as Staph aureus and epidermidis, also begin to flourish in such kind of wounds. When we excise them early on and we institute antibiotic therapy at the very outset, the chance of infection is much more reduced. Also, it also depends on the kind of the setup where we work. If there are very well-trained staff and there is infection prevention and regular cultures of everything, including the patient's wounds and the OT and the walls of the burn center, that greatly helps to have a good surveillance and prevention of infection. In the USA, there is a great concept of infection prevention in terms of the fact that if we visit their army burn center, they have made 2 mirror image buildings, and one building is operational for 1 week, and for the next week, the other building, all the patients and the staff move to the other building, which has been fumigated for 1 week. And the same cycle is repeated again and again. In Pakistan, we don't have similar kind of arrangement, but still the only thing which we can employ is that we don't wait for too long for the patient's wound to become cultured positive with the Pseudomonas or Staph aureus or other organisms. So, in short, I would say that early excision is one very important and effective tool in our hands that helps to prevent the onset of infection in the burn wound.
Thank you. So my second part of question was, what is the incidence of post-operative infection in your grafted patients?
Madam, the patients who are culture negative, at the time of excision and grafting, we take tissue for culture sensitivity. The patients who are negative at the time of surgery, they are the ones who are negative post-operatively also. But a small percentage of patients who are culture positive at the time of surgery, they also turn to be positive post-operatively. But with the institution of the culture-sensitive antibiotics, we don't come across graft loss as would be expected otherwise.
Okay, thank you so much. So my just one comment for, as the students and residents are here also, that this need has to be minimum, and we all need to work on the preventive aspect, because here we focus less on the preventive measures. Burn is a preventable thing in all of its type. So we all need to target to create awareness, and then the work of like Dr. Saik and many others is appreciable. Thank you, Dr. Saik.
Can I make a comment?
Yes, sir.
Yes, sir, please.
My comment is that there's no single intervention that will change the outcome significantly. If your hospitals and your wards and your operating rooms do not exercise a very high level of infection control, then it will not be possible really to follow any thing for a long time, because then you will have short interventions, then you'll be very, very particular about preventing infection, and then there'll be lapses, and then your results will start becoming bad. This happens very frequently with every intervention in less developed or developing, as we call them, countries, because consistently doing something good is not somehow has not been achieved in our system so far. We introduce a thing, and then it deteriorates over a period of time, and then we're back to the same thing again. Now, this is what the army has done in their burn center, because they knew this, that they wouldn't be able to have a sustained control over all these activities. So they take the final major intervention that we'll move to another place. As a matter of fact, even that is not an ideal situation, because that means that your infection control measures are not up to the mark. And that shouldn't be required on a weekly basis, on a regular basis. It should only be required once in a while. And that is what we need to really work on, because if you go to any hospital, particularly a public hospital, or even to major private hospitals, you can see in 5 minutes that the policies of infection control are not being used effectively. And the second thing that happens there is that we have left and right use of all potent, broad spectrum antibiotics throughout the day. There is no policy in the hospital for use of antibiotics, and that leads to very resistant strains. And when you talk of Pseudomonas, I mean, that's a hospital-acquired infection, and that really tells you that how good is your hospital infection control. So I think we need to look at this problem holistically, and unless we have improvements in every component of the management, the results may be very limited in a couple of few centers. But I mean, the problem of burns is enormous. It takes place in the entire country because of our social factors. People live in single room homes. They have a kitchen in there. They have 3 small children who are roaming around. The electrical sockets are not safely placed. Children put their things into the sockets. And so burns we'll not be able to prevent for a long time. But we need to work on the prevention. We need to work on hospital infection control anyway, not only from the burns point of view, but from every point of view. Because we're running short of antibiotics, and you've seen just the enteric fever, what has happened to it. That it's no longer responding to Oxidil, it's no longer responding to, even in certain cases, to Merenum, and people are really worried about it. So the same is happening to so many other things, the Staphylococcus, the MRSA. So I think it's time that people start working on preventive infection control measures more than anything else, regardless of what specialty you're following. Thank you.
Thank you very much, sir. Dr. Saik, we will need your brief response to one last question by another speaker, Dr. Taqir. Dr. Taqir, kindly ask your question.
Assalamu alaikum, Dr. Saab. I'm Dr. Malik from Islamabad. I have a question for you, sir. Do you have experience with a cadaveric skin or amniotic membrane as a skin substitute? Thank you, sir.
Sir, amnion at one point in time we used in case of vaginoplasty, especially in coordination with our maternal and child health center. But to be very honest, there were problems with having infection-free amnion in the first place. And then after 3 weeks, there was total loss or rejection of the amnion because it was not the autologous tissue. From then on, we just discarded that kind of idea. As far as the cadaveric skin is concerned, my friend Hassan, Colonel Hassan in the Kharia, he has now been working on the live-related donor skin. And since he has been working under the army setup, they have their own system of getting permission. He has done a little work on the live-related donor skin. But as far as the cadaveric skin is concerned, here in Islamabad, HOTA is the organization, Human Organ Transplant Authority. We have tried our level best to get it recognized, but there are many legal issues, ethical issues with respect to the use of cadaveric skin in Pakistan. So we have no experience, and nobody in Pakistan has ever thought of it. That cadaveric skin can be used as a temporary coverage for the first 3 weeks to save the patient until the time when the patient's own epidermis has been prepared to resurface the raw areas. So that's what we have been.
Okay, sir.
Dr. Taqir,
Yes,
just to add with Dr. Saik's reply that Professor Mahmood Shaukat is also online, and your concern of coverage of amniotic membrane, this has been tried under lead of Professor Mahmood Shaukat way back in 2008, 9, 10 time period when in New Hospital Department of Pediatric Surgery a lab was established, and we used to get the placenta from our sister gynae unit. Directly whole amniotic membrane coverage will definitely produce the issue of reaction, but de-epithelialized, desquamated amniotic membrane will provide the initial coverage in the deep wounds that meanwhile they become ready for the grafting, and even in superficial partial thickness wounds, they help in promoting the healing. But the only thing is that you cannot apply the whole amniotic membrane directly. There has to be desurfaced. Thank you.
Thank you, Herbal. I'm going to talk about it also a little in the presentation.
Thank you, Dr. Muhammad Saik, for joining us.
Thank you.
I
madam.
acknowledge the presence of our worthy co-chair of this session, Professor Dr. Muhammad Bilal Mirza, Professor and Head Department of Pediatric Surgery, Children's Hospital, Faisalabad. With a big round of applause, please welcome Professor Muhammad Bilal Mirza on the stage. I am honored to introduce Professor Dr. Mahmood Shaukat, a leading pediatric surgeon and pioneer in stem cell and regenerative medicine in Pakistan, currently serving as the chairperson of Nijinsky Medical Center. Professor Mahmood Shaukat has held various key academic positions in his career, including being the principal of Allama Iqbal Medical College, Lahore, and president of Association of Pediatric Surgeons, Pakistan. He has established the country's first stem cell laboratories and has extensive experience in treating various neurological and orthopedic conditions. Today, Professor Dr. Mahmood will be speaking on mesenchymal stem cells in complex wound care, from paracrine signaling to tissue regeneration. Professor, we are excited to hear your insights.
Thank you very much. I don't think it'll be very exciting because I'm not going to talk about any as you denote a pure scientific study. I'm just going to talk about a concept which has been introduced. It is an addition to your available means that you can handle for so many conditions, so many diseases, and wound is one of them, which is one of the commonest problems that everybody faces in every specialty. So stem cell application or regenerative medicine, to me, is not a specialty in itself. It's an additional tool, just like you had the laparoscope and you have the robot and you have the minimal invasive surgery and you have a cystoscope. So many people can use it. And that is what I'm trying to convince the authorities also at the moment, that this is not a specialty in itself. It has actually two components. One is preparation and growth of the cells, culture of the cells, and the second is application of them. The application of the cells will be done by clinicians, and that wouldn't require any great certified training, because we deal these conditions and we know how to do it. You have to inject the cells, you have to place them appropriately, but growing the cells would always remain a specialty, and that will be done by non-medical doctors who are PhDs in cell biology. And that is the basic concept, that this is just an additional tool which will be available, and this is based on rethinking on the principles of wound healing, and for that matter, management of it. So are you going to show my slides, or should I show them from here?
Sir, kindly, you can share your presentation. We have it. If you want us to
I
share
think
it,
it will be easier if you do it from there.
Yeah, that's fine. Presentations.
Okay.
But then you'll have to say next for us to move it on.
Okay, I'll do that. So you'll just let me know when we have the slides. Something happened here. I don't know what happened. Do you want me to show them from here?
Just a minute, sir.
Okay.
Sir, if you can share it easily.
Let me see if I can. Is that visible now?
Yes, it is.
Okay. So, but I can't see it now. That's it.
Okay.
Can you still see it?
Yeah, we can all see the first slide.
Okay. Okay. Now
Wound
this
is a
is
battlefield.
okay. Is it easily visible so I can proceed? A wound is like a battlefield. After the battle, there has to be some reconstruction, which starts. You have to build again what can be rebuilt, and then you also need to clean it up. You have to open the roads. You have to create access to the rebuilding activities. You have to transport the needed materials. You have to provide communications, control the activities in order to limit damage and rebuild what the thing well. So when you talk of a wound, it's precisely the same. When you've been hit or your part of your body has been damaged, then you have inflammation, you have proliferation, and then you finally have remodeling. The wound healing will take place, and this depends on, now this is where the stem cell concept comes, MSCs. It depends on growth factors, it depends on cytokines, it depends on chemokinetic factors, because that is what is disrupted by the attack of either bacteria or trauma or whatever it is. So these things need specific treatments as well. So what do you need there? Improved and enhanced repair activity or capacity of the area to rebuild. This is what mesenchymal stem cell would do. It'll augment the available resources in terms of workforce, macrophages, they come there, in terms of materials like angiogenesis factors, because the granulation would require new vessel formation, and timely and appropriate supervision. And then you have the remodeling, in which excess granulation is removed, and then the attempt is to move it towards a functionally competent repair rather than just a clean repair. Because if you have a missile hit and your buildings go down, they were functional units. But if you raise them on the ground, it'll be healed, but it'll not be a functional unit. So similarly, if you have your skin injury, you need a functional skin there. You do not just need a good scar. A scar will eventually form, whatever you may do. And you just saw bad contractures, they were scars. They left the condition healed, of course, but non-functional. So the wounds can be surgical, clean wounds, which are very good, which is what you would want. They can be clean contaminated, which is a little difficult, but still very good. Then you have traumatic, poorly managed wounds, what we saw in the burns. And then you have contaminated wounds. You have diabetic wounds. You have ischemic wounds. You have trophic ulcers and venous insufficiency. These are the wounds that I am talking about. That these are the challenges that really need to be looked into. Healing starts when the offense ends, because that is understood when the damage ends. So just like, as I said, like a war. So you have to give attention to the predisposing factors. You have to treat the causes. If there is a diabetic patient, unless you take care of the diabetes, nothing would happen. Then you have to make an assessment. As I say, that available ammunition of the enemy, that would be the diabetes, that would be the hypertension, that would be the ischemia, that would be the bacterial count, that would be the culture. And in our burns, we had a lot of viral infections. Nabila would bear me out. In Mayo Hospital, we had a lot of viral infections, but these were patients who were treated outside, and they all had. So your assessment is the first thing, because most of the patients that we get, we don't get them straight away. We get them late. So there's no violation of the principle. You have to keep it clean, you have to keep it moist, you have to keep it covered while maintaining good protein intake for the patient, proper hydration. These are all basic things. I will not put a lot of time on that. So inflammatory phase is when the initial response, where cytokines and macrophages prepare the wound bed for final healing. Proliferative phases where formation of granular tissue takes place, angiogenesis takes place, and reepithelialization starts, which is accelerated by regenerative therapies because, as I said, they provide you additional armamentarium to handle this situation. They would provide you more macrophages, they would provide you exosomes, which are actually the molecules that achieve between the cells, the paracrine messages, and so they make the cells work. They also directly affect the angiogenesis. So that is where the regenerative medicine comes in. So it's nothing new. It's basic rediscovering how does a normal wound heal, and can we accelerate that normal wound healing by providing these sources from an external source. So that is the concept. That's why I say this is no new specialty. This is just a technique which is going to be available to everyone. So every wound will ultimately, as I said, heal. So various definitions of regenerative medicine have been proposed, which means tissue repair and or enhancement, that you see PRP is used for enhancing the skin appearance. The development of the tissue that was not previously established. For example, in the case of genetic anomalies, you introduce things and genetically you try to modify the outcome of those genes, and techniques that are employed like stem cell making new organs. There has been lately an introduction of a technique called partial regeneration. That's why I put that in 3 different colors, because I don't really understand. Most of the people don't agree with that. So this is just, you can look at it, what is the source of the stem cells, where do they come from, and what do they do? So all these conditions can be treated. My main emphasis at the moment is on autistic children, and we've had very good results in that. But during earlier days, as I said, in Pakistan, we started this use of stem cells and growing stem cells and using them. The objectives then were very high. We were talking of a national cooperative program with so many other universities, but most of them didn't materialize. LUM didn't show any interest. Agriculture University, UOS, didn't show any interest. So we were unable to. The only thing that materialized was a close collaboration with Center of Excellence in Molecular Biology that continues to date. So now coming back to Nabila. Nabila was working with me when we started this project, and she has a lot of contribution in that. We thought, how are we going to carry these stem cells onto the burn? And let me just clarify one thing. Amniotic membrane is not a replacement for skin. Neither is cadaveric skin a replacement for skin. These are temporary biological dressings, and there have been some evidence from South America that people have used the fins of tilapia fish also, the skin of tilapia fish also, as a temporary dressing, biological dressing. The advantage of biological dressings is that they are superior to the routine dressings, and they cover the wound better, and they also introduce some biological environmental changes. And they're supposed to be superior, but they are not replacements for skin. So that point needs to be understood. So we decided de-epithelialize amniotic membrane, and Nabila was the major worker in that. And I always thank her for that. And then we started using, because Mayo was the only pediatric burn unit, and 12% of the total admissions of Mayo Hospital pediatric surgery were burns. So that was an enormous number. So we started preparing Simultaneously, we had a biological scientist, Professor Faridoon. He was appointed in KE from the HEC, but he had nothing to do. So we borrowed him from KE to our department, and we started growing. On the top left, you can see the isolated MSCs that we were able to grow in culture. And at the bottom, I think this is Nabila preparing an amniotic membrane. He used to prepare de-epithelial eyes. We all did that, but major component was done by her. So how do you do, so what does it really do? These MSCs are expected to differentiate into skin cells. That's one component. And they also have a lot of paracrine effects. They release growth factors. They stimulate the angiogenesis. They stimulate new skin appendages. That is what makes it functional. And they stimulate the inflammatory response, which brings in a lot of blood. As was previously mentioned, there's a zone of stasis. There's a zone of ischemia. And that if that can have more blood, it has a more chance. So this is the final prepared product, which is being placed in the Petri dish for final. Initially, we just used the amniotic membrane. So to improve our experience of use of amniotic membrane as a temporary biological covering. And subsequently, we started putting some cells on that. And these were done by, as I said, by the cell biologists. We have no role in that. We don't do anything with the lab, except that we made that lab out of donations and out of my own personal expense, because I thought this was an enormous opportunity for Pakistan and countries like Pakistan to really step into the research and make a mark. So we did a lot of these things. Although we used, I think we made about 2,000 amniotic membranes, and we bought a freezer and we had a backup electricity so that we never lost electricity. And we used them quite a lot. And then finally, we did about 20 patients in which we used PRP initially at the edge of the wound. And then we put these cells on the amniotic membrane and put them on there. But this was a very limited time, because then I moved to Allama Iqbal Medical College. Now I had some experience, so I set up a lab in Allama Iqbal Medical College, again in the Department of Pediatric Surgery. And there we didn't have a lot of burn, practically no burn, and there was a burn unit being coming up. So we had the stem cell for burn given to the burn center, and we focused more on spina bifida, because that's what we thought was unavailable. So we had about 30 patients, and that study has also been presented. We had very good results in 27 out of the 30 patients. Plan of work, I'll not go into. So here we move to SVF, because I thought that's a great opportunity of looking at another technique for developing stem cells, and that's a much easier thing. You take the fat of the patient, and you again need a cell biologist. So we employed a cell biologist here also. Roma, Dr. Roma is again a PhD in cell biology with her postdoctorate from USA. So she was preparing all this SVF, and we were injecting SVF directly into the meningocele sac. So I'll not talk much about this, because obviously this is not the topic of today. So these were some of the burns patients that really responded well to amnion, as well as, now I can't really tell you, in this I remember had the use of MSCs, and this also had the use of MSCs. But since these are very old slides, now this is lately that we've done on, this was, we have a collaboration with the ISCA, which is the International Stem Cell Application Organization, which works in 56 countries. So we invited them to Pakistan, and our main focus was on treating these chronic wounds. That's the component of wound management that I've been actively involved in. If you can see, these are very bad chronic wounds, and some of them were ischemic, some of them were venous, and very bad skin loss wounds. And after stem cell treatment, which was about 6 applications, and this took about 3 to 4 months. They did the first three applications, then subsequently we had to do them in our lab. And we had very good results from wound management, and encouraged by this. And if you look at this was all dead skin. And if you look at the outcome, I mean, you can't even see much, except the 2 sinuses, which I think are because of the osteomyelitis, and we'll tackle it subsequently if needed. Similarly, we had so many other patients where normal management would have taken months and months, and probably with very little hope of recovery. But in about 2 months, most of these wounds not requiring anything other than just stem cells or exosomes. We were using both of them, but I don't use exosomes now because we don't make them here. And the transportation of exosomes requires transportation at minus 70 degrees centigrade, which is not possible, because formally you can't import them and people hand carry them. And I don't think that's a reliable thing. So ultimately then, since we have a long collaboration with the Center of Excellence in Molecular Biology, after the ISCA, we asked the Center of Excellence in Molecular Biology to help us. And this is what we did. We used the amniotic membrane here also to place the cells. Although ISCA wasn't using any amniotic membrane, they were just injecting the cells into the perilesional area. But we thought that since we already had enough experience with amniotic membrane, and we thought that was very good. So we used here again amniotic membrane as the medium for transferring mesenchymal cells to the wounds. And we again had some very good results. Basically, my message is that stem cell application and regenerative medicine can be as simple as PRP, and you don't need anything. When you don't have many options, there's no harm in using PRP. There's another study that I had suggested to Nabila, I don't know where did that reach, that in children with major trauma, if they don't have enough blood, we can use the donor's PRP also, and that would be the first possibility of using a donor, because if you have a group matched donor PRP, and I suggested that to one of our candidates who was a candidate for MS, that they should use that. So I think we need to innovate. We need to learn to innovate. Learn to apply the knowledge is the first stage, and learn to innovate is the second stage. Unfortunately, developing countries have lagged behind in the desire to innovate. So we need to really work. PRP would do wonders, but I don't know why it is used very, very infrequently, because it is considered to be something special, to be used by a specialty only, which is incorrect. It can be used by anybody. The only thing is that you need to use it consistently. You need to keep your results, and then you need to learn from it yourself, and then you need to innovate. As I said, we've innovated to have PRP from the donor also, and we'll see how does it work, because there are no objections to the use of, if you can give blood transfusion from the same group, you can also use PRP from the same group. And in a way, there's a possibility of ultimately looking at a PRP bank. And so just like you have a frozen plasma. So that's what I think is what we need to innovate. And the role of the universities and teaching institutions like tertiary hospitals is to really make the younger people think and come out with novice ideas. So that's the message today that I wanted to give to everybody. Thank you very much. If there are any questions, I'll try to answer them. Hello?
Thank you so much, sir. Like always, I think the whole panel of audience sitting here has learned a lot. And also, I'm thankful that I, at that time, worked under your guidance and was a part of that very innovative project. So my just a little concern, which I think will be questioned in many minds here, about the cost and feasibility, especially in public sector hospitals. Like you remember, you put a lot of effort, and we also for developing that very small initial scale lab at Mayo. So with passage of around a decade or more, now how you see it and what are the cost constraints at the moment?
Yes, my answer to that question is twofold. The first is that I don't think there's a cost for a passion. If you remember, I had raised all the money myself for the lab in Mayo, and I had to repeat that for the lab in Allama Iqbal Medi, because I think if we think that we lead the medical profession in any capacity, then we also have responsibilities, and then we also have to do sacrifice. Because if you look at the story of any development, there's always the first phase of sacrifice. And secondly, I think in Pakistan and in countries like Pakistan, things don't happen spontaneously. There's nothing planned here. There would be not any help coming spontaneously from the authorities that implement. The good thing is that when we were training, there was hardly any potential for a private setup. But now there are organizations that can set it up, like this university. I don't think it'll be a major deal for a university of this size to really invest in stem cell lab. And now the cost has come down because China has become a big player. We had to import everything from the USA. We had to import most of things from UK. But now everything is available at about 35% cost of what we spent. So I think initially the cost meant something like 80 or 100 million rupees to set up a stem cell lab. But now I think you can set it up with the inflation in the same amount, because inflation would have made it 3 times, but China has reduced it by 1/3. So although the dollar has gone up from 60 to 300, but the cost has remained around 8 to 10 million rupees. Sorry, not 8, 18 to 20 million rupees for setting up a lab. But as I say, that you don't have to set up a lab in every department. What is 20 million for an institution? इतने के तो हम ले लेते हैं, छोटी छोटी एक अल्ट्रासाउंड मशीन, एक एको मशीन जो है वो आ जाती है 50-60 लाख की, एक अल्ट्रासाउंड मशीन 50-60 लाख की आ जाती है, अच्छी एनेस्थीसिया मशीन 70-80 लाख की आती है कम से कम. So I think at the institutional level there has to be a champion for this work. It is not the cost. The cost is certainly not prohibitive. The cost will pay itself, the cost will come back, and then we can work on a model where you can also provide this to people outside the hospital and you can earn some money for the hospital. Now, the problem is that when we want to earn money for the institution, then only we can progress. Unfortunately, वो जो हमारे डिवीजन हो जाती है ना, वो जो मरीजों से पैसे आते हैं उसके शेयर बढ़ जाते हैं. मैं हमेशा से उसके खिलाफ हूँ, लेकिन maybe one day that will materialize, because whatever money the hospital earns should be reinvested in the hospital. And if we can convince the government and the administrators about this concept, I don't think this is a very prohibitive cost.
Sir, we are extremely grateful for your participation despite a busy schedule, and we really, really appreciate the proactive role that academic leaders like you have done for bringing the innovative new technologies to treat patients. I think all of us sitting here really appreciate your work.
Thank you very much. Thank you. And I'm sorry, I will not be able to stay with you because I have a meeting of the Healthcare Commission at 10. So I'll be leaving now.
That was our fault because we had to move our conference 2 days later. Otherwise, you had promised. So next time, inshallah, next time.
Inshallah.
Yeah,
Inshallah.
inshallah, sir. Thank you so much, sir. Jazakallah khair.
Thank you very much.
Thank you, Professor Dr. Mahmood Shaukat, for joining us.
Thank you, Ji. Thank you very much.
I am pleased to introduce our next speaker of this session, Dr. Bilal Hussain Pracha, Assistant Professor of Emergency and Family Medicine from Dallas, Texas. He has contributed a lot in Gaza and is set to share a compelling talk on the resilience of Gazan healthcare heroes. Join us as he sheds light on remarkable stories of healthcare professionals in Gaza.
Assalamu alaikum warahmatullah. How are you doing, everybody? Can you hear me? Can you hear me on?
Yes, Dr. Bilal, we can all hear you.
Okay, thank you very much. Alhamdulillah Rabbil Alameen, wa salatu wa salamu ala ashrafil anbiya wal mursaleen, bismillahir rahmanir rahim, nahmaduhu wa nusalli ala rasulihil kareem. First of all, thank you very much. I'm really humbled and honored to be invited to this international esteemed dermatology conference. And I apologize if I sound a little sleepy because it is around 12 o'clock here in Dallas, Texas. And I will not be presenting such high academic innovative ideas and updates in dermatology, rather just simple, maybe talking about the purpose which brings us all together, which connects us all together as the healthcare workers, no matter what specialty we belong to, but why we are all working to save the humanity. And maybe that's why I have been invited here. And thank you very much, Dr. Tanzila and Professor Dr. Tanzila and Dr. Saim Ghori for inviting me. So this is a presentation. Hope you all can see that. So we are all Gaza. So one thing which always people ask, like how the resilience is going on, how they remain steadfast, those healthcare workers. And basically this is one of the most important reasons I think that the whole society is standing up steadfast, no matter what is happening and how the destruction is coming their way. So one reason that the reality, maybe the only reality which you find out as soon as you reach there, no matter we are Muslims or non-Muslims, when I present here these kind of the talks, many of the audience will be non-Muslim, and no matter we are practicing Muslims or not, but the moment you reach Gaza, you understand the Quranic verse, وَمَا الْحَيَاةُ الدُّنْيَا إِلَّا مَتَاعُ الْغُرُورِ, that this worldly life is nothing but a delusion. It does not have any reality other than just some kind of the imagination. That was my picture. Basically, that was my video, which I recorded last year in July. That was the most difficult time. Absolutely no food available at that minute. I remember one of the ICU nurses telling me that we come hungry from home. And home means tents. Most of those were displaced living in tents. And we come hungry here, we go back hungry, our kids are hungry back there. What do you want from us? Just kill us all. That is what he was saying. Yet they are coming day in and day out to save their people, no matter what's going on. And that day, I think it was July 12th or 13th, 2025, when they told us that today, World Central Kitchen, who had been providing food there one time, and that food would be like just a plate of rice or dal or something like that, and that they had been providing to the healthcare workers throughout this time, and they said, no more. We do not have any more food to give. That time we did see the hope dying, yet nobody gave up. And I recorded this video at that time, and after that, thankfully, things in few weeks started getting better. And then, as we know, things are much better, yet every time the hunger is still there and the death is still there. This is a picture in front of the hospital. This is Shohada Aqsa Hospital, Deir al-Bala, which is in the middle of Gaza. And you can see these kids still smiling and still enjoying life. Maybe many of them or some of them would have lost some of their family members for sure. This picture is really very dear to me and close to heart. These are the medical students, and you can see the shine, you can see the smile, the brightness on their face. And that shine and brightness remained there every time we went back, and that determination and the passion and the dreams, they're always there. And you see their like white coats, their clothes, and most of them are coming from like living in the camps, because their medical college, which I will show you the picture, it was in the north part of the Gaza that were badly destroyed, and their homes were there, and now they were all displaced with the families here and living in tents with whatever conditions you can imagine. Yet every day they will show up to the hospital ready to learn and ready to take care of the injured, the wounded, the devastated patients around there. Before they're moving forward, so each of them like sort of still had their dreams. So I asked them one day, I like had a little interview with them, and I asked them like how it happens that you are coming every day and still with these bright faces and keep going on. So one of them, the girls here, I think this one, she said that every night when I sleep with the preparation that this is my last night. I'm going to die tonight. And she said, I sleep with my sister. We are in the same room, and she was one of the fortunate girls who still had their home, because their home was in the same area and it was not attacked until that point. So she said that when the bombardment is going on, my sister, she would turn around and she would say like, sister, we are going to die today. So I'll say, not tonight. Let's see, we will have another day. And then the other day when comes next morning, we will come back as a new life, as a new day, and keep going on. Same thing, I asked a professor of anesthesiology who was like head of anesthesiology and hospital, I think deputy director, and he met us first day and second day and taking care of us. And I was standing outside the hospital, just taking fresh air and trying to be away from the ER for a few minutes. And he was going back from the hospital, just his backpack. So I said, how is that possible that you guys are all like laughing, talking, and still showing up every day? So he said, look, doctor, we are ready for istishhad, which means shahadat, which means being martyred every day and every night. And the next day is the day as is sort of a new chance to come back. This is one of the medical students. I'll show her another picture at the end. Her name is Sajida. I'm putting a chest tube there, and she's just standing there and seeing it and learning it. And she was basically upset, came to me saying that you have taught to other students and you are not teaching me or my other friends. So that's not right. So I said, okay, next time. And unfortunately, that next time was not too far. The next attack, the next, the big number of the patients just being stormed in the ER, it was happening every day. And we were putting the chest tube, and the other doctor, medical student, just so keen, always so keen to learn. And that's where you feel like sort of when we say, for example, why me? We say why these. Well, I have so much challenges in my life and all that. I always think about them, that what they were going through, and yet always seeking for the excellence, never giving up for the excellence, never giving up for the learning. This is one of their medical schools. I think they have 2 or 3 medical schools. And you can see it was pretty well built and well taken care of. So that was a picture just before the wall. And that is a picture after that. Deliberately, all those institutes have been targeted, attacked, bombarded. You may have seen these pictures definitely before, but that just like sort of giving the perspective how these healthcare workers have been going through, particularly going those places of their teaching and training being attacked, and the hospitals. And that is the hospital. Shifa International Hospital, basically. This is the this was the pride of Palestine, not only pride of Gaza, but pride of the whole Palestine. 700-bed hospital with all the specialties, including pediatric, interventional cardiology, cardiac surgeon, interventional radiology, you name it, everybody, and obviously all Palestinians, and many of them being trained outside Palestine. For example, the ER director where I worked, he got graduated from Ukraine, and then he came back to take care of his community. And similarly here, many specialists, some were from UK trained and other countries, but they were all back there. And then this is the aftermath of it. 3 times this hospital attacked, and directly attacked, surrounded by tanks, while they were taking care of the people upstairs there. They told, like, in one day we did 80 surgeries while tanks were revolving around the hospital, killing people and basically burying them in the mass graves and rolling over with the tanks. This is, we are standing in that Shifa compound. It's a big compound, multiple buildings, and you can see in the background here, sort of like on the left side, this is the director of the hospital. This is their local team, this doctor, orthopedic from England. Here, this is also from US, emergency doctor. She's from US, from pediatrician. But the story which I want to tell you about is this sister, this girl standing on the right side. She's a pharmacist. I think Gazan, her name. So it was this day, I think it is July 18th. We reached there, I think, July 8th. On July 1st, she gets a call. She works for an organization there, Heroic Heart, who have multiple workers there working, doctors, nurses, pharmacists, and other ground staff and volunteers. So she was basically, on July 1st, later I got that whole story. At that time, we were just getting pieces of it. She, I think July 12th or 13th, she was conducting a program which was done for a sort of like a welcome program for us to get introduced with all the team. And she was the one who was the MC of that program. And in the middle of the program, in the middle of the event, she sort of like could not continue and was crying and sat down. And that time we found out her story, part of it. And when she reached, she came us with, and then this is Shifa Hospital. We were in Shodak, so in the middle, this is north. And that is, as I said, around July 18th. Here we came, and she was with us. Later, she disappeared and then came back almost crying. And then we found some more part of the story. So what is the story? And then later, basically, when I came back, I texted her, and then I got the whole story back. That's why and now I'll tell you the whole story now. So basically, on July 1st, she said, I got the call from my father who said that our area has been marked as red zone, which means that we have to evacuate the area. Otherwise, Israelis are coming to bombard it and to basically kill us all. We have to evacuate. We have to, sort of take our belongings and run from here. So come back home quickly, help us back. When she, and you can imagine the transportation situation and all that, after 3-4 hours, when she was getting close to her area and running, a neighbor came across and he said, "Where are you going?" She said, "I'm going to my home." And he said, "What home?" He said, "There is no more home." She said, "Where is my family?" He said, "Go and sit in that hospital, not this one, Al-Ahli Hospital, is another hospital in this area of Gaza, big hospital next to Baptist Church, which was attacked as well." In any case, she was sitting there waiting for the ambulances, one after the other, none of the family members coming. Finally, he came back to her and he said, I cannot hold further. Go to the side of the hospital and find your mother wrapped up in the white sheets. She ran there, obviously found her mother, Shaheed, there. And she says, my whole life sort of shattered in front of me. She cried. She was shocked. You can imagine. But then she said, I thought, okay, my mother is gone. Where is my father? Where are my sisters? And then she started running again to the home. And then she was stopped again. She was told that bombardment is going on. You cannot go there. So this minute when she is standing here with us, still trying to smile and still trying to, taking care of us and all of her people, her father and her sisters are are just under the rubble of her home, which was not too far from here. And when she disappeared, she had come to the director asking him to give her the death certificate of her father and her sisters, which he said, we cannot give until we see the dead bodies. That is what I tell here when I talk with the audience here, that when you hear from the media saying Hamas-controlled Health Ministry of Gaza told that many people killed today, that is how controlled and precise they are, that they will not give death certificate until they see the dead bodies themselves. Finally, it was August 1st, or I think August 10th, she said, yes, after 40 days, that area was cleared by the Zionist killer army. And she was able to go and find her father and sister still under the rubbles. And she was able to bury them. Finally, and she had nobody left from her family, yet she is everything for everybody there and taking care of all around her. That is the resilience. Next, quickly, I know that I think my time is 15 minutes. Next, this story, this is a doctor, again, this was July of 2024. Working in the Ahli hospital, the hospital which I mentioned you, and in the ER again, running around, smiling, taking care of patients. And then she just pointed outside of the window and told me, see that grave, my father is buried there. And then she told her story, which I will just give a very short version, that her father, her uncle, her cousins, they were killed and attacked one after the other in front of their eyes, outside their home, when they were trying to collect or get water from a tank, and the rockets came one after the other, directly attacking them. She was the one who, and then her father was brought inside home, and at that time, he was like still breathing, and she said, he looked at my mother, and my mother said, you are Shaheed. Then they took him to the hospital. She ran after him. Finally, it was a long story. Finally, she reached hospital. Her father was taken by ambulance. And then she said that at that minute, he finally took his last breath. And as I say the verse here, so her father was just waiting for her to come and then pronounce him dead. Yet she is there taking care of everybody every day. This is a church. When I talk here, I show them these pictures that nobody's safe. And that church has been attacked, destroyed, multiple churches. This is just a quick Haaretz news, which is a Israeli newspaper saying that IDF, which is Israeli army name, admits that it has killed 70,000 Palestinians in Gaza. and they admitted that most of them were civilians. So this picture of now she's Dr. Sajida that I showed you in the beginning. I will show this picture again, but let me first show these pictures. So because it is a dermatology conference, I just wanted to show some pictures. So these are, and we were just talking before I think after psych about burns, that kind of the burns we had there. 80%, 90% body burn and chemical burns. They were saying that every new kind of the mum is being tested on us, and you can imagine and you can see what kind of the burns and what kind of the injuries they were having there, and what kind of the treatments could be possibly available, as you can imagine the infection control and all other interventions possible, available or not. There's some other picture. This one. This was a fasciotomy. There was a video also, but due to short of time, I'm not showing that. But fasciotomy is being done and all that. So this is again. I had many pictures, but just sort of like did not want to show all of that. This is a video a few months ago, and again how they got attacked, killed, many others. So it's sort of like, thankfully there is a ceasefire, but still the hunger is there and still the death is there. Talking about her, Dr. Sajda, so she was the 6th-year medical student at that time. They have 6 years of medical school, and I told them that how long is your medical school, and they jokingly said, again, they are laughing on it. They said they just want us to keep studying till we die. So we are studying to die. But what it means is they are living for others and ready to die at any time. This was her picture. You can see that after, like, when she graduated recently, like after the ceasefire. This is the Dr. Mazid, again, as a medical student at that time. He got married a few months ago, and he sent his picture. So this is, I want to conclude, obviously, and here, that how is that possible? Only defending yourself personally, or defending your family, or defending your land can take you to a certain extent, but not to the resilience, the level which we are seeing there. And one thing I would like to quickly add, I'm seeing, mashallah, here a lot of ladies, maybe more than men, that I really feel that in Gaza, they are standing because of their ladies, because of the sisters, how they are standing up firm and brave, taking care of themselves and taking care of their families, despite whatever is going on. But the point which I wanted to make particularly here is that they are living for a mission. They are living for a purpose much higher than themselves, than merely their home, their family, things like that. Because if that is only purpose, there are chances of giving up at some point. But the purpose is Al-Quds Lana. This is the frame in the director's office, and he was the director of the hospital, and these are other, like, their local leadership of the hospital, the other doctors from other places. But this frame is in this office, in many other offices, on the walls, everywhere it is written, Al-Quds Lana, Al-Masjid Al-Aqsa belongs to us. And that is the mission which basically connects all of us. Yes, we have to take care of them because we are one ummah, because we are Muslims, but also they are giving their lives for Masjid Al-Aqsa, and they are not forgetting this purpose and this mission, and we cannot forget that either. Masjid Al-Aqsa belongs to all of us, and I pray, and I told them, I pray that from Shuhada Aqsa Hospital to Masjid Al-Aqsa, soon we will all meet together, and that is what we pray for all of us. Thank you very much.
A sincere thank you to Dr. Bilal Pracha for sharing his profound insights. We appreciate your dedication to highlighting the selfless efforts of healthcare heroes.
Thank you very much. I appreciate that.
Dr. Bilal, I am Professor Tanzila Khalid. Thank
Yes.
you very much. I hope you can hear us.
Yes, yes.
Okay. We really do not have the words to express how we feel for our brothers and sisters in Gaza. May Allah accept their martyrdom, give them more sabr, and give them the ajr azim for whatever they have done so far and they are still facing. And it's a moment for us to reflect on how we have been able to help them. You are so lucky, mashallah, and we are really proud of you for how you went there in those difficult times and how you, I would say, represented us, the rest of the Ummah. However, it should have been much more than that. We should all, I wish we could contribute in some way. Can you guide us how we can still help them? Because most of us are literally clueless of how really we can help them.
Yes, thank you very much, Dr. Khalid, again for having me. And this is a very important question. And before that, quickly, which you said about representing, and that is really true. When I was there, I know a little bit Arabic because I was born in Saudi Arabia. So they will say that, where have you come from? So I will say, Raja min al-Imrika, Asli min al-Pakistan, جاء من أمريكا مولود الطائف أصلي من الباكستان ودمي فلسطيني. What it means is that I have come from the United States. I was born in Taif, Saudi Arabia, but I am originally from Pakistan and my blood is Palestinian. And when I would say that, you could see on their face as soon as the name of Pakistan comes. So really, Pakistan is the hope there. Pakistan is the light of happiness for them, and they really appreciate that. Coming to your question is sort of like, yes, definitely, still they need a lot of help in all regards. For example, this kind of the conference or this kind of the teaching programs are very important as well. And for example, like how the innovative treatment, we can try to get there in. It's still very difficult to get the equipments and all that, but doctors are still going there on regular basis, and we can send some things like this. So number one, yes, whatever medical teaching and training, they really appreciate it. This kind of the online programs, we can plan that through you, dermatology particular, for example. Number two, how we can send any medical equipment or medical sort of things which can help them take care of that. And obviously, yes, also big number of the students came to Pakistan. We still keep working with that if we can get more of their medical students, because as I showed you how the medical schools are destroyed. So those are a few things I will say that we still need to work on, that which we can do all together in coordination. For example, your organization, PIMA, as well as American organizations.
May I add? Yeah, Dr. Bilal, I'm Dr. Nabila. So first of all, huge appreciation, definitely. Because being Muslims, we all believe that it's not between you and people. At the end, it's between you and Allah. So every one of us is individually accountable and answerable at the judgment day. So we all need to play our individual role rather to wait for governments or authorities to take some action. Definitely, collective efforts, especially at the government level, must be in play, and whatever can be should be done. So we congratulate you, and we pray that Allah Almighty give you ajr azim. And yes, the title touched that, yes, we are all Gaza. So in continuity with your answer for the question of Professor Tanzila and for the rest of the hall, I would like to share that you can be contributing. The Al-Khidmat group and the Muslim Medical Mission, they are continuously doing efforts there, physically as well as in terms of the items. And like from the last 1.5 years around, I monthly donate. It's just for the motivation. It's between me and Allah. May Allah accept that whatever I try to do, but for the knowledge of the people that you can contribute. And there are evidences that they are actually doing, because we sometimes become doubtful that the donations are rightly in use or not. So these two associations, organizations are definitely utilizing. Secondly, I'm in a group where we are doing a telemedicine consultation for the Palestinians. Very initially, there were online circulation of those forms for the contribution and your consent to participate in those teleconsultations. And there is a huge portal where we all are active through the emails and WhatsApp. And whenever there is a new patient, they have the color coding, and whosoever is available of the relevant specialty replied first, whoever sees. And this is around now more than a year that I am in that group and is like contributing. So Professor Tanzila is now in contact, and if she would like, I would like suggest her number to the admin of that group, and then the volunteers from this institution of different specialties can give their consent and can be added in that group and that portal, and then have their personal IDs and passwords to access, and they have the system of alert for the new patient. Also, there are lectures which we off and on take and like relevant to my specialty. If similarly, I was when the Afghanistan war was very much, and the medical students, female medical students were stopped to go to medical colleges, then I become the part of that group of online teaching to the Afghan female medical students. But unfortunately, even now that has been stopped from certain. So there are always ways and means. Where there is will, there is way. And plus, we know that Nabi Pak Sallallahu Alaihi Wasallam has told us that innamal amalu bin niyat. So अमाल का दारोमदार नियतों पर है, तो थोड़ी सी अगर नियत करेंगे तो इंशाल्लाह अल्लाह ताला हमें तौफीक देंगे कि हम कहीं ना कहीं अपना थोड़ा सा रोल प्ले कर सकें. Once again, a huge appreciation for you. Thank you.
Thank you,
Thank you,
sir.
Professor Nabila. Thank you, Professor Nabila.
I want to
We would
ask,
definitely contribute towards this, and I will take this opportunity to also share. City of Faisalabad is also some Palestinian students. They are currently studying with us. And we are also partially in touch with their educationists. A delegate of their educationists from Palestine came just a couple of months ago. And I think we are working on some collaboration as well. Thank you so much.
Dr. Bilal, really appreciate your efforts, and may Allah accept all of your efforts and all those who are working there right now. I want to ask, as you have told, there were very meager resources available as food and other. How did you manage to arrange the medical supplies there? Because every day you must be seeing many hundreds of the patients. So what was the means that we can contribute? Are there any channels available so that from here we can contribute for that? Although Professor Nabila has already told few of them, but what is the actual dynamics there in Gaza?
Yes, thank you very much. Basically, I just quickly give you an idea. For example, like first day when we were there and the patients started coming after an attack, and there was one young patient around, I would say 35, 40 years old, and he was alive at that minute, and he was like sort of, he needed chest tube, and he could be saved. Definitely easily saved if we had all the resources. I said, like, I think we should intubate him, but I mean, it was like basically this thing that we have to intubate him right away. But the director of the ER was not that excited about it, and he says, okay, no, let's see, we don't know, maybe he will make it or not. Finally, he said, okay, go ahead, and it was like he was on the floor. He said, don't worry, we do it every day. I said, okay, let me try. Thankfully, I was able to intubate. But the point later, which I understood right away, that they did not have ventilators. So the things which we take like sort of as granted, that intubated, ventilator, no second thought, but they had to ration this basic fundamental kind of the thing, and that's why many patients were dying. Similarly, as simple as, okay, ventilator is a big thing. Even in Pakistan, maybe we don't have that many. As simple as the gowns, the what you call the surgical gowns. So many a times it happened that we had the surgeons with us. We had like thoracic surgeon, neurosurgeon, orthopedic, and there are injuries going on, but they are sitting and feeling so frustrated that we cannot do anything because there are no basic equipments and even not surgical gowns. And that's why many surgeries were delayed, canceled, or whatever the situation. So that was pretty bad situation at that time. I hope it's improved now, but particularly answering your question, I think WHO, working with WHO is very important on official level, on for example, like from hospital level, from your organization level, like from the dermatology Pakistan body level, because WHO is doing wonderful job there. Their coordination is instrumental. Sometimes we don't give credit to these international bodies. UN and WHO, if they literally are putting their lives at risk and taking care of coordinating all this care. So they had big warehouse there, which was getting depleted in front of our eyes and all that. Now things are going very slowly in there, but it seems they are going there. So I will suggest that, for example, as Dr. Nabila mentioned about Khidmat, PIMA, other organizations, through them or directly working with WHO is essential to get the big medical equipments in there.
If any one of the delegates wants to ask the question, they can ask right now.
Assalamualaikum, Dr. Bilal. My
Yes.
name is also Dr. Bilal. So what I wanted to ask you is, after working in these circumstances with these people and seeing what you saw and experiencing what you experienced, how has this affected your own personal spiritual journey? If you would add a few personal comments as well.
Yes, thank you very much. That, as I mentioned in the beginning, basically even before going there, I will say, for example, like, so it's interesting. I tell like, my wife was more eager than me to go there. Like, sort of when it all started, she would say like, when are you going? So I said, you understand what it means. So she said, yes, I understand, and I'm ready for any, God forbid, happens, but we have to do it. Finally, it was March 2024 when first time I was able to go there. But even before going there, so sort of as you know, like when we talk like in the home that some flani ye kaha ya fla ye baat hui, and then we said ourselves that these things don't matter. Kisi ne kya, matlab, there were like sort of her colleagues or somebody like that. So there were some talks going on. That is exactly what I feel like the transformation, that many things which which may seem to us very important, you realize that they have absolutely no importance in our life. And also you understand the value of the relationships and the value of the family, the value of your close ones. So that is the most important thing, that you let go many of the things which seem pretty big to you, and that is what brings you closer to your loved ones around you as well as to Allah.
Thank you, Dr. Bilal, for joining us. Your contribution is truly valued.
Thank you very much. I appreciate it. Thank you very much for having me. And I really congratulate all of you for having such a wonderful sort of like international level conference there. I appreciate that. So,
It's now my pleasure to introduce Dr. Taqir Ahmed Malik, a consultant diabetic foot and wound care surgeon, International Diabetic Foot Center, Islamabad, Pakistan. With over 22 years of experience recognized globally for his expertise, today he will be speaking on unusual approach to heal acute and chronic wounds. Doctor, we are excited to hear your insights.
Bismillahirrahmanirrahim. Assalamu alaikum. Good morning. I am Dr. Malik from Islamabad, Pakistan. We are very thankful to the organizing committee ICDS 2026, who accepted our abstract unusual approaches to heal acute and chronic wounds. Most people have at some stage in their life experienced a wound. For the majority, healing is simple and rapid process. It is not associated with a persistent pain, excessive exudate, odor, or the distress. However, in some patients, healing is complex and prolonged. It is accompanied by major symptoms which adversely affect the quality of life of a patient. Like we can see this patient who underwent thoracotomy, and this patient who post laparotomy having complicated wounds and feces is contaminating the wounds. We as a healthcare providers face the dual challenge to meet patient expectation of the prompt and the trouble-free wound healing, and to recognize and act appropriately for those patients in which wound healing may be prolonged. The concept of wound healing is very complex. All the three phases of wound healing has emerged as a very complex and a very complicated coordinated process to heal wounds. Evolution of wound care. Traditional dressing has been used as a first aid dressing centuries ago, including honey and the herbs. Later on in the 19th century, a concept of advanced wound dressing emerged. Most wound healing and acute and chronic wounds concept were applied in the wound healing. In 20th century, highly advanced dressing, highly advanced concept of wound management came, and it involved tissue engineering, growth factors, antimicrobials, and enzymatic. In order to wound heal, we should understand the concept of most wound healing. In 1962, Dr. George Winter he applied occlusive dressing on part of the wound, and he kept other part of the wound exposed to the air. And he observed that the wound which he occluded with occlusive dressing healed 40% faster than the wound which was exposed. So in order to heal our wound properly, the concept of moisture balance should be there. Our wound should not be overhydrated or should not be dehydrated. Regarding selection of the dressing, it is a very complex process because of many reasons like technological developments, development of the wound specific products, proliferation of the products, contradictory advices from the company, patient preferences, cost and cost effectiveness, clinical evidence, wound etiology, tissue types, level of exudate, and many others. And more than 2,000 products are available in order to heal, in order to help our wounds to heal. You can see that these are the dressing applied on the different kind of wounds, and we believe those wounds are very serious wounds, and small mistake can lead to disaster outcome. Then what should be the ideal dressing which we should use on our patient? And in 1990 and 1985, Dr. Turner he developed concept of ideal dressing. He said that ideal dressing should maintain a moist environment. It should remove excessive exudate and the toxic component. It should allow gaseous exchange. It should provide thermal insulation. It should be impermeable to bacteria. It should be free from particulate and the toxic contaminants. It should allow removal of it should allow removal without causing trauma, and we should select dressing with the most qualities. We can see that these are the dressing according to Dr. Turner. They are filling the full criteria of the ideal dressings. There's many types of the dressing, like traditional dressing including gauzes. We have hydrocolized hydrogels, odor containing dressings like charcoal dressings. We have foams with the silver and without silver. We have transparent film dressing. We have collagens. We have alginates. We have hydrofibers. We have antimicrobial silver dressing. We have alginate hydrofiber with the silver. We have negative pressure wound therapy, honey, biological dressing, and many antimicrobial dressing which are non-chemical dressing. These are all can be used. The other thing we should be familiar with the wound bed preparation and the time concept. The wound bed preparation is a structured approach that should be considered for all wounds that are not progressing to the normal wound healing. Time concept was developed in 2000 by the wound care experts, and it was first presented in 2003 in the European Wound Management Association conference. since then it has been a very popular tool in order to heal wound. In approaching any wound and in order to heal any wound, we should consider this cycle time wound bed preparation care cycle. We should always start with the patient. We should identify wound etiology and we should perform time assessment. We should agree on the goals for the treatment, and we should treat and evaluate time intervention. If our wound has healed, we should go for the prevention, and if it's not healing, then we should start with the patient again until our wound has healed completely. In our study, we use sterile strips, we use negative pressure wound therapy, and we use human amniotic membrane transplantation. We use sterile strips to minimize tension on the wound edges to help gradual approximation and closure of the wound. 17 patients, they were treated successfully. Out of 17, 13 were post fasciotomy lower limb wounds. This was the post-fasciotomy lacular wounds. We used sterile strips on this wound. Wound was contaminated. It was not a clean wound, so it was we were unable to close this wound as a primary intention. So we applied sterile strips to counteract infection and exudate from the wound. We applied this antimicrobial dressing, which was absorbing the exudate and killing the microorganism. This was the second patient, post-traumatic chronic foot wounds. We also applied sterile strips, and the wound was satisfactory healing. This was the post-lipoma excision wound infection. It was a bit challenge for us. So we applied this sterile strips, and on top of it, we applied antimicrobial dressing, and the results were satisfactory. Vacuum assisted closure along with a natural lipid containing antimicrobial non-adhering gauze in abdominal pressure ulcer and diabetic wounds were applied. We treated 23 patients. Out of 23, 11 were diabetic foot and 5 were abdominal wounds, and the 7 were pressure ulcers. This was the patient of diabetic foot. We did debridement of the wound, and we used this lipid containing non-adherent gauze, and then we applied this wax system on this foot. And after first week of application of the wax system, we started to find a lot of granulation tissues. The third material we used was the human amniotic membrane. We use it as a primary wound dressing for a variety of cases. Dressing was changed 1 to 2 times a week using a standard local protocols. So far we have done 75 cases. Out of 75 cases, 45 cases were diabetic foot, 5 were crush injuries, 11 was burns, and 8 were pressure ulcer, and 6 were post-operative cases. This was the case 60 years old who underwent amputation of the big toe. We applied amniotic membrane, as you can see here, and after 1 week, results were we were surprised to see the results. And within 4 to 6 weeks, wound healed completely with minimum scarring. This was a patient, he was around 27 years old, who had road traffic accident with a lacerated wound on his arm. We applied amniotic membrane, as you can see, and within 4 weeks, his wound was less than half of the original wound. And within 7 to 8 weeks, his wound completely healed with good scarring. Treating any wound, it needs a multidisciplinary approach. We need a lot of specialties in treating our wounds. Without multidisciplinary approach, our wounds cannot be treated properly. In doing so, most of the time we are wasting our resources and our patient get harms instead of getting benefits. And finally, sometimes the best treatment wears a uniform and a smile, and it is our humble duty to respect our patient and give a smile and treat our patients with respect. Thank you very much.
Insights. If anyone has any question or observations, you are welcome to share them now. Thank you so much, sir, for joining us. Okay.
Can you hear me?
Dr. Toki, can you confirm your audio?
Yes, yes, ma'am. I'm listening. Yeah. Can you hear me?
Yes, doctor, we can hear you, but can you hear our chair of this session?
No, 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 ma'am.
Am I audible now?
Yes, yes, ma'am.
Yeah, thank you. Thank you, Dr. Toki. First of all, a lot of efforts we are witnessing in your patient care management. And I think with keeping the comorbid factors of majority patients like diabetic and there are very encouraging results. My one concern is that in long-term follow-up, in terms of cosmetology or aesthetics, definitely in old age, that may not be the first priority, but in younger age group, that is definitely a concern. So what about their long-term aesthetic outlook of the wounds managed by these remedies?
If you think about amniotic membrane, what we found, it has amazing results. The scar quality is good. It's as near as to the normal skin. We have a lot of cases. We had no time to share with you all those results. Despite that, I sent. Abstract about the amniotic membrane alone, but it was not accepted. So, what is our experience since 2008 when I was in Saudi Arabia? I am using this amniotic membrane, and we have presented in international conferences. What we found, it has a very amazing results, and it facilitates epithelialization. It maintains normal epithelial phenotype. It infection and rejection of the grafts are very rare. It reduces scarring. It reduces tissue adhesion. It reduces exudate. It is a widely available thing, and which we can use on our patient. What we did, we tried on many patients. We applied on bones. It covered the bone. We applied on the tendon. It covered the tendon. Overall, the scar quality was very good, very excellent. If you talk about the strips, of course, the scar quality was not as good as it should be with the skin graft or with the amniotic membrane, but it was showing good results. Regarding vac-assisted vacuum therapy, it depends on the wounds and the quality of the wound. But overall, the foot, we don't care about the aesthetic issue, but rest of the body, the scar was good.
Thank you so much, doctor.
Thank you very much.
I have a question. Very nice presentation of the techniques used for the management of diabetic chronic wounds. In one of the techniques you used is by giving the wound approximation through strips. So basically, in that case, the wound is being healed by secondary intention. Do you have any control data by how much magnitude did this enhance the secondary closure?
Actually, we didn't do any study. We were just did trial on some patients because basically we did in Saudi Arabia when I was there. So those patients which were unable to close and they were in hurry to heal their wounds, so we are applying this strips. On top of it, we are applying some antimicrobial dressing to heal and to approximate our wound gradually. The first case which I showed you, it was a post fasciotomy in the leg, and it was very difficult to be closed. So we started trial of this strip. Gradually, we are applying strips along with the antimicrobial dressing, and within a few weeks, wound get approximated, and later on we did secondary suturing on that wound. So we found the stethoscopes can be used on most of our patients. If the wound is, for example, we have a wound on the abdominal wound post appendectomy, and we cannot be closed. It cannot be closed. Then in that case, we can use the stethoscopes gradually. Using stethoscopes, what I believe. Wound is not fully closed, and any exudate which is coming, it is coming outside the wound, and later on the wound can get approximated. So basically, we didn't do any trial, we didn't do any control data, but it was just our personal efforts to heal our wounds. Yes, sir.
Thank you so much, doctor, for joining us.
Thank you very much, ma'am.
Now, it is my pleasure to introduce our next speaker, Dr. Suryani Behroun, Senior Lecturer in Reproductive Health at Universitas Magraske, Indonesia, specializing in maternity nursing and reproductive health. She holds a nursing bachelor, master's in biomedical sciences, and PhD in medicine. Her work focuses on maternal health, complementary therapies, and public health issues, including COVID-19. She conducts research and community programs on reproductive health, vaccination, and health education. Her topic for today is postpartum women's experience with ginger-based herbal therapy for perineal wound care, a narrative approach in service of Ketang Community Health Center. Doctor, we are honored to have you with us.
Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Suryani Bahrun. I am from Megareski University, Indonesia. Postpartum women's experience with ginger-based herbal therapy for perineal wound care, a narrative approach in the service area of the Ketang Community Health Centers, East Nusa Tenggara. Introduction and background. Critical nature of postpartum recovery. The postpartum period marks a vital recovery phase for women involving psychological and social adaptation after childbirth. Complications like perineal wounds affect 35 until 85% of vaginal deliveries, leading to pain, infection, and delayed healing. Therefore, effective interventions are essential to enhance maternal quality of life. Prevalence of perineal wounds in Indonesia. In developing countries like Indonesia, perineal wounds from spontaneous tests of episiotomies remain high, contributing to maternal morbidity. Factors such as nutrition, hygiene, and knowledge significantly influence healing rates, with complications occurring in up to 25% of cases if unmanaged. It underscores the need for accessible, culturally aligned therapy. Rise of complementary herbal therapy. Recent studies highlight complementary therapy, including herbals as safe alternative acceleration, wound healing, and reducing pain. Ginger stands out due to anti-inflammatory and antibacterial properties from compounds like 6-gingerol. By integrating this, healthcare can become more holistic. Postpartum period challenge. Critical nature of postpartum recovery. Perineal wounds affect 35 until 85% of vaginal deliveries, leading to pain, infections, and delays in healing. 25% of perineal wounds result in complications in developing areas, with nutrition, hygiene, and knowledge influencing healing. Rise of complementary herbal therapy. Ginger-based herbal therapies, now for 6-gingerol, help reduce pain and speed up healing. Research gap and novelty. Limitation of prior quantitative studies. Most previous research focused on clinical efficacy via quantitative methods, overlooking subjective experience, culture influences, and psychological aspects of ginger therapy use. This leaves a gap in understanding real-world postpartum narrative. Thus, a narrative approach will destroy. This study innovative by combining evidence-based phytotherapy with local Indonesian traditional practice through a narrative lens, exploring by socioculture dimension. It provides comprehensive insight absent in prior works. Problem statement and objective. Core research question. How do postpartum women experience perineal wound care using ginger-based herbal therapy? This question drives the exploration of physical, psychological and culture impacts. Specific objective breakdown. Objectives include identifying psychological benefits like pain reduction, exploring psychological effects such as comfort, and analyzing cultural influences on the therapy adoption that align with a holistic review, ensuring a target insight for decision makers. Literature review. Postpartum and perineal wound dynamics. Phase of wound healing process. Wound healing comprise inflammation, proliferation, and remodeling phase lasting 6 until 40 days postpartum. Delays from poor nutrition or infection hinder recovery, emphasizing timely intervention. Ginger modulate inflammation via 6-gingerol, promoting faster epithelialization. Risk factor and complication. Key factors include nutritional status, hygiene, maternal knowledge, and activity levels. Studies show mothers health 13 until 16% faster, while complications like infection rise without proper care. Therefore, education is pivotal. Pharmacological benefit of ginger. Ginger contains gingerol, shogao, and zingerol, offering anti-inflammatory, analgesic, antibacterial, and antioxidant effect. This reduces mediator like cytokine, accelerating tissue regeneration in episiotomy wounds. Clinical trial confirm pain reducing by 14% in user. Evidence from clinical studies. Trial demonstrate ginger extract lower pain, intensity, and speed healing compared to standard care. Systematic review. Systematic reviews endorse it as complement save for culture content. This builds a strong evidence base for adoption. Narrative approach in qualitative research. Strength of narrative methodology. Narrative methods capture subjective stories, revealing emotional, cultural, and contextual meaning. Either for health experience, they integrate chronology events with personal interpretations. Thus, they provide deeper patient-centered insight. Research methodology, study design and rationale. Qualitative narrative approach. This study employs a qualitative narrative design rooted in constructivism, focusing on participant stories, use care experience. It excels in holistic capture of physical and psychosocial elements, surpassing surpassing quantity limits. Data collection technique. In-depth interviews, observations, and data source organized by restoring for a thematic. This ensures the contextual narrative. Participants and setting. Inclusion-exclusion criteria. 6 postpartum.
Thank you so much, ma'am. As we are exceeding our time limit, we will move toward our next session. It is my pleasure to introduce our next speaker, Professor Dr. Saira Salim. She is a leading breast surgeon in Faisalabad and head of Department of Breast Surgery at Medina Teaching Hospital, Faisalabad. That is the first breast surgery unit to be established in Faisalabad. She also serves as a professor of surgery at University of Medical and Dental College, Faisalabad, where she guides the next generation of surgeons. She has extensive experience in breast cancer surgery and is recognized internationally as a regional counselor for the Royal College of Physicians and Surgeons, Glasgow. Today we are excited to hear Professor Dr. Saya Salim on topic Advances in Scar Prevention and Cosmetic Restoration, Role of Surgical Planning and Technical Considerations. With a huge round of applause, please welcome Dr. Saya Salim on stage.
Bismillahirrahmanirrahim. And good morning, everyone. And I would like to extend my sincere gratitude to the organizers, especially Dr. Tanzila Khalid, for organizing such insightful conference and bringing together physicians, surgeons, medical educationists, nanotechnologists on one forum to discuss this crucial subject. And today I'm here to talk about advances in scar prevention. And can you share the first slide, please? And what's the role of technological considerations and surgical planning in scar prevention? So what most of the clinicians do when a patient come to a clinician with a bad scar, usually they advise creams or ointments, but many miracle scar creams lack solid randomized controlled evidence to support their marketing claims and confuses and misleads the patients. So what the clinician should do when the clinician tries to explore the evidence, there is a tsunami of basic science text amount to an indigestible intellectual burden for the busy clinician. So I have tried to extract some basic principles how we can prevent bad scars. So what are the principles of wound care and scar prevention? The slide share, please. So the first principle is management of scar is intimately connected to stages of wound healing. I will share different stages where we can do an intervention to prevent a bad scar. Then the management begins with the thorough informed consent process. Then in scar prevention, the single most important factor is the wound tension and an incision focused on minimizing tension along the natural skin lines. Then post-operative visits count has great weightage to screen for the signs of scar hypertrophy. Then early intervention is key to control hyperplastic response. And finally, we should learn innovations to move towards the scarless surgery. So what's the pathogenesis behind the adverse scars? Either we've encountered bad scars because of delayed healing that is observed in conditions such as diabetes, post-chemotherapy, or radiotherapy patients, as shown in the picture. Then excessive healing. We find hypertrophic and keloid scars that are characterized by abnormal accumulation of extracellular matrix, altered local vascularization, and increased cellular proliferation like fibroblasts lead to bad scarring. As shown in the picture, the hypertrophic scar and then the keloid scar that outgrows the original wound margins. So the first principle is that we should know the various stages of wound healing where we should interfere. So different stages are, it starts with hemostasis, then stage of inflammation, then stage of proliferation comes, and then remodeling. So where a surgeon should interfere? These step 3 and step 4, stage of proliferation and remodeling phase, the scar prevention focuses on modulating the wound healing during the crucial stages of proliferation and remodeling at first or second weeks post surgery to prevent excessive collagen deposition. The second principle is informed consent. How many of the surgeons inform the patient about the bad scar? Usually our focus is on some early complications like bleeding or infection, but very few surgeons tell the patient about how the scar can be prevented. So the management of an elective surgery patient begins with a thorough informed consent process in which the patient is made aware of scar-related complications and personal and clinical circumstances that may be modifiable and non-modifiable, such as patient should be informed that genetics play a great role. Some patients have a natural tendency to develop a bad scar while the others don't have. Then skin tone, as darker skin people are more prone to develop thick or bad scars. Then proper aftercare is needed. Once the wound is healed, the patient should do regular follow-ups so that the bad scars are assessed and timely intervention can be done. Then sun protection is crucial as UV light can cause pigmentation. So all these things should be explained to the patient before surgery is done. Then technical considerations, preventing a suboptimal scar is much easier than managing a bad scar, we all know. So what technical considerations are important? As a surgeon, we should know which small steps can make big changes. So incision design, treatment of scar begins before suturing the wound. Proper care in creating the incision design and a tension-free closure is very important. As shown in this picture, Because I'm a breast surgeon, I would like to share this example of the second picture. You can see a patient has a breast cancer in the upper outer quadrant of the breast, and four options are mentioned. And option 1 at the inframammary fold, option 2 at the areolar edge, option 3 on the lateral crease of the breast extending to areola, and option 4 on the axillary skin. So in this particular case, the best option will be option 3 to give, so that if we design an incision on the outer and lateral crease of the breast, this will ultimately we will get a scarless or hidden scar as a final outcome. So regarding the incision design, we should consider the relaxed tension lines. There are natural skin lines. So we should design the incision parallel to these Langer skin lines. So again, regarding suturing technique is very important. How we handle the tissues, how we apply the sutures. So we should opt an atraumatic technique. Usually the surgeons, some surgeons put Alice forceps that cause bad scarring, do excessive tension, stretching. So these practices should be forbidden at the very initial years of learning, the foundation year training, how to handle the tissues. A tensionless closure is very important. Prevents strangulation while approximating the tissues and applying the sutures. There should not be strangulation and too much tight closure of the wound edges. Then proper skin edge eversion is important. It should not be like that skin edges should go inward. This will give bad scar. Then alignment of skin edges is very important. It should not be like one edge go down, one edge goes up. It should be a proper alignment. Then restoration of anatomical landmarks, as shown in the picture. When surgery is done around the areola, reconstruction of the natural areolar outline is very important. Then dog ear correction is very important. Otherwise, having dog ears causes seroma formation and an ugly scar. Here I would like to share a picture of some of my patients. This was a young 35 years old lady having a 4 into 4 centimeter breast cancer at upper inner quadrant, and it was approached by oncoplastic breast surgery, and the incision that was designed for this patient was around the areola, a crescent shaped incision, and the final scar you can see, it was like a scarless surgery. Another patient in which the cancerous lump was at near the inframammary fold, a wide local excision was done, then a flap was reconstructed from under the breast, and you can see the final outcome. There is a scar along the natural skin line, and the final outcome was a hidden scar. It was not visible. So postoperative visits are very important to screen an adverse scar at an early stage. So the postoperative visit should screen for signs of scar hypertrophy and has a dual purpose of continued patient education and reinforcement of proper care. The management of a surgical incision doesn't end when the sutures are removed, as most of the patients and some surgeons think that now sutures are removed, now their work ends. No, still you have to guide the patient about the post-operative follow-up visit so that you can detect if an adverse scar is forming, you can do an early intervention to prevent that. So if you will not adopt proper precautions, it will end up like this, an adverse scar. So what are these early interventions? So we can adopt a number of options like silicone therapy, silicone gel or sheets are widely considered first-line treatment to flatten and soften the scar. Massage, regular gentle massage with moisturizer keeps the scar supple. Then steroid injections we can inject an intralesional corticosteroid injection, sometimes on monthly basis, so as to reduce the scar thickness, redness, and itching. Then pressure therapy using special garments can also help to reduce the scar volume. Then laser treatment, either pulse dye or fractional lasers can improve the texture and color of the scar. And patient is advised to have protection from sun that should be used to prevent hyperpigmentation until the scar is fully mature, around 2 years. So I would like to share an algorithm. If a suboptimal or bad scar is found, then and it is surgeon detects that an inappropriate technique is utilized, yes, then surgical scar revision should be done. However, if it looks that it's not an inappropriate technique that is used, then look at the time of patient presentation. If patient presented in less than 6 weeks, then you can use adjunctive therapies like silicone, pressure garment, or intralesion steroids. If patient presents in 6 weeks to 6 months period, then you can use these adjunctive therapies or dermabrasion or laser. Then, if patient presents late in 6 months to 1 year, do a clinical assessment, and if the scar is still immature, then you can use laser therapy or adjunctive therapies like intralesional steroids. But if it is a mature scar, then different surgical scar revision procedures like Z-plasty or other plastic surgical procedures can be done. So to summarize, scar prevention, early intervention options in immediate period in 0 to 2 weeks, tension-free closure techniques, proper suturing, and botulinum toxin injection that usually our dermatologists use to prevent the wrinkles. It can also be used for scar prevention. And then early intervention in 2 to 8 weeks, silicone gel sheets or pressure garments or pulse dye laser therapy. Then if the patient presents late, after 3 months, then fractional laser, microneedling or corticosteroid injections can help to reduce a bad scar. So as Dr. Mahmood has told that we must learn innovations. So although he has very well elaborated different regenerative processes in wound healing, so I will not go into detail of these regenerative procedures, but the higher level of cytokines like TGF-beta and proteases, low secretion of growth factors, overproduction of reactive oxygen species, and matrix metalloproteinases, suppressed angiogenesis. All these factors promote fibrosis and extracellular matrix destruction. So regarding regenerative wound healing, we look towards getting a scarless wound, and to enhance wound healing, there are different chemical and physical strategies that can be applied to accelerate the recovery. I think much has been told by Dr. Mahmood earlier. So the take-home message of my today's talk is advances in scar prevention have shifted from passive post-operative management to an active and individualized care aimed at minimizing collagen overexpression. Then preventive strategies begin before incision is planned. Then integration of technical considerations during surgery, and then focusing on modulating wound healing during proliferation and remodeling phases to prevent excessive fibroblast activity, collagen deposition, and inflammation, and finally, early intervention. Then technological considerations include aseptic and clean environment, absence of tension, that is incision design along the relaxed tension lines, accurate approximation, and a traumatic technique for closure. Thank you very much. Thanks for your attention. If there's any question, I welcome.
Dr. Saira, thank you for the very informative talk. But I like to just comment, no questions, that we have listened and you have mentioned about the different techniques. So at the same time, we need to stress the importance of the multidisciplinary team. And we need to tell our youngsters that involvement of the different specialty at very early stage will definitely change the outcome, like presence of a plastic surgical colleague, the same time when you know that you are going for a wide excision and you are need to develop some flaps and similarly. So I think in this era, multidisciplinary team approach need to be highlighted and stressed.
It's very rightly said. An integrated approach is very important. I think one slide that I skipped, the multidisciplinary team plan was mentioned in that. So that is very important. Thank you.
Thank you, Professor Doctor, for your valuable insights. At this point, I'd like to invite Professor Dr. Nabila Talat, renowned pediatric surgeon, medical educationist, and healthcare administrator, to share her expertise on where the pathways turn different, surgical management of wounds in children. Please join us to share your knowledge.
Bismillahirrahmanirrahim. Assalamu alaikum and good morning. थोड़ी सी late good morning. Or first of all, I would like to congratulate actually the organizers and especially Professor Tanzila Khalid. I'm so glad to see so many of the audience in the hall. And mashallah, most are women because definitely it's a women-only institution. So being the advocate of women equity and women empowerment, I'm so glad. So congratulations. Because just to share that I'm the founding vice president of Medical Women Association of Pakistan. Plus, I am officially the representative of Women in Global Health and International Organization as their Speakers Bureau. Secondly, I'm very thankful, rather humbled to be called here and given this opportunity, though a little short notice, but it's my honor to be here. And since I see that the people are sitting since 8, I think, may I request all to stand for a half minute and stretch a bit. Stand on your toes. Yes. Because I think we all know, and I'm extremely, extremely grateful that my teacher, my mentor, my General Surgical Supervisor, Professor Abdul Majid Chaudhary Sahab here, and we all know the incidence of varicosities. So continuously sitting without involvement of your calf pumps. So one more time the stretch and we can please sit down. Yeah. I'm very thankful and rather apology that I made, but I think this is very necessary. So by the time I think many know me, I'm Dr. Nabila Talat. And as I have shown my institution, I'm from the Children's Hospital, University of Child Health Sciences, Lahore. Currently heading the Department of Pediatric Surgery as well as I'm Dean Faculty of Surgery. We take pride, a little bit of introduction, because we are the second largest on the globe and largest in Asia, the 1,400 bedded hospital with 43 specialties of pediatrics under one roof. So you name any specialty of adult and we have in pediatrics, and we are having the level 3 training and 11 level 4 specialties we are offering the training, the super and subspecialties. So we are trying our hard to contribute our bit. So my job has been already made easy. And I think my talk will be quick and will be just a recap of many previous talks. But I was given the assignment by Professor Tanzila for pediatric wound management. Most of it is theoretical, available in literature. I tried to sum up. I'll share the presentation as well for the sake of the students if they consider it to be of some value. Otherwise, the young generation is more tech savvy and can have access than us. So we always start that children are not small adults. And this is true in every aspect. And coming to the wound management is again true that they have multiple special issues with their skin and with their wound healing. And we will see in the next few minutes that how. So first of all, they have increased injury risk and increased chances of hypothermia if they face any challenge. And plus, because of their growing nature, their sensitivity, they have a lot of tendency for huge psychological impact. So I tried to sum up the anatomical differences. You can see that how they differ from the adult skin. The pointer is not working, but I hope that the slides are visible till the last row. And we can see that they have the less dense dermis and immature and sparse fibers. ये नहीं काम कर उस पे नहीं शो होगा अच्छा चलिए okay. So just consider this limitation that the pointer won't work. So try to be with me where I am talking about the words so on the written. So we identify that the pediatric skin has its own peculiar differences in terms of anatomy. And then we see that there are physiological differences as well. And we will see that recently the speakers before me have touched upon different areas which I now will touch for the pediatric population, that how they have their pros and cons of this skin. At one side, they have the faster healing, but this is two-edged sword, I'll just discuss, and then the reduced barrier function and the greater susceptibility of infection. So with this background, coming to the wounds, the journal wounds, and then we will see that pediatric population also faces all these challenges of these different categories of wounds. They can be open and closed. Then we talk about the acute and chronic. And acute and chronic wounds has been touched by one speaker. And then clean versus contaminated. And in our setup, especially in public sector, as we all understand and identify that our hand hygiene practices, disinfection, sterilization practices as per protocols are not that up to mark. So we face a lot of challenge. So surgical wounds range from day-to-day injury to the burns to gunshot, and then a lot many. So the pediatric population also is victim of all of these types of wounds. So as per anatomical and physiological differences, we see that the faster healing response is a two-edged sword. On one side, it is a blessing, but on the other side, sometimes it creates problem of the hypergranulation, the unchecked response of the proliferative phase, which Dr. Saira also mentioned, and few other speakers have shown as well. And this all many a times lead to increased risk of hypertrophic scar. The pathway initially is same of the 4 phases of hemostasis, inflammation, proliferation, and remodeling. So I summed up because this is important to understand that many a times pediatric population develop this exaggerated unchecked proliferative response. So what it will do that on one side, I have shown the normal proliferative phase and in the upper left corner, and on right side, when overactive tissue response comes, excessive granulation tissue happens, which excess collagen production is the result and which leads to either hypergranulation or hypertrophy or the keloids. And this has own clinical and management impact. So sometimes these kind of hypertrophic. So again, spectrum of pediatric wounds covers and touches all these. And important is the congenital lesions. By birth, few patients born with the wounds or the lesions which need cover or the treatment, the birth defects. So in one of the presentation, the time concept for the wound management or the healing was touched. And in pediatrics, it's again adapted. And I'll also touch upon the ladder of the pediatric wound management, which is generally also adopted in adults, that initially you always try to do the minimum, to intervene minimum. But if you say, because the pediatric population is very prone and susceptible to infection, so you see that if it happens, then you need to intervene, and on regular basis, again, you need to assess the wound margins and the edge assessment to proceed with the offered therapy or to intervene surgically. So core surgical principles are these four, and we generally try to stick as per the patient's condition and patient's wound condition guide. So as I have mentioned that in generally we follow those principles, but especially in unusual wounds like burns, because pediatric population is too much susceptible. We receive a lot of burn patients. And as I have mentioned earlier, that we all need to work on the preventive side. We are spending a lot on the management therapy, but I think there is a huge vacuum on the preventive side. So we need to also work on that, creating awareness. And we see a lot of patients who are preventable, but they got. And then the congenital lesions. So sometimes early excision and grafting helps. And then the picture is showing the concept of stem cell use and the new tissue re-engineering, tissue engineering. And the larger wounds can be taken help of these technologies, as Dr. Saira was mentioning, the innovation. So these techniques has to be incorporated. And another area is tissue expansion, the concept of tissue expander. Again, our plastic surgical colleagues come in to help, and the placement of expanders and gradually increasing their size, getting the stretched skin overlying, and then using that stretched and large skin either by rotation or by moving to the another place. And then there was also many of the speakers, even including Dr. Saira and other speakers, touched for the recent dressings. And I'll quickly go through that. Silicone-based dressings are very much in vogue, and they have their proven efficacy in the literature because they avoid dermal stripping. Otherwise, the routine dressing, every time you change the dressing, the thin epidermis started coming, many a times it peeled off, and you go back to the point zero. So these dressings are good in a sense, and plus they many a times can be left for multiple days. So silicone wound contact layers and tapes, these are for very superficial wounds or very initial wound management. These are like this, transparent, but with the adhesive film, which is non-adherent, cannot like damage to the growing epithelium or epithelialization, and can be kept in place. And then the silicone foam dressings, these are thicker, and these have an additional property of absorbing the exudate or the fluid. These are of these types. And then recently, again, the scar management was just discussed, and there are now different dressings available which helps in keeping the scar minimum or reducing the scar. And these are in the form of different tapes or sheets, along with many other dressing materials. And in another area, which we at the moment, even at Children's Hospital Lahore, and I know the surgical floor across the world is now using, is the negative wound management therapy. And in this, the controlled subatmospheric pressure help in shrinking of the wound, help in minimizing the infection, as well as it keeps on sucking the exudate, as well as it maintains the moisture balance. So this is the setup of the negative pressure wound therapy. And this is very effective. And even the larger wounds, if cannot be closed totally, but they get reduced in the size and help you in managing by the surgical intervention. So this is the comparative outcome of your conventional therapies and the negative pressure, that the faster healing with reduced bacterial load and so on. And in the pediatric patient, these are very effective because many a days you don't change it and the patient remains comfortable. So these are different clinical applications and precautions to use these therapies. And in the interest of time, I'm not going into detail of individually, but they are all applicable. So coming to the reconstructive ladder, the stepwise approach for wound management, the small wounds can be left to the nature. You yourself has experienced that sometimes if you get an abrasion while working or get a blister while cooking by steam, immediately you feel pain and you apply something and then you just forget and it gets healing on itself. So secondary intention can be left. But if it's deeper or larger, then the primary closure, the best method, because edge-to-edge approximation will reveal the best scar. And if not, then the options I have just touched upon, the skin grafts and the flaps and the help of all these types of the different dressings. So with all this, I would like to stress that the pediatric patients are very sensitive and their patients are accompanied by the parents. So the parents also face a lot of emotional and psychological trauma. So the foundation is overall psychosocial care along with your clinical management. Do provide good analgesia, appropriate medicines, but focus also to provide the psychological and emotional support to the patient and the parents as well. Thank you so much. I would be happy to answer any questions. I keep it basic and minimal because I know that everyone will talk about the very advanced. So I hope that will serve the purpose. Any questions?
Very insightful lecture. And Professor Nabila Talal is my mentor, and we have worked together for more than a decade at Children's Hospital Lahore before I moved to Faisalabad. And we together have many research projects on wound management as well. And I would like to ask her to briefly describe the management of complex perennial injuries, especially few of them are from the child abuse cases.
Thank you so much. I'm actually, again, humbled and overwhelmed. Dr. Bilal is one of the strength of the team. Still, we consider him as part of the Children's Hospital Lahore, though he moved to Children's Hospital Faisalabad. The traumatic perennial injuries, especially because I'm the chair of Hospital Child Protection Unit as well. Though the time is short, but just to share background that way back in 99, 2000, when I started as the pediatric surgeon career myself, so being the few females, that time it was not very common females to opt for the surgery, especially the pediatric surgery. We were on fingertips. One of very good friend and Professor Abdul Majid Chaudhry's resident, now mashallah, consultant Dr. Aruj and me were like few of the female residents and then become consultants. So at that time and even now, I think there is no change. And we face every single day the abused children, especially the girls, physical abuse, especially the sexually abused children. And it's very painful. And I have in my memory multiple of cases with grade 5 even perineal injuries. And I still remember one 6 months old baby girl from Gujranwala sexually abused by a neighbor teenager boys with the grade 5 open book like perineum till abdomen. When I started doing this, there was a concept of diversion that stoma used to be made and the dressings for the perineum. But then I took it as a challenge and I started primary repair, primary reconstructive surgery of the perineal wounds. And Alhamdulillah, the article is under publication that we have dealt with a very good outcome in terms of function as well as in terms of aesthetics. So I think more and more girls need to opt for the surgery. More and more girls like Saira has opted for breast. I think dedicated colorectal and perineal female surgeons should be coming up. And these sort of cases, uh, fingers crossed, may Allah give us sanity that these cases should be minimum. But so far, we see a lot of number of these cases. The gaining and attaining the skill plus the compassion and empathy for these patients is very much important. And the youngsters are sitting. So I see that many may, inshallah, opt for the surgery in these areas. And secondly, I would like here to mention in terms of wound aesthetics and management, our article has published in international journal. Trainee of ours, especially Dr. Bilal, supervised that study. Sometimes we made a lot of stomas in pediatric population because of many congenital anomalies. And the stoma site is generally considered as infective. So their wounds are very prone to infection. And generally long linear scars at the time of stoma reversal are made. So this study is about the purse string suture closure. And internationally, it has been made into infographic and shared across the globe as well. Dr. Asad Mir has done this under our supervision. And I would request everyone to go through that study. The ultimate scar is very nice because with purse string closure, you don't attain 100% closure. There is a center gap from which the exudate comes out for few days and then it shrink on naturally and the ultimate scar is. Thank you. Any other question? Oh, thank you.
Thank you, Professor Dr. Nabila, for your thought-provoking insights. Next, I'm honored to introduce Mr. Usman Ahmed, the Rescue Safety Officer heading Rescue 1122 Faisalabad District. Today, we are excited to hear his perspectives on assessment and management of wound in Rescue 1122 emergency care. Mr. Usman, the stage is yours.
Thank you very much. And thank you very much, organizer of the University of Faisalabad, especially ma'am, Professor Dr. Tanzila, to invite Rescue 1122. And we talk here, what is the introduction of Rescue 1122 and what is the role of our wound management of Rescue 1122 start performing. And my name is Usman Ahmed, Rescue and Safety Officer as a head City Tehsil in charge Rescue 1122 Faisalabad. And Rescue 1122 did lot of daily emergencies, which is especially after dealing and shifted to hospital, which is adversible effects if it did not deal well. Please next. The main objective, we will discuss the types of wounds, effective bleeding control techniques. Okay. Prevent infection during patient handling and transport, select appropriate wound dressings, and Rescue 1122 pre-hospital and wound management protocols. Rescue 1122 started their work since 2004. It started their work from ambulance, in just 12 ambulances in Lahore, and it move to next 5 major districts from Islamabad, Rawalpindi, Multan, Lahore, and Gujranwala, and 5th is the Lahore. And it expanded in all provinces now, and especially Punjab province. We worked all districts, tehsils, and now move on towns. But if I'm talking about district Faisalabad, the Faisalabad district started their work in 2017, 24/7 rapid response. You just call 1122, and free calls, rescue 1122 will move to incident sites and provide special care regarding pre-hospital treatment to save crucial injuries and crucial lives. So rescue 1122 move fire rescue services, road traffic accident response, which is the agenda to the talk, in which we face lot of more than 300 daily cases in district Faisalabad in road traffic accidents where public did not follow the rules and regulations and come to many injuries. Rescue 1122 worked in disaster response and management support. Now are working community emergency awareness and safety trainings. Daily basis, Rescue 1122 worked in different colleges, schools, universities, and urban and rural area to train the workers and public to respond the first aid. And now working urban search and rescue operations. And there are more projects launched from Rescue 112 patient transport system, in which we shifted patient from one hospital to other, from one district to other. And now the disease care service started since last month from Rawalpindi and Lahore, and next month will be started in Faisalabad. And air ambulance service also started from northern to a far away distance to move a good hospitals. This is the statistics data from district Faisalabad. The total emergency call received 17345,406, in which emergency call received 14,35,067. Road traffic crashes accidents from 2007 to 2026, 4,28,228 calls received and responded. Rescue 1122 and shifted to patient hospital. Fire incidents, average response time meant international standards 7-minute average response times, but ambulance, motorbike ambulance services also started from Faisalabad and different districts of the Punjab, where response time just 4 minutes attained. Total patient rescued and hospitalized 1459629. Patient revived after CPR and automated external defibrillator through automated external defibrillator 96. And estimated property saved in fire cases 78,179.16 million through fire cases. What is the goal of wound management? The process of preventing and treating skin and tissue injuries. The Rescue 1122 goal for wound management, that is the control bleeding, prevent infection, promote healing, and minimize complications, and if it required to move, shift the patient into hospital, then safely and move to hospital. The different types of wounds which daily basis Rescue 1122 face to different patients, that is abrasion, incision, laceration, puncture, avulsion, and crush injury. Open wound in which skin broken, closed wounds, skin intact, but risk wounds that Rescue 1122 faced in daily basis, that is the infections, internal bleedings, and shocks. Acute and chronic wounds also found. The responder roles is early identifications and proper care and timely refer. If they refer to the hospital, then move to hospital. Complications of wounds faced, that is severe hemorrhage, infection, tetanus, maybe disability, delayed healing, and hypovolemic shock. Infection prevention and control, that is the redness, swelling, plus, and sometimes in some cases in fever. The preventions, Rescue 1122 deal with it is sterile dressing, avoid contaminations, hand hygiene and use of gloves and masks to save yourself. proper disposal of waste and sterile equipment. Bleeding control technique that use rescue 1122, that is the direct pressure. You just apply the direct pressures to control bleeding and elevate from your heart to elevate or low down the pressure of the blood, and use the pressure points and tourniquet applications. Signs and treatment of if I found the patients of shock, the pre-hospital treatment of rescue 1122 deal rapid and shallow breathing. These are the signs: capillary refill of greater than 2 seconds, failure to follow simple commands such as squeeze my hand, change in skin color. These all are the signs which found from the shock patients. Use of a traumatic amputation or arterial bleeding, then we use tourniquet 5 to 7 centimeter above to the wound to control bleeding. First of all, rescue 1122 responded to emergencies area. Then firstly, staff ensure safety, yourself and patients and staff. Then stabilize the patients. Then prevent contaminations and treat shock if found the signs and symptoms of the shock. Then patient deal the signs shock treatment. Then record and treatment location responded due to the medical legal certificate which needs to doctors and other legally our departments. Follow standard operating procedures and monitor vital signs throughout to shifting the hospital. Communicate with the hospital, and then after reach to the hospital, all scenes and which data collected and informed to doctors about patients, and then ensure the patient comfort throughout shifting. First of all, when we responded rescue 1122, it dealt and assessed the D or CABD danger. They check danger from patient, for public, for rescue 1122 staff, and then response to the patient, which collect from response from the patient, which type need to pre-hospital treatment. Then the circulations, then circulation is ensured because circulation is more important in bleeding control. If it required very little time for patient to save their life, then breathing and defibrillation is the next step. If we are talking to the wound care, then the personal protective equipment, PPE, will be used for responders, rescue 1122 staff, in which they PPE wear and protect yourself. Then bleeding control, they will use the gloves, mask, and clean wound, apply dressing, immobilize, and monitor circulation to shifting the patients. The summary and keys take where they assess and act quickly, control bleeding effectively, prevent infections, and follow rescue 1122 protocols and document all care provided. Thank you very much. If anybody have any questions, please.
Not question, just comment, rather compliment, because I think that Rescue 1122 is a blessing. The way they reach and the way they bring the patients. Because I remember in my early days of surgical career, and Professor Abdul Majid Saab, my teacher, is sitting here, that the concept of cervical spine stabilization was not like लटकते पटकते से सर गिरते हुए इधर और रोड ट्रैफिक के या ट्रॉमा के या फॉल के जो पेशेंट्स थे वी यूज टू रिसीव कि शायद जिनमें पार्शल इंजरी होती होगी और हम तक पहुंचते हुए स्पाइन की कंप्लीट इंजरी हो जाती. But the way you guys are trained and the way you people take care for all the SOPs, it's really appreciable. Keep doing the good work.
Thank you very much. Assalamu alaikum.
Thank you, Mr. Usman, for your powerful and enlightening presentation. We greatly appreciate your time and talk today, as well as the huge contribution of 1122 in saving lives. At this point, I'd like to request our chair of this session, Professor Dr. Nabila Talat, to come on stage and give her remarks.
Thank you so much. I think we are already running short of time. Plus, after each presentation, it was very interactive discussion, and I also commented. So overall, all the presentations were aligned with the theme of the conference. That's very beauty of this event. And again, credit goes to the organizers because they chose the speakers and the talks assigned, including myself. So I think great applause. Thank you.
Thank you, Professor Doctor, for your valuable remarks. Now for souvenir presentation ceremony. I request our chair, Professor Dr. Nabila Talat, and co-chair, Professor Dr. Muhammad Bilal Mirza, to kindly come forward to present the souvenir. I also request chair of this conference, Professor Dr. Tanzila Khalid, to accompany chair and co-chair of this session.
I would like to request my mentor, my teacher, प्रोफेसर मजीद साहब टू प्लीज कम ऑन द स्टेज. ये हो नहीं सकता कि सर बैठे हूँ और मैं अकेली स्टेज पे हूँ. मैं तो पहले ही सर आए हैं तो मैंने नीचे आके कहा कि सर ऊपर आए हैं. तो मैंने बहुत कुछ सीखा सर से. और जनरल सर्जिकल प्रिंसिपल्स मेरा ख्याल है फाउंडेशन होते हैं. तो सर के लिए हमेशा दुआ निकलती है. और सर का एक जो और बहुत एक स्ट्रॉन्ग कह लें कि ट्रेट है वो ओनरशिप है. आज तक हमें ओन करते हैं अपने स्टूडेंट्स को. तो अल्लाह ताला सर को जिंदगी सेहत दे.
For sustainability purpose, we have replaced conference shield with souvenir this year. Now I request Professor Dr. Sara Salim to kindly come forward and accept her souvenir. For sustainability purpose, we have replaced conference shields with souvenir this year. Mr. Usman. Mr. Usman.
Innovation. That's because shields cannot save life.
Now I request Mr. Usman Ahmed to kindly come on the stage and accept his souvenir. Now I request Chair of the Conference, Professor Dr. Tanzila Khalid, to kindly present souvenir to the session chair and the co-chair. Professor Dr. Nabila Talat, please come forward to receive your souvenir. Yeah, she's there. Professor Dr. Muhammad Bilal Mirza, please come forward to receive your souvenir. Yes, ma'am. Thank you to all our respected guests for honoring us with your valuable insights. Now I will hand over the stage to Mahnoor Fatma for the inaugural session.
एक चेंज मैडम साइडा की जगह डायरेक्टर और ओके मैंने ऊपर नहीं बैठा डॉक्टर डायरेक्टर और एक सही रहमत सही
और फिर सोवेनियर के लिए मैडम साहब को बुलाओ।
नहीं वो चली जाएंगी फिर चलिए चलिए आपने डायरेक्टर साहब को भी बुलाया ठीक है ज़्यादा मतलब जगह डायरेक्टर और एक लिख
वो नहीं, ठीक है, वोट जानना मैम ने यहाँ पे आ जाना स्पीच के लिए, वो हम लोगों ने ऑलरेडी डिसाइड किया हुआ है। यहाँ पे नहीं, वो बस पड़ी रहनी है।
किस किस को देने हैं मुझे एक बार लिखवाना, लाइन वाइज लिखवाना।
पहले वो उसको देना है, एक नबीला तलत को भी
दे दिए और बस दो तो
Bismillahirrahmanirrahim. Assalamu alaikum and a very warm welcome to all distinguished guests, respected faculty members, honorable speakers, and dear participants. I am Mahnoor Fatma, former Vice President, Society for Skincare, and it is a great honor to moderate the inaugural session of 5th International Conference on Dermal Sciences. This year's conference is centered around the highly significant theme, wound management and skin repair, highlighting innovation, research, and clinical excellence in advancing dermal healthcare. To begin this blessed gathering, I request Hafizat Taskeen for the recitation of Holy Quran and Miss Aisha, a renowned Naat Khan for Naat, to please come on the stage.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم هو الله الذي لا إله إلا هو عالم الغيب والشهادة هو الرحمن الرحيم المهيمن المهيمن العزيز الجبار المتكبر سبحان الله عما يشركون هو الله الخالق البارئ المصور المصور له الأسماء يسبح له من في السماوات والأرض وهو العزيز الحكيم آمنت بالله صدق الله العظيم. He is Allah, beside whom there is no God, the knower of the unseen and the seen. He is all merciful, very merciful. He is Allah, besides whom there is no God, the sovereign, the supreme in holiness, the safe from all defects, the giver of peace, the guardians, the almighty, the all repairer, the sublime. Pure is Allah from what they associate with Him. He is Allah, the creator, the inventor, the shaper. His are the most beautiful names. His purity is proclaimed by all that is in the heavens and the earth. And He is the Almighty and All Wise. Jazakallah.
जहाँ भी हो वहीं से दो सदा सरकार सुनते हैं जहाँ भी हो वहीं से दो सदा सरकार सुनते हैं सरे आई न सुनते हैं पसे दीवार सुनते हैं खड़े रहते हैं अहले तख्त भी दहलीज़ पर उनकी खड़े रहते हैं तख्त भी दहलीज़ पर उनकी फकीरों की सदाएं भी शहे अबरार सुनते हैं फकीरों की सदाएं भी शहे अबरार सुनते हैं गुनाहगारों दुरूदे वालिहाना भेज कर देखो गुनाहगारों दुरूदे वालिहाना भेज कर देखो वो
अपने उम्मती का नग़माए किरदार सुनते हैं, सरे आईना सुनते हैं, पसे दीवार सुनते हैं, जहाँ भी हो वहीं से दो सदा सरकार सुनते हैं।
Jazakallah for the beautiful recitation and soulful naat. Now I request everyone to please kindly rise for the national anthem. Thank you. Please be seated. I request Professor Dr. Abdul Majid Chaudhary, our esteemed chief guest, to kindly come to the stage and honor us with his presence. Please join me in welcoming Professor Dr. Abdul Majid Chaudhary. Right. I request our guest of honor, Professor Dr. Nabila Tallat, to kindly come forward and take her place on the stage. I request Professor Dr. Amanullah Malik, Rector, the University of Faisalabad, to kindly come to the stage and occupy his seat. I request Professor Dr. Akram Malik, Principal, University Medical and Dental College, to kindly come to the stage and please be seated. I request Director Auric, Dr. Zahir Ahmed Zahir, to please come on the stage and occupy his seat. I request Conference Chair Professor Dr. Tanzila Khalid to kindly come to the stage and take her seat. To formally introduce the conference and share its vision, I request our conference chair, Professor Dr. Tanzila Khalid, Dean of Clinical Research, Faculty of Medical and Allied Health Sciences, University Medical and Dental College, and Head of Department of Dermatology. Professor Dr. Tanzila Khalid has been the founding chair of 5 consecutive ICDS, has demonstrated exceptional continuity in leadership and steadfast commitment to advancing dermal sciences through innovation and collaboration. To kindly address the audience, I request, ma'am, please.
Thank you, Banu. Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuhu. Worthy chief guest, my teacher and mentor, Professor Abdul Majid Chaudhry, guest of honor, Professor Nabila Talat, Rector, the University of Faisalabad, Professor Amanullah Malik, Principal, University Medical and Dental College, Professor Muhammad Akram Malik, and Director Auric, Zahir Ahmed Zahir Saab, honorable speakers, distinguished guests, and dear conference delegates. As the conference chair, it is indeed a privilege and an honor to welcome you all to the 5th International Conference on Dermal Sciences, ICDS 2026. Thank you. This year's theme is wound management and skin repair. That reminds us of our collective responsibility in a world where wound care, despite its critical importance, often remains overlooked and under-discussed. At a time when the burden of chronic wounds, burns, and trauma continues to rise globally, it becomes imperative that we bring this subject to the forefront of academic, clinical, and public health discourse. And ICDS 2026 aims to do precisely that. We are proud to share that ICDS 2026 has received more than 600 registrations, reflecting an extraordinary level of academic and professional engagement. Equally remarkable is the response to our pre-conference hands-on workshops that have collectively engaged over 560 participants, demonstrating a strong demand for practical skill-based learning. These workshops covering soxlet extraction techniques, pico-laser procedures, burn management, neuropathic wound care, healing through kintsugi art, and emergency response training conducted by Rescue 1122 have provided invaluable clinical and technical exposure, truly bridging the gap between theory and real-world practice. Over the course of these 2 days, our scientific program reflects both depth and diversity, and you have already witnessed that in the keynote session. From keynote discussions on mesenchymal stem cells therapy, platelet-rich plasma, and advanced burn management, to sessions on pharmacological innovations such as nanotechnology-driven wound healing, hydrogel-based therapies, and emerging drug delivery systems, we are exploring the frontiers of modern dermal science. Our sessions on regenerative medicine further highlight cutting-edge advancements, including exosome therapy and ozone-based interventions. Importantly, ICDS continues its tradition of interdisciplinary and interprofessional excellence. Our session on multidisciplinary and integrated approaches to wound healing emphasizes collaborative care models, while the panel discussion on interprofessional education in wound care, gaps in curricula, addresses a critical need in healthcare education. Equally unique is our dedicated session on the psychological, cultural, and narrative dimensions of wound and scar, where skin is explored not only as a biological entity, but as a site of identity, trauma, memory, and healing by experts in literature. This year, the conference also features more than 50 research contributions and keynote addresses representing dermatology, plastic surgery, pediatric surgery, breast surgery, emergency services, health professions, education, nursing and allied health sciences, pharmaceutics, and English literature, showcasing the growing strength of this interprofessional platform. Like every year, we have a young researcher session reflecting the passion, innovation, and promise of the next generation. At the end, I extend my heartfelt gratitude to all guests, speakers, and organizers who have made this gathering possible. Most importantly, I thank all worthy conference delegates, because conferences truly come alive through the exchange of ideas, discussion, and intellectual curiosity that each of you brings. I hope that the coming sessions will stimulate meaningful discussions, inspire innovative thinking, and strengthen our collective commitment to improving wound management and skin repair for patients around the world. Thank you very much.
Thank you, ma'am, for outlining the vision and significance of this conference so eloquently. Your leadership continues to inspire excellence in dermal sciences. Now I request Professor Dr. Amanullah Malik, Rector, the University of Faisalabad, a visionary leader providing dynamic direction to the institution who actively spearheads academic, research, and international collaboration initiatives and remains closely engaged in student orientation, research presentations, and faculty development to kindly deliver the welcome address. Please join me in welcoming Professor Dr. Amanullah Malik.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على خاتم النبيين. Very Honorable Professor Dr. Abdul Majid Sahib, Chief Guest, Professor Dr. Nabila Talat, Guest of Honor, Professor Dr. Tanzila Khalid, Conference Chair, Professor Dr. Akram Malik, my colleague, Professor Dr. Zahir, Dr. Zahida Makpoor Sahaba, Madam Registrar, very honorable, distinguished guest, honorable speakers, colleagues, dear students, Assalamu alaikum. It gives me immense pleasure to welcome you all to this 5th International Conference on Dermal Sciences at the University of Faisalabad, an institution that takes great pride in fostering innovation, academic excellence, and meaningful societal impact. The International Conference on Dermal Sciences over the years evolved into a hallmark of intellectual engagement, one that reflects not only academic rigor, but also a deep commitment to addressing the real-world challenges. This year's themes, wound management and skin repair, is both timely and significant in a world where trauma, chronic wounds, and post-surgical care continue to present major challenges. Healthcare, the need for integrated, research-driven, and patient-centered solutions has never been more critical. What distinguishes ICDS is truly an interdisciplinary nature. It brings together clinician, researcher, pharmacist, psychologist, and scholars from diverse fields, creating a platform where science meets humanity and innovation meets compassion. This integration is essential if we are to move forward in addressing the complex realities of healthcare today. I'm particularly pleased to see the strong emphasis on hands-on workshops and practical trainings. Such initiatives not only enhance knowledge, but also equip our professionals and students with the skills required to translate theory into effective practice. As an academic institution, we believe that conferences like ICDS are not merely events, they are catalysts for change. They inspire inquiry, strengthen collaboration, and contribute to the advancement of both national and global health priorities. I commend Department of Dermal Sciences, Professor Dr. Tanzila Khalid, and her team for the vision, dedication, and continued excellence in organizing this remarkable conference. I wish all the participants a productive and enriching experience. With this prayer that may Allah bring peace and relieve suffering of the humanity, particularly what we are facing many parts of the world, but especially in the Middle East. Pakistan, Hamesha Zindabad.
Thank you, sir, for your encouraging words and continued support toward academic and research excellence. Your vision plays a pivotal role in fostering platforms like ICDS. It is now my privilege to introduce our esteemed chief guest, Professor Dr. Abdul Majid Chaudhary, Member, Board of Governors, Cancer Research and Treatment Hospital. Professor Dr. Abdul Majid Chaudhary is a distinguished surgeon, renowned educationist, and a visionary administrator. He has served as the principal of Lahore Medical and Dental College and former principal of Fatma Jinnah Medical College. He completed his MBBS in 1973 and holds Fellowship of Royal College of Surgeons, Fellowship of Royal College of Physicians, and Master in Health Professional Education. He served as Chairman, Department of Surgery at King Edward Medical College for more than a decade. He was the project director of Surgical Tower at Mayo Hospital, Lahore. He is pioneer in medical education in Punjab and organized 2 international conferences on medical education. With over 70 research publications and leadership of South Asian Association for Regional Corporation Surgical Society. He has made remarkable contribution to surgical practice and medical education, particularly in promoting practical and sustainable healthcare solutions. Now I request Professor Dr. Abdul Majid Chaudhary to kindly address the audience. Please join me in welcoming Professor Dr. Abdul Majid Chaudhary.
सुनो मैं एक सिर्फ हिस्टोरिकल 2-4 चीजें
सर आपको जो दिल करेगा
तो ये इनको दे दे फिर लोड कर दें इस पे फैसलाबाद का जिक्र
तो 2 है
डर्मल साइंस दोनों में एक ही है Bismillahirrahmanirrahim. Assalamu alaikum, everybody. Ladies and gentlemen, I'm truly humbled and honored having been invited to be here in this conference. Honestly speaking, I never knew there is such conference which exists till Tanzila rang me up. And it's always a pleasure coming back to Faisalabad, where I started my career, I think before most of you were born. I was the first demonstrator of Punjab and Rawalpindi Medical College, which started at the same time in the city of Faisalabad in 1973. And I think it's a wonderful conference. Honestly, I never knew that, dermal sciences could be such an important thing. And all credit to Professor Tanzila for organizing this conference. And of course, to the medical college, Professor Akram, and the rector of the university, because without their blessings, I mean, nothing would be possible in these institutions. This institution has another feather in the cap. One of the first ever lady counselor of College of Physicians and Surgeons of Glasgow. She is sitting here, and she has done a wonderful job, represented Pakistan, and if everybody remembers, even last year, for the first time ever, President of our College of Physicians and Surgeons of Glasgow, Professor Mike McCurdy, visited the institution, And I think there was a seminar on breast diseases, and for the first time ever, honestly, in Pakistan. Ladies and gentlemen, there have been some wonderful presentations. Yeah, I did bring one, but I think everything has already been said. You know, at the end of the day, what you are giving to a patient is a scar. They don't know what you have done inside. I remember once working with a chief in England. Would you believe he never used any instruments while suturing other than the needle holder? He would always use his fingers. And 2-3 decades ago, there was a paper, and somebody compared it with the instruments used and the fingers used. And they had a microscopic examination of the wounds, you know? And it's amazing how much trauma do we cause, you know, to the wounds while we are suturing. So they say your fingers are still the best instruments that we have. Can be a bad one as well, but by and large, ladies and gentlemen, it's always honestly. In fact, would you believe I've got a lot of associations with the city of Faisalabad. I kind of created a Society of Surgeons of Faisalabad many years ago. And although it's very dormant now, I keep on reminding the surgeons that, you know, you must come up. And I tell you, you know, I taught in King Edward for 27 years only. And it's such a pleasure seeing your students. Nabila is sitting here, rising to such heights. And would you believe, in this province of Punjab, other than one, all the vice chancellors, they have been my students. It's very, very, it's very, very, very heartening, and you know, it keeps you going. So I think tissue respect is a very, very important thing. If you, is this the first slide? Now, I'm not going to take long, by the way. I think you have seen so much of it. I'll just mention some historical aspects because I love history. So, you know, we come across these day in and day out. And other thing I forgot to mention, I'm very happy that 1122 people have been invited here. Would you believe that the Act of 1122 was written by me way back in 2004? And the then Chief Minister of Punjab, Professor Parvez Elahi Saab, you know, he gave me this responsibility. And the concept of air ambulance was given by me in those days, when a surgical tower was being, you know, it was started in 2002. And in 2004, when the chief minister came and I said to him, I said, we need an air ambulance. He said, why? I said, sometimes important people like you can be injured and can be lifted to the top of a surgical tower in Mayo Hospital. And would you believe he went back and rang me up in 2 hours that I have sanctioned a helicopter. And so, ladies and gentlemen, I'll just take 2 minutes to tell you the history. But one of the most important things for a surgeon is the tissue respect. You know, one who doesn't respect the tissues, their wounds will get infected. The trauma that you cause, if you're not kind and careful, in good old days, in Mayo Hospital, you come across all kinds of people, natural sophistication in their hands, and few people are very crude. And we coined the term in those days, Kuchola surgeon. Typical Punjabi description of somebody who is not very kind to the tissues. They would always have problems, with the infections. Next one. Now, I think you have seen all these. I'm not going to go into it. Just next one. Just a couple of slides, that's all. Next one. Now, ladies and gentlemen, it has been going on ever since, the medical science started. In those days, during the Hippocratic era, abscess formation used to be considered a good sign. That is about, nearly 500 years BC. Presence of a thick, white, odorless pus in a wound as a positive sign of healing. It went on for a very long time in the world. Next one. Till such time, these are the people who had a great contribution. Semmelweis, in gynecologists, maybe sitting here, who first time advocated that you should wash your hands. And Joseph Lister, who was a Londoner based in Glasgow, professor of surgery. And of course, William Halsted. His wife was a nurse. And one day, she had a boil on the finger, but she had to assist her husband. And she said, I have got an idea. What I'll do is I'll use the kitchen gloves. And that's where use of surgical gloves came into being. Next one. But look at this, 500 years BC. And then, Theodoric of Serbia, he was Dominican surgeon. And somewhere in around 1230, he described and he challenged this laudable pus. He advocated clean wound management, minimal contamination, use of wine or alcohol as antiseptic. Proposed that suppuration is harmful, not beneficial, essentially centuries ahead of Joseph Lister. And he was an early advocate of what we now call aseptic wound care. He opposed the teaching of Galen, who was considered to be, and Hippocrates, two of the most important names in the history of medicine. Next one. They say in Alexandria and Egypt, the mummies were found with their wounds stitched with catgut. And that's nearly 1500 years BC. And techniques included sewing with plant fibers, hair, or animal tendons, using giant ant jaws as staples. And this was done in this part of the world by Sashruta from city of what is now called Varanasi, but it used to be called Banaras. He was another surgeon of that region, plastic surgeon sitting here would know, who described the forehead flap 500 years BC, and it still holds true. Animal and plant materials were used, like silk, linen, cotton, horsehair, human hair, and tendons. And ancient Indians specifically mentioned in Ayurveda some of the historical facts, which I think, we must know history. We must know the evolution of all these things. And I think when we remember history, we are paying tribute to these people who have done wonders with no facilities whatsoever. Next one. Like ancient Egyptians and Indians used the beetles to bite the wound edges together, after which the insect's body was removed, leaving jaws to act as a staple. And Sashruta from India described method of suturing, including straight and continuous zigzag and interlocking. And I tell you, he was the man who described medical ethics around the same time as Hippocrates. And it's absolutely wonderful if you have a look at it. Next one. I think I'll just, you can stop this. Ladies and gentlemen, I tell you something. These days I'm looking after Cancer Hospital in Lahore, which is a hospital which provides totally free services to anybody and everybody. We are having around 1,000 patients of cancer every day visiting. There is no registration fee. Nobody is allowed to say the word rupee from here. And we have the first ever palliative care unit of the country. I tell you, I was going through the history. Was a surgeon from Frankfurt. He, in those days, described the valve of Pfister, if you remember. It's a mucosal valve in the cystic duct of the gallbladder. In those days, they would do every kind of surgery. And he wrote a paper that a lady came to me with cancer breast, which was the size of the head of that lady. In those days, there was no anesthesia. I'm talking about 1705. There was no anesthesia, and people and the surgeons used to have their patients drunk. And mastectomy used to be done. They will strangle the breast at the base and chop it off with a knife and take a red hot iron for the hemostasis. Those were the days. And he, after doing the surgery, he asked his team to weigh this tumor. And this tumor was 12.3 pounds in weight. Why I'm telling you this story is, about a month ago, I was operating in Cancer Care Hospital. And this lady presented with a very large breast mass. You people can't even see it. And we operated upon this lady, rotated a flap to cover the raw area. And I asked my team to weigh it. Ladies and gentlemen, 320 years down the line, the tumor that I removed was 18.5 pounds in weight. हम लोग बड़के बड़ी मारते हैं. But we have failed to educate our people. We have failed to provide them with the basic health facilities, which is very, very unfortunate. And I tell you, in this country, the alternate medicine, they are playing havoc with the people. I'm not against dam darood. वो करवाओ, वो खुदा के लिए इलाज तो करवा लो. All these people with alternate medicine, when they have a problem, they will come and request you the surgical intervention the same night or next morning and go back and do the same silly things to human beings. So that's where we stand. I think, I don't know how many of you believe that we have a 58% literacy rate. I doubt it very much. It must be very, very low. Very low. Anyway, ladies and gentlemen, thank you very much. And Tanzila, well done. And, well done to organize this conference. And I'm honored and humbled having been invited to attend this conference. Thank you very much, ladies and gentlemen. Sorry if I have crossed any line. Thank you.
Now for the souvenir distribution ceremony, I request Professor Dr. Amanullah Malik, Rector, the University of Faisalabad, for souvenir presentation. I also request Professor Dr. Tanzila Khalid and Professor Dr. Zahir Ahmed Zahir to accompany Professor Dr. Amanullah Malik for souvenir distribution to our worthy chief guest, Professor Dr. Abdul Majid Chaudhary. Everyone, please have a huge round of applause for them. I request Professor Dr. Nabila Tallet to please come forward and accept her souvenir. Thank you to all our respected guests for honoring us with your presence and for your valuable contribution. I would now like to hand over the floor to Dr. Rabia Mahmood, Secretary Conference.
Bismillahirrahmanirrahim. Distinguished guest, I feel privileged to acknowledge Rescue 1122, established in 2004 for transforming pre-hospital emergency care in Pakistan. Today, it stands as the country's largest humanitarian emergency service, rescuing over 2.2 million victims in 2024 alone, with an impressive response time of 7 to 8 minutes. Beyond emergency response, it strengthens community resilience through training and disaster preparedness. At the first line in trauma and wound management, its professional saves lives every day. I invite representative of Rescue 1122 to receive the Tough Excellence Award for their outstanding service and dedication to the humanity. Please come and sit. Thank you. Now it's time to recognize Department of English Language and Literature at the University of Faisalabad for its innovative collaboration with ICDS since its inception. The department has used language and literature to explore the cultural, psychosocial dimensions of the skin, identity, and representation. By turning conference insight into the meaningful research, it has strengthened interdisciplinary dialogue. The department has presented 10 research studies in third ICDS, which had led to 8 publications in a reputable national and international journal. In fourth ICDS, research studies were presented, 6 research studies were presented, whereas 23 research studies have been submitted at this time. Very nice. This contribution highlights the role of language in enriching discourse of skin health and society. I invite Professor Dr. Naila Riaz, Head of Department, to receive Tough Excellence Award for the innovative collaboration. Please, ma'am. Thank you. It's an honor to recognize Department of Dermal Sciences. National platform in dermal sciences. Since its inception, ICDS has successfully hosted 5 conferences addressing diverse, impactful themes from colorism, cosmeceuticals to the emerging trend, then skin connects and wound management. Under the visionary leadership of Professor Dr. Tanzila Khalid, ICDS has evolved into a global forum. bringing together over 95 speakers from 15 countries and 35 disciplines, including around 12 professions, fostering meaningful interprofessional dialogue. By bridging the research and practice, ICDS continues to advance skin health while elevating Pakistan's presence in global scientific community. To receive this award, I call Chair of ICDS, Professor Dr. Tanzila Khalid, Secretary ICDS Dr. Rabia Mahmood, myself, and Conference Coordinator Ms. Sana Arshad to please come on stage to receive this award. And we are very honored to have accompanying Dr. Zahida Makbul, Registrar at the University of Faisalabad, for joining to grace this award to us. Thank you so much. This is the end of inaugural session. Now I would like to say our guests to please join us for tea. Thank you, sir.
language को इंग्लिश समझा कैसे कैसे इस्तेमाल को कैसे इस्तेमाल मिस्टेक्स को कैसे इस्तेमाल कर सकते अब पहले क्या देखेंगे क्या करेंगे जो कहानियां हैं अब हम पढ़ेंगे कैसे कैसे सीरियस इम्पोर्टेंस सीसी का इंग्लैंड में इसका अलग ही white and black comparison is black plus white plus black nano आता है supremacy का अपनी upper hand होने का जो कि इन दोनों का और अपना जुबान जो है उसको बैलेंस करता है और जो जरा बड़े लोग रहते हैं उनको और पाकिस्तान की भी देखा होगा कि पहले उनकी बच्ची का रिश्ता तलाश करना मुश्किल हो जाता है इसलिए ड्रीम्स अब बिजनेस इतना ज़्यादा प्रवेश करता है लेकिन आईसीडीएस सिर्फ कॉस्मेटिक्स नहीं है आईसीडीएस में इतने मुख्तलिफ तरीके से ड्रीम्स को डिस्कस किया है जैसे आप दौर के हवाले से इतनी इसमें इंजरीज इतने विक्रम्स इसमें एम्पुटेशंस होती हैं और जो जिस्म के आज़ाद वो कट जाते हैं और इंसान कैसे स्पेशल विकेट उस तरह नहीं चल सकता जैसे भी चलता है खेती तो साइंसिस का माहौल कि वो मैनेज भी कर स्पार्स का रिड्यूस करके इस तरह स्किन को स्ट्रेच किया इस तरह कि उसको इम्यूनिटी कॉस्मेटिक्स से बल्कि इस तरह वो आप एआई के साथ साथ वो आर्टिफिशियल लिम्स के साथ इनेबल कर ह्यूमन बींग्स बस ये मुझे बहुत ही अच्छा जब मैं एक पाकिस्तान का एक जिम्मेदार शहरी रूप से सोचती हूँ मुझे पाकिस्तान उस मुकाम पे पहुंच गया है तो सालिसी का किताब और आप देखिए ईरान और अमेरिका के साथ शामिल तो पाकिस्तान में उसमें सालिसी का किताब था जो पाकिस्तान के दर्द को बुलंद करता है फिर आप देखिए कैसे मिडिल ईस्ट से उनके लोग आया और कैसे उन्होंने पाकिस्तान को अपनी मदद के लिए वहां के बुलाया यानी बीच में से जो सुप्रीम पावर है वो निकल गई और उसकी जगह पाकिस्तान आ रहा है इस बात से दिल बहुत खुश होता है कि पाकिस्तान आज 2026 में इस मकाम पे है कि वो जंग बंदी को पा सकता है और तवानाई अपना भरपूर हिस्सा अगर आप जिया करें पाकिस्तान के किरदार और माना गया पाकिस्तान में कोई असर नहीं और हम उसको इस तरह देखने लगे इस जो दोनों पार्ट अपनी अपनी जगह पे
Advancements in emerging pharmacological strategies that will significantly contribute to improve the outcomes and therapy tissue regeneration. As a very good, we can really work, especially with intellectually enriching for all participants. To commence the session, it is necessary to have a gym of today's session. मैम मुझे तो सेशन के बारे में बताया गया तो एक मैम Assalamu alaikum and good afternoon to all distinguished guests, respected faculty members, and esteemed speakers. It's a privilege and honor to moderate this session. My name is Ruman Yunus and I represent the Department of Dermal Sciences, Semester 4. I have the honor of moderating Scientific Session 2, titled Pharmacological Frontiers in Wound Healing and Tissue Regeneration. This session is designed to highlight recent advancements and emerging pharmacological strategies that are significantly contributing to improved outcomes in wound care and tissue regeneration. I sincerely hope that this session will be both insightful and intellectually enriching for all participants. To start this blessed gathering, I would like to invite Ramshah for recitation of Holy Quran. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم كلا إذا دكت الأرض دكا دكا وجاء ربك والملك صفا صفا وجيء يومئذ بجهنم يومئذ يتذكر الإنسان فأنى له الذكرى يقول يا ليتني قدمت لحياته فيومئذ لا يعذب عذابه أحد ولا يوثق وثاقه أحد
صدق الله العظيم.
Jazakallah. To commence this session, it is my distinct pleasure to introduce the chair of today's session, Professor Dr. Atif Raza, Professor and Principal at the Punjab University College of Pharmacy. He is a distinguished academician and researcher with an extensive background in pharmaceutical sciences and a gold medalist from the University of the Punjab. I request Professor Dr. Atif Raza to please come on the stage and have their seat. Now it's my pleasure to introduce the co-chair of this session, Dr. Ikramullah Khan, Associate Professor and Head of the Department of Pharmaceutics at Government College, University, Faisalabad. As a head of Government College, University, Faisalabad, he is likely involved in innovative researchers and academic initiative. I kindly request Dr. Ikramullah Khan to please come on the stage. Without further delay, it's my pleasure to introduce our first speaker, Dr. Siti Afliza Shari. Dr. Shari is an associate professor at University Putra, Malaysia, with expertise in industrial biotechnology, pharmaceutical sciences, and statistical experimental design. She holds a PhD in industrial biotechnology and is currently leading the first international closed meeting on Wound Healing Project 2026 in collaboration with University Putra, Malaysia. She will be delivering her presentation, Healing Beyond Boundaries, a knowledge-driven approach to wound healing. We are honored to have Dr. Ashari joining us virtually. Kindly join me in welcoming her.
Healing with Kratom. So this research basically focus on integrating the natural product with nanotechnology for enhanced wound healing application. So geographically, Pakistan and Malaysia are about 6,000 kilometers depending on the route taken. However, the distance does not limit the scientific collaboration. And thank you very much to the organizer for inviting me to be part of this speaker in the 5th International Conference on Dermal Sciences. All right, so let's begin with the introductions of my university. So University Putra Malaysia, or UPM, is a leading and pioneering university in agriculture, not only in Malaysia, but also globally. And UPM also offer extensive student exchange and mobility program over 75 countries around the world. All right, so here is the outline of my presentation. So I will begin with a brief introduction to drug delivery systems, followed by nanocarrier system and the limitation. And also I will presenting a part of our finding on the nanostructure lipid carrier system, conclusions, and also our achievement. All right, so let's begin with the this slide, which is drug delivery system. So what is drug delivery system, or DDS? So basically, DDS are developed to effectively deliver the exact amount of drugs to appropriate target sites and maintain the desired drug levels. However, we have a few limitations of this conventional drug delivery system, So usually drug delivery system can be in a form of tablet, capsule, granules, ointment, syrups, and also suppositories. But in our case, in our research, basically I'm looking forward on the ointment, usually in topical drug delivery system. So basically, there is a limitation by using conventional DDS. For example, it has a poor absorption from target site, poor bioavailability, fluctuation in plasma drug level. Sometimes it can be repeated dosing and also high dose dumping. Therefore, we are looking forward on the innovations by using nanocarriers in controlled drug delivery system. So what is nanocarriers? So basically, nanocarriers is colloidal nanoparticles that are used for transporting therapeutic substance to a targeted site. And usually, these molecules, the particle size is within 1 to 100 nanometer, which is useful for applications such as drug delivery due to natural interaction between nanocarriers and biological system. So as you can see here, this is part of the mechanism where we can see in the middle there is a drug active site, and it is encapsulated by this nanocarrier system at the outside field. Right? So there is a lot of types of nanocarriers. For example, we have lipid-based, consists of liposome, solid lipid nanoparticles or SLN, and also nanostructured lipid carrier system. And also we have gold nanoparticles, iron oxide nanoparticles, and also we have mesoporous silica nanoparticles. And then in terms of inorganic, we have carbon nanotube, graphene oxide nanoparticles. In terms of polymeric, we have a lot of types in polymeric types, such as a very common one. We are using polymeric micelles, and also in terms of biological, we have exosome. But in our innovation, we are focusing on nanostructured lipid carrier system. All right, so this is our recent innovation where we use Metrogenous spiosa crude extract, where we encapsulate this plant extract into NLC system for wound application. So what is so special about NLC? So as you can see here, this NLC is produced using emulsifiers, solid and liquid biodegradable and suitable lipids. As you can see here, we have drugs in the middle, and then we have selections of solid lipid, and then we have liquid lipids, and also we need to use the surfactants, and then it's surrounded by the aqueous phase. Okay, so we are looking forward into a patch system. So why we choose NLC? Because of these advantages. For example, it has high drug loading and drug release. It has low toxicity, improved depigmentation properties, and also it can produce a very small particle size which are able to penetrate into deep skin cells easily. And this NLC is actually mimic the natural living tissues. And we are trying to embed this NLC in a form of hydrogel film because it can provide moisture, it can improve the wound microenvironment and combat infections, facilitate the healing process, and then it gives cooling effects, and also it can improve the patient comfort. All right, so why we choose this plant, or we call it as Metrogenous spiosa? It is origin in Southeast Asia. The family name is Rubiaceae, and the local name basically we call them biak ketum or kratom. So by traditional uses, it can be used in intestinal infections such as diarrhea, muscle pain, reduced coughing, diabetic, and wound healing. In terms of biological activities, this plant having antimicrobial, antioxidant, antimutagenic, anti-inflammatory, and antinociceptive. And this is part of the chemical compound or its physical phytochemical compound that having in Metrogenous spiosa or kratom. All right, so basically this is the whole process of our project. All right, as I mentioned earlier. So basically, if you want to produce, which is related to wound healing, you have to make sure that the ingredients you have, the active ingredients you have good antioxidant, antimicrobial, angiogenesis, and anti-inflammatory. That is a very prominent characteristic for wound healing. So the challenges of this Metridium spiosa or the scrotum is actually it's having a low biocompatibility and bioavailability. It is unstable storage during long-term storage for wound healing applications. And in terms of control administration, it's unable to maintain a control administration for transdermal drug delivery system. So therefore, our innovation, we are looking forward to transform this plant into this patch system. All right. So this is the overview of our research method, which include 2 PhD students of my group. So it consists of the first one on the preparation and optimization of the plant, and then we examine the behavior in terms of its gel fraction, rheological behavior, swelling behavior, and then we move on to the identification, characterization, such as we are looking forward on its particle size, surface morphology, and also instability study. And of course, we have a lot of wound healing evaluation. But in this research, in this presentation, I will just highlight the most important part. Okay, for the first one, we are looking forward on its compound. So this is one of my students' paper. We managed to publish in top 10% high impact factor. So this paper is actually, we are looking forward on the identification of compound from crude extract using LCMS. So we managed to identify about 27 compounds, which consists of alkaloid, flavonoid, phenolic, and fatty acid, which we believe that all these compounds having wound healing properties on it. Then we move on to the formulation itself. So my second PhD student also managed to publish in one of the top 10% high impact factor journals under industrial crops and products. We do some screening and selections of formulation compound using liquid lipid, solid lipid, and also surfactant. And based on the good surfactant selections of all these 3 ingredients, it shows that our formulation having a good stability, which we can see that there is an improvement on its colloidal stability. Yeah. And then we move on to this in vitro evaluation of the wound healing properties. So the first one, we are using in vitro scratch assay using 3 T3 fibroblast cells. So if you can see here, we have 4 different samples, and it shows that for MS-NSC with hydrogel, within 24 hours, it shows that excellent improvement in fibroblast cell migration, about 64.21%, right? Which is it having a strong proliferative and migration activities were reflected the ability of the cells to increase to cover the scratch wound areas. Then we move on to the in vivo study using sprout dolly rats. So you will see here, this is actually, because I'm a chemist, this is my first time handling rats. Yeah. So it is, we are looking forward on its scar improvement. So this is a wound kinetics diagram, the pictures using different samples with different concentrations. So we are focusing on different concentration of MS-NSC hydrogel from day 0 until day 21. So I will highlight on the day 21, as you can see here, from control, MS crude, MS NLC, and different concentration. As you can see here, the blue color one is actually the formation of collagen. Okay, the top one is our skin or scrotum corneum, and HR, there's start formation of hair follicle, the growth of the hair follicle. So we can see that in day 21, that we start the collagen formation and wound closure will produce in day 21. All right, so in summary, I would say that our end product possesses beneficial effects which play a crucial role in wound healing, which having a very excellent stability and maintain the particle size less than 200 nanometer. And this MS-NLC in hydrogel film could promote wound healing with improved pharmacological and toxicology. All right, so this study is actually begin in 2018. We managed to secure the intellectual properties using trade secret. So this is our formulation, this is our end product. And with that distance, with that journey, we managed to graduate 2 PhD students with around 8 papers published in high impact factors journal. And with that, I would like to acknowledge our collaborator, national and international, and also our funder from the Ministry of Education of Malaysia. And this is part of our collaborator. For example, we have from Japan, which helped us on angiogenesis part. And we have Associate Professor Dr. John Sanderson in Durham University, which helped me on the formulation or lipid synthesis. And also this is Associate Professor Dr. Holly Wilkinson from Hull York Medical Center, which helped us in terms of wound analysis. Because we are chemists, so we need to have this expertise to make it our finding useful and successful. All right, so with that, I'm looking forward for a new collaboration from Pakistan because this is my first time presenting my work under you guys, and I hope that we have a future collaboration in the future. Right, so with that, thank you very much. So see you soon. Assalamualaikum warahmatullahi ta'ala wabarakatuh. Bye. Right, Bismillahirrahmanirrahim.
Thank you, Dr. Ashari, for your insightful and enlightening presentation. It's my pleasure of inviting Dr. Muhammad Ishfaq, Professor and Dean at the National Business School, Faculty of Management Studies, the University of Faisalabad. He brings valuable expertise in management studies and plays a significant role in advancing academic and research excellence. His presentation topic is Socioeconomic Impacts of Agrochemical Exposure on the Skin Health of Agricultural Laborers. Kindly join me in welcoming Dr. Ishfaq.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Since morning, you are listening the presentations on the scientific part, on the medical side of wound management and skin repair, etc. But, let's shift the gear and talk about and look the issues from a different perspective. Okay. Thank you, Beta. The title of my presentation is the Socioeconomic Impact of Agrochemical Exposure on the Skin Health of Agricultural Neighbors. Next, please. This is a sequence of presentation. I will talk a little bit about the background of the issues and the objectives of the study, methodology, results, conclusion, and followed by the few recommendations. Thank you. Okay, agriculture in Pakistan is basically the backbone of the economy, which contributes about 24% to the national income and employing the about 37% of labor force. Cotton is a very important crop for the agricultural economy of Pakistan, which is known as the white gold, and it is the largest agro-based textile industry, contributes roughly 10% of GDP, and it generates over 55 to 60% of foreign exchange earnings, which is being produced using the cotton as a raw material. It provides livelihood to millions of Pakistani farmers' families. Agrochemicals play a significant role in meeting the demand of increasing population for the cotton fiber. And these pesticides disperse in the atmosphere, which is being used for protecting the cotton crop. And the major routes by which these pesticides can be absorbed by human bodies, they are the skins, lungs, and the guts. and the skin is the major place for accidental exposure. If you see the percentage share of different crops in total pesticide consumption, cotton is using 60% of the total pesticide being used. Sune. I will not take much time, और मैं ये भी बताऊं ये boring नहीं होगी. थोड़ा सा जरा सुन लें जरा. Keep silence, please. Okay, objectives of studies to analyze the pesticide use awareness, the perceptions and precautionary measures adopted by the farm workers. Number 2, to identify the health effects among farm workers due to this pesticide exposure. And the last one is to just give the recommendations. For this study, the Punjab province was chosen, and from Punjab district Bahawalpur was, which is the main, one of the major cotton producing area that was, selected. And from that district, 2 tehsils were selected, that is Mandi Yazman and the other tehsil, that is Bahawalpur. So these 2 tehsils were selected randomly. Primary data were collected, and the total number of respondents were 130, comprised of 65 applicators, the guys who are spraying the pesticides to the cotton crop, and 65 were the female workers who were picking the cotton. So the empirical estimates of the health cost, the total health cost was the medication cost, travel cost while visiting the doctors, dietary cost, home remedies, the work loss days, and the cost of precautionary measures. In this study, the cost incurred to government in providing health facilities does not include. And secondly, the pain, the suffering, and we cannot, quantify those costs. So those costs are also not included in the studies. And the Tobit model was used to find the determinants of health cost. That is, the Tobit model is a type of regression model used when the dependent variable censored. That is, it has a limited range, and many observations are clustered at a boundary levels. So these 2 methodologies were used for estimating. Okay. क्या हुआ हो गया? Yes. So these are about the results of the studies. So the first regarding the age of the applicators and the cotton pickers. You can see the applicators were majority, that is 33%, were in the range of 31 to 40 years. And for cotton pickers, it was in the age bracket of 21 to 30 years. If you look the average age, it is okay. So the average age is 35 years for applicators and cotton picker 33 years. If you look the education level, majority of these, 2, the applicators as well as the cotton pickers, they are illiterates. Majority of them were illiterate. If you look the gender, so in applicators, all males, and cotton pickers, all females. And the family members, majority of them have the average family members, 7.3 members, and about 7 members per family. So this is the distribution of applicators according to awareness about agrochemicals, which are, just causing problems for skin and wounds. So if you look that how you dispose of the container of agrochemicals. Mostly they throw away, the applicators just throw away the containers. And when we ask, do you read labels on the packages? Majority says 88% no. So look, the level of awareness and the use. So when they were asked, do you follow instructions given by farmers, by experts, majority, 72%, they replied no. And according to you, are the agrochemicals, they are toxic? So majority of them knows that they are toxic, but still they don't care. They are not, practicing good management. And have you attended any workshop trainings? So majority didn't, attended. About 70% didn't attended. Do you eat, drink, or smoke during spray? 10% still, they were eating or they were using, cigarettes during the spraying practices. When they were asked, do you store food items in agrochemicals containers? So majority said no, but still 1.5% were using those containers for food, for storing food items, which is not good. And the last question was, do you determine the wind direction first and then spray? And still about 40% they are not following. But this is very important because before spraying, they should know that what is the direction of wind so that it should not, damage themselves, and it's also be effective for the crop as well. So when we ask the same, different questions to the cotton pickers, so we asked, do you get instructions from farmers about clean picking, which is important? 54% said no. And when they were asked that, do you get instructions about precautionary measures? 92% said no. So they were not aware about the use of the precautionary measures during cotton. And, this is very dangerous for the health of female cotton workers. Then we asked, do you attend any trainings? Majority said no. And you take children with you while cotton picking? Majority said no, but still 3% female farmers, they were taking their kids with them during this practice. Look, the farm workers' perception of pesticide risk, about, 18% they are still said that there is no issues with the farmer. And there were, the mild perceptions were very also high. This is not, the good sign. So precautionary measures, if you look at the applicators and cotton pickers, so majority were, not using precautionary measures. They should use both the applicators and the cotton pickers. They should use the precautionary measures while spraying the chemicals and while picking the cotton. So this is pics from the field. And look, no gloves, no masks during picking. So not good for the health, and the same. But if you see the sprayer, the applicators were using the gloves as well as the masks. So the effect of agrochemicals, illness. Majority of applicators, they reported that, yes, they are, experienced the illness. And also the cotton, 63% cotton pickers also. And the number of ailment during a season, during the year, about 2 times, at least 20% they have this, experience. Health effect due to agrochemical exposures, 37% have skin irritations. In case of applicators and cotton pickers, about 55% they have. So other, ailment, they are eye irritation, itching, etc. And but skin irritation was the major one for this. So this is a model results. Health cost was about for applicators about 1,700 rupees, and the cotton pickers were 2,000, more than 2,000. And the major determinants they were the number of ailments, the cost of health, age, gender, personal, habits, duration of work, and protective clothing. They are significant determinants. What we can conclude, from the studies, pesticide intoxication is mainly driven by illiteracy, lack of training, and safety awareness, poor application technology, and limited use of personal protection equipments. Farm workers are generally illiterate, low-income earners with large household size, increasing their vulnerability. And eye and skin irritations are the most common symptoms after pesticide sprays. Among cotton pickers, skin irritation, burning sensations, and giddiness are highly prevalent. Health costs are higher for cotton pickers when we are comparing it with the pesticide applicator. Health expenditure increases with age, which is quite understandable. Duration of work, severity of symptoms, and distance to health facilities. Female workers incur higher health cost as compared to males, and smokers face higher cost than non-smoker in case of sprayer applicators. So what are the major recommendations? Number one, improve literacy and awareness through training, farm field schools, and learning groups. Number two, promote safe handling pesticides practices and encourage the use of less harmful agrochemicals. Number three, ensure use of protective measures, which is very important, like covering the face and using the gloves, and support vulnerable workers, particularly the cotton pickers. Very important. They should, through public interventions, alternative employment opportunities, and improved wage conditions, and include health risk information. And the last one is strengthen the pesticide regulation. So thank you very much, ladies and gentlemen. This is all about my presentation. If you have any question, if you have any comments, feel free. I'm here, or at the end of this session, we can have this discussion, sir. Thank you very much.
Thank you, Dr. Ishfaq, for your valuable and thought-provoking insight. It is now my pleasure to invite Professor Dr. Atif Raza, who is also our chair of today's session, Principal and Head of Department of Pharmacy at Punjab University. He has authored numerous publications in high-impact journals and has presented extensively at both national and international conferences. He will be presenting on safety of materials in cosmetics, a regulatory concern. Please join me in welcoming Professor Dr. Atif Raza.
राइट जी, बिस्मिल्लाहिर्रहमानिर्रहीम। सबसे पहले तो मैं बहुत दिल से मशकूर हूँ ऑर्गेनाइजर्स का, जिन्होंने आज यहाँ आने की लिए दावत दी और आप जैसे यंग लोगों के साथ इंटरेक्ट करने का मौका दिया। तो अस्सलाम वालेकुम टू एवरीवन। My presentation is basically a cosmetic से related है, और इस context में कि जो इस वक्त emerging area of the business world है, उसमें cosmetics जो है, they are टेकिंग द लीड रोल, और जो बच्चे बिल्कुल एंड में बैठे, अगर वो आने वाले सालों में लाखों रुपया कमाना चाहते हैं तो वो थोड़ा आगे आ जाएं। और क्योंकि आज जो ये मेरी प्रेजेंटेशन है, इट्स टेक्निकली तो शायद होगी थोड़ी सी, लेकिन इट्स मोर एंटरप्रेन्योरल साइड, क्योंकि मैं समझता हूं कि ये जो वक्त है इस वक्त, ये हमें बहुत से जहां एडमिनिस्ट्रेटिव चैलेंजेस हैं, वहां हमारे लिए इकोनॉमिक चैलेंजेस भी बहुत हैं। खास तौर पे हमारे ये जो जेंजीज आ गए हैं हमारे सामने, इनकी रिक्वायरमेंट्स और हैं, इनके मामलात और हैं, और हमारी जनरेशन को तो ये किसी काबिल समझते ही नहीं है। और हमें, क्योंकि हमारे बच्चे ही कहते हैं अब्बा आपको क्या पता, हमें ये नहीं पता कि जी उनको क्या पता है। लेकिन बहरहाल आई हैव ट्राइड माई लेवल बेस्ट कि आज की जो प्रेजेंटेशन है, इट गिव्स यू सम आइडिया के वेयर द वर्ल्ड इज गोइंग एंड what necessary things to be done in the next few months. मैं इसलिए सालों की बात नहीं करता कि वक्त बहुत तेजी से चल रहा है, और ये जो वक्त है ये सबसे ज्यादा इस वक्त मैं समझता हूँ कीमती चीज है, जिसको इफ यू नॉट टैप टाइमली तो बहुत देर हो जाएगी। और हम पाकिस्तानी इस मामले में बहुत खुद कफील हैं कि जब सब चीज़ें गुजर जाती हैं तब हमें याद आता है कि जी हमें भी कुछ करना चाहिए। मैं एक लास्ट वीक एक फ्यूचर रेडी एंटरप्राइजेस के एक फोरम पे था, तो वहाँ सबसे ज़्यादा जो चीज़ मुझे बड़ी फील हुई कि वहाँ एक चीज़ डिस्कस हुई कि पाकिस्तान के पास अपॉर्चुनिटीज़ किस तरह आई और किस तरह हमने या हमारी यूथ ने कैसे उसको ज़ाया किया। मैंने कहा जी अर्ली 80s में कंप्यूटर्स आए एंड दैट वाज अ रेवोल्यूशन, और उस कंप्यूटर्स के आने पे बहुत से लोगों को ये शिकायत हुई कि जी अब तो बहुत सा काम तो अब कंप्यूटर करेगा, लोगों की ज़रूरत नहीं रहेगी और लोग ये बेकार हो जाएंगे और मशीन्स आ जाएंगी। तो ये सब जानते हुए भी हमने उसको ऑप्ट नहीं किया, और हमने उसको एज ए बस एक बॉक्स मशीन बॉक्स समझा, और अपनी कुछ ज़रूरी चीज़ें जो काम करते थे, प्रोसेस जो कैलकुलेटर का काम था वो जो हम पहले जुबानी कर लिया करते थे, हमें शायद आज भी वो पंजाबी में गए सानू आज भी पहाड़े याद नहीं, वो हम याद कराते थे 2 1 2 2 दूनी 4, ठीक है, और हम कैलकुलेट करते थे विद इन सेकेंड्स। फिर कैलकुलेटर आ गए, वो खत्म, टाइम टेबल्स खत्म हुए, टेबल्स खत्म हुए, फिर हम कैलकुलेटर पे, फिर कंप्यूटर्स आ गए। बट वी मिस द अपॉर्चुनिटी एट दैट टाइम, वो जो रेवोल्यूशनराइज हुआ था। उसके बाद इंटरनेट आया, लोकल एरिया नेटवर्क में जी, वो साथ वाले ऑफिस वाले को मैं यहीं से ही मैसेज करता हूँ और वायर के थ्रू मैसेज चला जाता है और हम इसमें खुश होते रहे। और क्या हुआ, इंटरनेट की एडवांटेज सारा हमारा पड़ोसी मुल्क ले गया। हम बिलियंस ऑफ ट्रेड कर बैठे वो इंटरनेट के होने से, और हम वहीं पीछे अपने सिर्फ उसी शुगल मेले में हमने वो वक्त ज़ाया किया। इट्स अगेन द टाइम इज नॉकिंग विद एआई। अब आर्टिफिशियल इंटेलिजेंस इज नॉकिंग एट द डोर। Believe you me, by the next 4 5 years, everything will be changed. और हमने आज इस अपॉर्चुनिटी को ना अवेल किया, अगेन वी विल बी सिटिंग बिल्कुल ऐसे, अगले साल 2 साल बाद ऐसे ही आएंगे, तकरीरें होंगी, टॉक्स हो जाएंगी, एंड देन विल गो बैक। सो व्हाट आई फेल्ट ओवर द लास्ट कपल ऑफ वीक्स, जब मुझे इनविटेशन आई तो मुझे लगा कि मैं यंग जनरेशन के साथ क्या डिस्कस करूं विच गिव्स सम काइंड ऑफ फ्रूट फॉर थॉट कि हमें क्या करना चाहिए। एंड बीइंग द डोमेन इन द साइंटिफिक अरीना, और पर्टिकुलरली विद द कॉस्मेटिक्स, क्योंकि मैं खुद बहुत ज़्यादा ये जो डर्मल ड्रग डिलीवरी सिस्टम है इस पे काम, लास्ट ईयर मुझे याद है मैंने नैनो फाइबर्स के ऊपर बात की थी कि वी आर हैविंग गुड नैनो फाइबर फॉर्मेशन टेक्नोलॉजी, और उसको हम यूज़ करते हैं। तो आज जो मैं ज्यादा बात करने वाला हूं, यार इसके किस ऊपर कौन सा था, ये वाला, ये क्या गया भाई? हाँ, ये बैक साइड लो, फर्स्ट स्लाइड लेके, हाँ ये आप ये देखिए, ये मैं सिर्फ अभी पाकिस्तान मार्केट की बात करने लगा हूं, जो आपकी कॉस्मेटिक की मार्केट है, ठीक है, एंड it is going to touch $5.3 billion मार्केट इन बाय 2026 के ऊपर ये अचीव कर चुकी है वर्ल्ड लेवल पे। और पाकिस्तान जो है इस वक्त तकरीबन तकरीबन जो है वो $4.5 मिलियन की मार्केट बन चुका है। जो लोकल डोमिनेंस है, हाई इंपोर्ट ड्यूटीज हैं अप टू 40%, जो अब आपकी जो कॉस्मेटिक बाहर से आती थी उनके ऊपर इस वक्त 40% ड्यूटीज लग गए एंड द थिंग्स बिकम वेरी एक्सपेंसिव। और इसमें अपॉर्चुनिटी हमारे लोकल मैन्युफैक्चरर्स के लिए है कि दे कैन कैच दिस अपॉर्चुनिटी के वी आर इन द कैपेसिटी टू डेवलप अवर ओन प्रोडक्ट्स, और हम इस बढ़ती हुई मार्केट को कैप्चर कर सकते हैं विद स्लाइट फोकस ऑन द वे फॉरवर्ड व्हाट वी हैव टू डू। और इसके अंदर सबसे बड़ी जो ये देखें, जो ई कॉमर्स के प्लेटफॉर्म्स हैं, अब आपको किसी वो जो एक पेशावर से एक डेलीगेशन आया था पंजाब यूनिवर्सिटी, तो उसमें बेटियों हमारी ने ये सवाल किया कि जी यहाँ पंजाब में तो बड़ा एक्सपोजर है और बच्चियाँ जो हैं वो काम भी करती हैं, लेकिन केपीके में वी आर हैविंग वेरी रिस्ट्रिक्टेड एनवायरनमेंट और वो हम नहीं कर सकते जो हम यहाँ देखते हैं। तो आई सेड देयर एज वेल कि जनाब अब आपकी मार्केट जो है वो एक केपीके मार्केट नहीं है, इट्स नॉट द पाकिस्तान मार्केट, नाउ वर्ल्ड इज योर मार्केट एंड यू कैन डू इट मिरेकल्स बाय सिटिंग एट योर होम। और वहां से आप अपनी प्लेटफॉर्म्स डेवलप करिए, आप अपना ऑन वर्चुअल ये डिस्प्लेस अब अवेलेबल हैं, मुख्तलिफ प्लेटफॉर्म पे आप जाके अपनी प्रोडक्ट कर सकते हैं। और इसीलिए ये $490 मिलियन की मार्केट है पाकिस्तान की इस वक्त कॉस्मेटिक्स की बाय 2025। और अगर आप इसका ये ग्लोबल मार्केट देखें कि स्किन केयर प्रोडक्ट्स जो है ना वो लीड कर रही हैं इसके अंदर, कोई मोर देन 70% ऑफ द मार्केट शेयर जो है कॉस्मेटिक्स का वो स्किन केयर प्रोडक्ट्स का, या बॉडी केयर प्लस स्किन केयर प्रोडक्ट्स जो है ना उसकी मार्केट है। बाकी कुछ हेयर प्रोडक्ट्स हैं, कुछ फ्रेग्रेंस हैं, दे आर सो मेनी, मैं अभी दिखाता हूँ उसकी मार्केट। और इसकी जो एक्यूमुलेटिव जो ग्रोथ रेट है दैट इज 5.25% बाय 2032। तो उससे आप अंदाजा करिए कितनी ह्यूज मार्केट जो है इज अवेटिंग फॉर द पीपल हु कैन डू मिरेकल्स इन दिस मार्केट। ये देखिए, मैंने इसलिए पहले ऊपर लिखा स्टार्ट अ ब्रांड, अपने ब्रांड्स बनाइए। अब ये इतनी बड़ी मार्केट है, मैं ऐसे नहीं कहा जो पीछे वाले बच्चे जो मिलियंस ऑफ रुपीस महीने के कमाना चाहते हैं, थोड़ा दो सीटें आगे आ जाओगे, ज्यादा जल्दी कमाइयाँ शुरू हो जाएंगी। ठीक है ना, कितने अरसा बैठ के यहाँ पे सुनना है, और कुछ सुनाने वाली पोजीशन पे भी आए। वो किसी ने कहा, वो कासिम अली शाह साहब का रेफरेंस से एक वो मीम बनी कि जी कासिम अली शाह साहब कहते हैं पैसे की कोई वैल्यू नहीं है, पैसा एक ऑर्डिनरी चीज है, असल चीज जो है वो आपके इखलाक हैं दूसरे। वो कहते हैं वो ये बात कहने के 4-5 लाख रुपया लेता है। सो जिसे कहते हैं जिसके घर दाने उसके कमले भी सियाने। ठीक है, दिस इज द रियल फैक्ट। इफ यू आर नॉट अर्निंग बाय द नेक्स्ट 2-3 years, रेस्ट एश्योर घर वाले आपको बड़े अजीबो गरीब नजरों से देखेंगे, क्या मसला है तुम लोगों के साथ भाई, कौन लोग हो तुम। तो जस्ट गोइंग बैक, स्टार्ट अ ब्रांड इन पाकिस्तान, एक्सपोर्ट लोकल प्रोडक्ट्स टू द इंटरनेशनल मार्केट। हमारे फार्मेसी के स्टूडेंट्स ही हैं, व्हाट दे हैव स्टार्टेड, उन्होंने अपनी एक कंपनी बनाई, और वो आपकी तरह के बच्चे हैं, वो स्टूडेंट्स थे 16 साल 2 साल पहले। उन्होंने सिर्फ सेग्रीगेशन करना शुरू की, छोटे लौंग में और बड़े लौंग में, सिर्फ उन्होंने और कुछ नहीं किया। दे हैव जस्ट सेग्रीगेटेड। वो हमने सेविंग पढ़ी हुई है ना कि जनाब को वो छोटा साइज बड़े साइज से अलग हो जाता है, तो उन्होंने सिर्फ डिफ्रेंशिएट किया एक स्पेसिफिक लॉन्ग और एक बड़ी लॉन्ग को, और उन्होंने स्टैंडर्डाइज कर दिया उसको, एंड नाउ दे आर एक्सपोर्टिंग इट like anything to the international market. So it's only the matter of thinking out of the box. कि अब आपको सोचना चाहिए कि इतनी बड़ी 2023 में 4.6 मिलियन की मार्केट थी, which is going to be $6.28 million by the year 2026, by end of 2026. इस साल के एंड तक ये 5.329 मिलियन डॉलर्स की मार्केट बनने वाली है आपकी। और उसमें जो मेजर शेयर देखें, इट्स अगेन स्किन केयर एंड हेयर केयर प्रोडक्ट्स। वो मैं अपने जैसे बहुत से ये जो दो भाई को ही देख रहा हूं, तो मुझे भी आ गया कि यार कोई तो है हम जैसा। तो ये मैं दिस इज व्हाट, मुझे कोई आज कह दे यार तेरे सर पे बाल आ जाएंगे अगले 1 साल में, मैं कम से कम एक दफा जरूर ट्राई कर लूंगा। तो दिस इज व्हाट इज इंपॉर्टेंट फॉर अस टू अंडरस्टैंड कि देखें, वी बीइंग फार्मासिस्ट, हमें अपने आप को रिस्ट्रिक्ट थोड़ी करना है, और पैसा हमें कमाते हुए कोई बुराई है, बट वी हैव टू टारगेट। और आप तो बड़े खुशकिस्मत है, आपके साथ एक ये पूरा ये डिपार्टमेंट ऑफ ये डर्मल साइंसेज है, प्रोफेसर साहिबा साथ हैं, एक्सपर्ट लोग साथ हैं, आपकी फैकल्टी साथ है जो मुख्तलिफ इनोवेशन करती है। आपको तो छा जाना चाहिए अब तक, इतनी बड़ी मार्केट इज वेटिंग फॉर यू, तो कुछ कर लो भाई। सो ये सब करने के लिए देखें बात कि इतनी बड़ी मार्केट है, तो उस बड़ी मार्केट को आपने अगर एंट्री करनी है या आपने उसमें से अपना शेयर लेना है, तो वो ऐसे ही नहीं है। यू हैव टू सेट सर्टेन स्टैंडर्ड्स कि मार्केट इस वक्त किन स्टैंडर्ड्स पे है और कौन सी प्रोडक्ट्स की मार्केट में एप्रिसिएशन है। तो और उस तमाम प्रोडक्ट जो लीड करती हैं, उन सब की जो मेन जो स्ट्रेंथ है, दैट इज कंज्यूमर हेल्थ थ्रू साइंस एंड रेगुलेशन। और ये दोनों चीजें आपके घर में ऐसे भागती फिरती हैं जैसे जो है ना मुफ्त में कोई एम्प्लॉय मिल जाए, हर काम उससे करा लें। यू आर द बेस्ट पीपल इन द साइंस who understand skin and the products. You are the best people in this hall to understand the regulations which governs the laws which deals with the products. आपसे बेहतर रेस्ट एश्योर कोई नहीं मुझे नजर आता इस वक्त पाकिस्तान के अंदर। तो मैं पूरे यकीन से कहता हूं कि बीइंग अ फार्मासिस्ट, अब मुझे रियलाइजेशन होती है कि यार फॉर्चुनेटली या बाय सम काइंड ऑफ माय गुड डीड्स कि मुझे अल्लाह ताला ने फार्मासिस्ट बना दिया। कि आई एम सो हैप्पी नाउ कि यार कि मेरे पास वो तमाम अल्लाह ताला ने चीजें हमारे से लिंक कर दी हैं कि जिसमें हम इसमें काम कर सकते हैं और बड़ी मार्केट के अंदर हम अपने आप को मनवा सकते हैं। सो प्रिवेलेंस एंड कॉमन रिएक्शंस, क्योंकि सबसे इंपॉर्टेंट चीज यही है कि जब भी आप प्रोडक्ट को मार्केट लेके जाएंगे तो यू आर ऑफरिंग अ प्रोडक्ट विच इज फ्री फ्रॉम द साइड इफेक्ट्स, फ्री फ्रॉम obnoxious effects, free from something which is not acceptable by the market. ठीक है, तो हमें इस चीज के ऊपर देखना है कि वो क्या चीजें हैं जो कॉस्मेटिक प्रोडक्ट्स के अंदर पर्टिकुलरली, क्योंकि मैं अभी फोकस सिर्फ कॉस्मेटिक्स की कॉन्टेक्स्ट में बात करूं, और कॉस्मेटिक्स में भी जनरल कॉस्मेटिक्स। आई एम नॉट कंसर्न विद द कॉस्मोस्यूटिकल्स, आई एम जस्ट टॉकिंग अबाउट द कॉस्मेटिक्स। आप में से मैं नहीं समझता कोई भी यहां मौजूद है जो कम से कम 5 से 6 प्रोडक्ट डेली बेसिस पे एक्सपोज नहीं होता। और उसमें जो केमिकल्स हैं, दे आर मोर देन 12 to 15 केमिकल्स विच आर बीइंग एक्सपोज्ड। सुबह से शुरू करते हैं, फेस वॉश से, सोप से, डिओड्रेंट से, शैम्पू से, वो ये मेकअप से. There are lot of products which you are being using in everyday life, and more than 12 to 15 ingredients, chemicals which you are being exposed on daily basis. और myths है ना हमारे पास कि जी मैंने तो ऊपर ही लगाया हुआ है, बॉडी के अंदर थोड़ी जाता है. It's safe. तो वी हैव टू अंडरस्टैंड कि जो हम बॉडी के ऊपर मलते हैं चीजें, ये बॉडी के अंदर भी जाती हैं, ये एब्जॉर्ब होती हैं, थोड़ी हो ज्यादा हो लेकिन होती हैं. तो हमें इस चीज को अंडरस्टैंड करना है. ये जो ये अब बेटियां बैठी हैं ज्यादातर, तो लिपस्टिक भी बहुत ज्यादा इस्तेमाल ही करती हैं. एक रफ अंदाजा है कि 3 से 4 पाउंड्स ऑफ द लिपस्टिक्स आप अपनी 1 ईयर में खा जाते हो. मैं किसी पे गुस्सा चढ़ जाता है तो होंठ को बींच लेते हैं, क्योंकि उसको तो कुछ कह नहीं सकते. अपनी लिपस्टिक शुदा होंठों को ही खाना शुरू कर देते हैं. तो वो चीजें कहां जा रही हैं? दे आर एक्चुअली रिजाइडिंग इन योर बॉडी, विच इज डेंजरस. और फिर ये भी चीजें, गो नेचुरल, ओ जी ऑर्गेनिक है, हर्बल है, इसका कोई इफेक्ट नहीं. ऐसा नहीं है, बल्कि कई ऑर्गेनिक ज्यादा खतरनाक है, सिंथेटिक सेफ हैं ज्यादा, क्योंकि उसके ऊपर टेस्टिंग हुई है, उसके ऊपर बहुत सा काम किया हुआ है, विच हैव प्रूवन देम सेफ. नेचुरल पे तो काम ही कुछ नहीं किया. बस खा लो, नेचुरल है, लगा लो, नेचुरल है, सूंघ लो, नेचुरल है. और ये मिथ्स हैं जो गलत हैं. सही दफा नेचुरल चीजें खतरनाक हो जाती हैं बनिस्बत सिंथेटिक्स के. तो वी हैव टू टेक केयर ऑफ एवरीथिंग. सो top symptoms, acne is the most common side effects reported by 36% of users, followed by skin redness, itching and general irritation. आप सब इस परसेंटेज में शामिल हैं. ठीक है. हाई रिस्क कैटेगरीज के अंदर 73.4% एंड मेकअप 70.2% आर द प्राइमरी कल्प्रिट्स जो आपके साइड इफेक्ट्स के ऊपर आते हैं. झुर्रियां दूर करनी थी, झुर्रियां पड़ गई. बाल ज्यादा उगाने थे, बाल जो रह गए थे वो भी गए. भी बड़ा शैम्पू किए, बड़ा हमने इसके ऊपर वो किया, वो पता लगा कि जनाब वो मैं ड्राई एरोसोल, वो क्या कहते हैं, रेडी टू वॉश एरोसोल पाउडर्स आ गए हैं. नहाने से भी जान छूट गई. ड्राई शैम्पू, वो ऐसे ऐसे देख रही जैसे मैं कोई गलत बात कर रहा हूं. कोई नहाने की जरूरत नहीं है, बस जल्दी जाओ, थोड़ा सा वो एरोसोल लगाओ और जनाब बाल शाल सीधे. और ये नहीं पता कि उस एरोसोल स्प्रे में देयर इज बेंजीन व्हिच इज कार्सिनोजेनिक, और हम जनाब बड़े मजे से लगाते हैं. सो यू हैव टू बी वेरी केयरफुल नाउ, क्योंकि कॉस्मेटिक्स इज ओवर पार्ट नाउ. ये हमारा न्यू नॉर्म है कि जी जब तक कॉस्मेटिक्स प्रोडक्ट्स अप्लाई नहीं ना कर लेंगे वो कमी रह जाती है. जैसे मोबाइल जब तक हाथ में ना हो, लगता है मेरा कोई हाथ रह गया घर. बंदा किताबें भूल जाता है, बंदा अपनी खाना भूल जाता है, लेकिन अपना मोबाइल नहीं भूलता. पता नहीं ये क्या साइंस है कि ये नहीं भूलता, बाकी हर चीज भूल जाएगा. बिकॉज इट इज नॉर्मल टू यू नाउ. ये अब आपका हिस्सा है. क्योंकि अब जैसे हम कहते हैं ना, अपने हाथ से मक्खी उड़ाते थे, अब इससे स्मार्टफोन से उड़ा देते हैं जनाब. वो ये नहीं करेगा हाथ से मक्खी, वो इसके अंदर एक बी होगी जो क्रिएट करेगी वाइब्रेशन, और वो वाइब्रेशन मक्खी उड़ा देगी. वो हाथ से ऐसे नहीं करेगा, वो इसका अच्छा ओके ऐसे का, चलो जी मक्खी उड़ गई. बट इट्स अ न्यू नॉर्म नाउ. ये जेंजीज बड़ी मजे की जनरेशन आ गई है हमारे पास. इससे बहुत कुछ सीखने को मिलता है. सो prevalence and common reactions जो हैं, they are the global and regional data show that female, particularly those under 30, they are more exposed to these reactions जो आपकी बात ही कर रहे हैं हम. ठीक है. So look at this. 77% is microbial contamination in the cosmetic products, जिसकी वजह से आपको skin rashes भी हैं, infections भी हो रही है, बहुत कुछ हो. Then there are banned ingredients, जिसकी वजह से 12%. के जो साइड इफेक्ट्स और रिएक्शंस होते हैं बिकॉज ऑफ द प्रेजेंस ऑफ द बैंड प्रोडक्ट्स इन द कॉस्मेटिक प्रोडक्ट, जिसकी वजह से इचिंग, बर्निंग एंड एवरीथिंग। तो ये सब चीजें हमें समझनी है, then we will be able to develop a brand which will be accepted worldwide. और अभी अब जो नेक्स्ट पार्ट ऑफ द प्रेजेंटेशन जो अब मैं दे रहा हूं, ये मैं उन बच्चों के लिए दे रहा हूं who want to become in this market, कि उनको कुछ बुनियादी बेसिक्स पता हो, so that if they want to be in this market, तो उनको बुनियादी चीजों का पता होना चाहिए कि what they have to do। और उसमें सबसे पहले जो चीज इंपॉर्टेंट है, टू अंडरस्टैंड द कॉस्मेटिक सेफ्टी, कि व्हाट वी मीन बाय द कॉस्मेटिक सेफ्टी। So by definition, any substance applied to the body to clean, perfume or change appearance comes in the category of cosmetics। ठीक है, कुछ भी आप अगर करते हैं, आप विग भी अगर लगा लेंगे तो that comes the part of the cosmetic product, क्योंकि it changed the appearance। Complexity, typical products contain 15 to 50 ingredients in a product। So you understand by this कि जी कि कितनी complexity है cosmetic products की, कि जहां पे you have to be very careful when you are going to develop a product। Objective इन तमाम चीजों के to ensure product are safe for human health under normal and reasonably foreseeable use, कि आप जो उसकी expected intended use है उसके context में रहते हुए it has to be safe। Now, this is very important for the students to understand the major classes of cosmetic ingredients, कि इन बुनियादी ingredients के बगैर आपकी cosmetic product नहीं बनती। First one is the functional ingredients, the other one the performance, then the aesthetics, and then comes the natural or synthetic development of the product। तो उसमें बेसिकली क्या है, जो फंक्शनल इंग्रेडिएंट्स हैं, these materials provide the necessary structure, stability and texture to a product। ठीक है, ये आपके वो बेसिक इंग्रेडिएंट हैं जो उसकी ओवरऑल ये शेप को डिफाइन करती है और उसकी स्ट्रेंथ को डिफाइन करती है, जिसमें इमल्सिफायर्स और विस्कोसिटी मॉडिफायर्स और प्रिजर्वेटिव शामिल हैं। Then we have performances, which are the active ingredient, जो फर्स्ट प्रेजेंटेशन थी जिसके अंदर वो एक प्लांट को यूज किया गया एज एन API। सो दैट इज द परफॉर्मेंस इंग्रेडिएंट्स, जो कि बेसिक इंग्रेडिएंट होगा उस प्रोडक्ट को यूज करवाने के लिए जो इंटेंशन होती है। और इसके अंदर मॉइस्चराइजर्स, UV फिल्टर्स, एंटी एजिंग, बिकॉज दीज आर दी जिसे कहते हैं कि आई कैचर्स हैं या सेलिंग हॉर्सेज हैं, जिनकी बुनियाद पे आपको कहते हैं जी ये यंग कर देंगे, आपको 2-3 महीने में स्किन ग्लो कर देंगे आपकी, जनाब काले को कर दे चिट्टा और चिट्टे को चनवर का। तो मैं ये सारी चीजें जो हैं वो इसके अंदर ये आती हैं, विच आर द परफॉर्मेंस। और यू हैव टू बी केयरफुल इन द सिलेक्शन ऑफ दीज इंग्रेडिएंट्स। देन द एस्थेटिक्स, ये क्योंकि बहुत ही इंपॉर्टेंट पार्ट होता है कि जी ठीक है एक्टिव इंग्रेडिएंट्स भी हैं और स्टेबल भी है, बट इफ इट हैवंट गॉट द एस्थेटिक अपील इन द प्रोडक्ट, आपकी जो सिलेक्शन ऑफ द प्रोडक्ट है वो कंप्रोमाइज हो जाती है। और इसके अंदर जो ज्यादातर यूज है वो कलर्स एंड पिगमेंट्स हैं और फ्रेग्रेंसेस हैं। एंड आउट ऑफ द मेन कल्प्रिट्स, ये जो दोनों हैं जो एस्थेटिक्स लेके आते हैं, ये सबसे ज्यादा खतरनाक हैं, कलर्स और पिगमेंट्स, क्योंकि मोस्टली दे आर वेरी डेंजरस एंड कार्सिनोजेनिक। और फ्रेग्रेंसेस का तो हाल ही कोई नहीं है, क्योंकि आप जब भी किसी प्रोडक्ट में देखते हैं तो उसमें बस फ्रेग्रेंस लिखा होता है जी, फ्रेग्रेंस भी ऐड की गई है, और वो फ्रेग्रेंस है क्या, कहाँ से आई है, कहाँ से एक्सट्रैक्ट किया है, इसका कोई पता नहीं होता। एंड नेचुरल वर्सेस सिंथेटिक, हम अक्सर ये कहते हैं नेचुरल इंग्रेडिएंट्स आर नॉट इनहेरिटली सेफ, कि ये जो एक मिथ है ना कि नेचुरल है तो ये सेफ भी होंगे, ऐसा नहीं है। नेचुरल मटेरियल्स भी डेंजरस हो सकते हैं, बल्कि वो जो क्या कहते हैं खारिश बूटी भी एक जैसे होती है, किसी को अगर खारिश लगानी हो तो उसको बूटी मल देते हैं, वो फिर बेचारा खारिश ही करता रहता है। ठीक है, तो इस तरह की बहुत सी ऐसी नेचुरल मटेरियल्स हैं विच आर नॉट गुड फॉर द ह्यूमन यूज। सो की इंग्रेडिएंट्स एंड सेफ्टी कंसर्न्स, जैसे मैंने कहा प्रिजर्वेटिव में पैराबेन्स हैं, दे आर ऑब्सलीट नाउ। इसमें कुछ पैराबेन्स ऐसे हैं जिसको सेव किया, मिथाइल पैराबिन और इस तरह की चीजें हैं जो कि एज ए प्रिजर्वेटिव कॉस्मेटिक्स में यूज होती हैं, लेकिन ऑल पैराबेन्स आर नॉट सेफ। सो यू हैव टू बी केयरफुल कि जब आप यूज करें तो आपको पता होना चाहिए कि इनमें से मेजॉरिटी पैराबेन्स जो हैं दे आर बैन्ड नाउ। सिमिलरली फॉर्मेल्डिहाइड रिलीजर्स, ये भी एक फिनिश प्रोडक्ट के अंदर जो है, इफ इट गोज मोर देन 0.5% तो इट बिकम्स डेंजरस। हैवी मेटल्स इज वेरी कॉमन फॉर यू। मर्करी जो है, इट वाज बीइंग टॉक ऑफ द टाउन के लिए अब मर्करी प्रोडक्ट्स को बैन किया हुआ है कि कोई भी ऐसी कॉस्मेटिक प्रोडक्ट्स जिसमें मर्करी होगी दैट कैन नॉट बी यूटिलाइज्ड बिकॉज कार्सिनोजेनिक। फ्रेग्रेंस अ कॉमन सोर्स ऑफ एलर्जिक रिएक्शंस, जो कि कॉन्टैक्ट डर्मेटाइटिस के हवाले से आता है। मैं इसको अभी अब स्किप कर रहा हूँ क्योंकि ये सारी चीज़ें जो हैं दीज आर एकेडमिक्स के कॉन्टेक्स्ट में है, ये आपने को पढ़नी चाहिए क्योंकि इसकी साइंस जो है दैट इज़ मोर इम्पोर्टेंट। कि ये जैसे पैराबिन्स हैं, ये क्यों ये खतरनाक हो जाती हैं, बिकॉज इट मिमिक्स द एस्ट्रोजेंस। इसके जो केमिकल स्ट्रक्चर्स हैं ये उसके रिसेप्टर्स पे जाके करते हैं और दे कैन मिमिक लाइक हार्मोन्स, तो इसलिए इनको ये बड़ा एहतियात से यूज़ करना पड़ता है। हैवी मेटल्स के अंदर हमें सबको पता है लेड, आर्सेनिक, मर्करी, इन सब की ये लिमिटेशंस हैं कि जब कि आप किस लिमिटेशन से ज़्यादा यूज़ नहीं कर सकते। फ्रेग्रेंस को हम इसलिए ब्लैक बॉक्स कहते हैं कि जी फ्रेग्रेंस का पता ही नहीं चलता कि आपने जो इसेंस उसका जो ऑर्डर जो आपने लेके आए हैं वो अगर नेचुरल है तो उस नेचुरल की आपकी टेस्टिंग हुई हुई भी है कि नहीं। सो इट हैज़ टू बी अ ब्लैक बॉक्स मैजिक इन टर्म्स ऑफ फ्रेग्रेंस। जो नए रूल्स आ रहे हैं वो भी मैं आपको बताता हूँ फ्रेमवर्क के अंदर जो अब इस वक्त रेगुलेटरी, मैंने क्यों कहा है कि एक रेगुलेटरी कंसर्न है। ये अब क्यों कर रहे हैं, हम पहले क्यों नहीं किया था। पहले एक प्रोडक्ट थी, ये फ्रेग्रेंस थी, जो लिली, ये बेस थी लिलियक उसके नाम से। इट इट वाज इन द मार्केट फॉर 40 years, लेकिन क्योंकि जब रूल्स और रेगुलेशंस चेंज हुई और उस फ्रेमवर्क में जब उसको देखा गया तो इट बिकम्स डेंजरस और उसको बैन कर दिया गया। तो अब चीजें जो हैं उस नए फ्रेमवर्क के तहत देखी जाती हैं और इसलिए इंतहाई जरूरी है कि आप जब भी इस प्रोडक्ट के कॉन्टेक्स्ट में, जब भी कॉस्मेटिक्स के हवाले से करें, तो जो रेगुलेटरी फ्रेमवर्क्स हैं उसको आपने इग्नोर नहीं करना। So common toxic ingredients in cosmetics are the parabens, phthalates, which enhance the flexibility और particularly वो जो nail polishes हैं उसके अंदर ये बहुत ज़्यादा यूज़ किए जाते हैं। Formaldehyde, ये shampoos में आपका जो है SLS बहुत यूज़ होते हैं, which are dangerous for the skin और ये irritation cause करते हैं। Fragrances and toluene. But these are the main common ingredients which are being used in the cosmetics, so you have to be careful. Now, regulatory framework. What is this regulatory framework? Agar if you are interested in the business of cosmetics, you should understand the regulatory framework. वो ये क्या कहते हैं, there is no excuse to law. कि आप ये नहीं कह सकते कि मुझे पता नहीं था या इस कानून का मुझे नहीं पता था, because law has no excuses. You have to be compliant with the regulatory framework. जो भी उस मुल्क के अंदर regulatory framework है, you have to be very very careful regarding those regulatory framework. अब इसमें ये यूरोपियन यूनियन और यूनाइटेड स्टेट्स, अब ये यूरोपियन यूनियन की एक अपने रेगुलेटरी कंट्रोल्स हैं और यूएस एफडीए के अपने हैं। दोनों में एक बड़ा मेजर फर्क है। यूरोपियन यूनियन रेगुलेशंस कहती है कि आपको पहले सेफ्टी ऑफ द मटेरियल्स एस्टैब्लिश करना है और फिर प्रोडक्ट मार्केट ऑथराइजेशन होनी है, जबकि यूएस एफडीए कहता है कि नहीं जी, आप प्रोडक्ट्स ले आए और अगर कहीं एस्टैब्लिश हो गया कि वो प्रोडक्ट हार्मफुल है तो वो विड्रॉ कर ली जाएगी, वो रिकॉल कर ली जाएगी। तो दोनों में ये मेजर फर्क है। और हमारे यहाँ भी अभी बहुत सी चीजें आ रही हैं। ये जो ये पीफास है, फॉरएवर केमिकल्स में, पीफास इज द पॉलीफ्लोराइड अल्काइल सब्सटेंसेस। ये तकरीबन हर कॉस्मेटिक्स के अंदर डलती है, विच इज नॉट रिकमेंडेड नाउ। अब जो लीगल फ्रेमवर्क्स हैं उसमें इनको ये जो है ना, ये रिस्ट्रिक्ट किया गया कि इनका यूज कम से कम हो। ये एक्ट आपको पता होना चाहिए। पाकिस्तान में इस वक्त अब अथॉरिटी है पाकिस्तान जनरल कॉस्मेटिक रेगुलेशन अथॉरिटी, ठीक है। अब पहले तो जिसका दिल करता था वो जनाब वो घोलता था मटेरियल्स और उसको पैक किया और सेल कर दिया। नाउ देयर इज एन अथॉरिटी, 2023 में ये अथॉरिटी इस्टेब्लिश हुई और इसी 2023 अथॉरिटी के जो है ये एक जो कॉस्मेटिक एक्ट है उसके अंदर ये अथॉरिटी डेवलप हुई है। So now there is an act which regulate the general cosmetics. Cosmeceuticals को आज भी ड्रैप देखता है, लेकिन जो जनरल कॉस्मेटिक्स है उसको ये कॉस्मेटिक एक्ट 2023 वो एक्सप्लेन करता है, और जो अथॉरिटी इसको रेगुलेट करती है दैट इज पीजीसीआर। नाउ द सेफ्टी असेसमेंट प्रोसेस, कि आपकी रेगुलेटरी सारी चीजें मुकम्मल हो गई। नाउ द पॉइंट इज कि जी अब आपकी जो है सेफ्टी असेसमेंट प्रोसेस भी आपको पता होना चाहिए कि जी उसमें क्या क्या चीज़ों को हमने असेस करना है। उसके अंदर इंपॉर्टेंट जो है इंग्रेडिएंट कैरेक्टराइजेशन है, विच इज नॉर्मली वी डू इन एवरीथिंग, कि जो भी इंग्रेडिएंट यूज करना है वी गो फॉर द कैरेक्टराइजेशन, टॉक्सिकोलॉजिकल प्रोफाइल, एक्सपोजर असेसमेंट एंड मार्जिन ऑफ सेफ्टी। ये दो एडिशनल चीजें हैं जो कॉस्मेटिक प्रोडक्ट्स में की जाती हैं, कि आप उसका एक्सपोजर जो है कि वो क्योंकि बहुत माइन्यूट होता है बट द फ्रीक्वेंसी इज वेरी वेरी मोर देन कन्वेंशनल प्रोडक्ट, तो उसकी आपको एक्सपोजर असेसमेंट करनी पड़ती है। ये बेस्ड ऑन द रिंस ऑफ एंड लीव ऑन, के कुछ प्रोडक्ट्स ऐसी हैं जो आप अप्लाई करते हैं और रिंस कर देते हैं, और कुछ होते हैं कि वो अप्लाई किए रखते हैं, जैसे सनस्क्रीन है वो आप अप्लाई रखते हैं, उसको आप जब तक आप एक्सपोज हो रहे हैं उसको यू हैव टू अप्लाई ऑन द स्किन। और कुछ रिंस और फेस वॉश है या दूसरी चीजें ये आप अप्लाई करते हैं एंड देन यू रिंस इट। तो उसकी दोनों की एक्सपोजर कैलकुलेशंस का डिफरेंस है, उसको अभी हम उस पर नहीं जाते, लेकिन दे कैन बी कैलकुलेटेड। फिर एनालिटिकल टेस्टिंग है, वो कन्वेंशनल इंस्ट्रूमेंट्स हैं जिससे आप करते हैं। इन विट्रो में नॉन एनिमल, अब ये एक बड़ी, क्योंकि जो वेस्ट है वो एनिमल टेस्टिंग को ये डिस्करेज करता है, और उसके अगेंस्ट उन्होंने सिमुलेशंस डेवलप कर दिए हैं, कुछ उन्होंने इन विट्रो मॉडल्स डेवलप कर दिए हैं दैट यू कैन टेस्ट योर प्रोडक्ट ऑन दोज इन विवो मॉडल्स और इन विट्रो मॉडल्स। क्लिनिकल टेस्टिंग स्टिल इज वन ऑफ द लास्ट रिजॉर्ट जिसके अंदर हम उसको करते हैं, और that is imperative for a new product to be in the market. अच्छा, अब ये भी इंपॉर्टेंट है कि जी जो और एक पार्ट है, आपने मैन्युफैक्चर भी कर लिया, आपने लीगल फ्रेमवर्क में रहते हुए भी उसको देख लिया, लेकिन अब उसकी जो एक एंड यूजर है विच इज द कंज्यूमर, उसको इंफॉर्मेशन भी पहुंचानी है कि उसको पता लगे। इफ यू राइट एक्वा ऑन द प्रोडक्ट तो एक कॉमन मैन को समझ नहीं आनी कि ये एक्वा क्या है, बट इफ यू राइट वाटर बेस तो उसको समझ आएगी। तो यू हैव टू डीकोड दी पैकेजिंग नॉर्म्स ऑफ द कॉस्मेटिक्स, कि ताकि जनरल लेमैन को भी अंडरस्टैंडिंग हो कि आपकी प्रोडक्ट में क्या क्या चीजें मौजूद हैं। स्टैंडर्डाइजेशन और ये मैंडेटरी लेबल एलिमेंट्स, ये तमाम चीजें जो आपकी प्रोडक्ट के ऊपर होनी चाहिए। और सबसे इंपॉर्टेंट जो चीज है एट द एंड ऑफ द डे इज द क्लेम, कि आप जो क्लेम कर रहे हैं दैट इज अंडर लॉ। अगर आप कहते हैं कि जी ये एक्नी ठीक करती है तो उसको एक्नी ठीक करनी चाहिए। अगर आप कहते हैं जी ये फ्रैकल्स को रिमूव करती है तो उसको करना चाहिए, क्योंकि दैट इज अंडर लॉ। कि जी अगर आप जो क्लेम करते हैं और अगर वो उस क्लेम का एविडेंस नहीं है अब आपके पास, तो दैट कैन बी कंट्रोल, और मुख्तलिफ जो रेगुलेटरी बॉडीज हैं उसको वो देखती हैं। जैसे एक और चीज जो इसमें हमने कहा कि आप लिखते हैं कि जी ये पैराबिन फ्री है, तो इट हैज टू बी पैराबिन फ्री, क्योंकि ये आपका क्लेम है। या आप क्लेम कहते हैं इट्स हर्बल, तो इट मीन इसको हर्बल होना चाहिए। So, in conclusion, a safe cosmetic is the result of partnership between rigorous science, strict government oversight, and informed consumer choices. तो ये तीनों कंपोनेंट्स जो हैं जब ये आपस में इंटीग्रेट करते हैं तो यू कैन डेवलप अ क्वालिटी प्रोडक्ट, और उसकी मार्केट जो है वो एक अच्छे तरीके से बन जाती है। और इस वक्त जो ये इंटरनेशनल हार्मोनाइजेशन भी चल रही है कि तमाम चीज़ों को हार्मोनाइज किया जाए, ताकि एक सेट ऑफ डोमेन की चीज़ें जब दूसरी कंट्री में जाएं तो उनकी भी अंडरस्टैंडिंग वही हो जो उसके कंट्री ऑफ ओरिजिन में है. So at the end of the presentation, I'll again दिखाना चाहता हूं ये कि ये बहुत बड़ी मार्केट है. It's time to come into this market. और आप में से जो बच्चे अगर इस तरफ आना चाहते हैं, ठीक है, वो अपने राब्ता करें अपने जो भी मेंटोर्स हैं. और ये वी कैन क्रिएट ये, क्योंकि मैं इस वक्त एक दो ये बोर्ड्स का ये मेंबर हूँ, तो इट्स माय अटमोस्ट डिज़ायर कि हमारे बच्चे जो हैं, जो थोड़ा सा अपने अंदर ये एक रखते हैं, एक एम्बिशन रखते हैं, so they can come forward, submit your proposal with the with your subject in charge. क्योंकि मैं तो मिस सना को ज़्यादा जानता हूँ, तो आप मिस सना से ही कह दीजिएगा, ठीक है. तो इंशाल्लाह we'll be in a position to arrange some angels for funding as well. ठीक है. आप में से जो लोग अच्छा काम करना चाहते हैं कॉस्मेटिक इंडस्ट्री के कॉन्टेक्स्ट में, अगर वो अपने प्रोजेक्ट्स बनाएं, submit to Miss Sana, or we will send them to the funders. और उनमें से अगर किसी ने उसको ऑप्ट करता है तो they can actually give you funding for the project as well. तो उसमें we will be able to facilitate you inshallah ta'ala. So thank you very much for your kind listening and patient listening. So God bless you all.
Thank you, Professor, for your outstanding presentation and valuable contribution. Next, I request Dr. Ikramullah Khan, also co-chair of today's session and associate professor and head of the Department of Pharmaceutics at Government College, University, Faisalabad. His research focuses on microfluidics, responsive drug delivery system, and physical pharmacy. He will be presenting on current trends and innovative technologies for the management of cutaneous wounds. Kindly join me in welcoming Dr. Ikramullah Khan.
Assalamu alaikum and good afternoon to everyone. First of all, I'm really thankful to the moderator of this session for a nice and a detailed introduction. And then I'm really thankful to the University of the Faisalabad, the Department of Dermal Sciences, and the Department of Pharmacy for inviting me on this conference. I have been visiting this conference for the last 3 years, and I can see this conference is constantly improving. It is very well organized. And one of the important thing that I can see is that there are a large number of undergraduate students as well. And they are also very well disciplined and well organized as well. अब मुझे ये अब मुझे ये अंदाजा नहीं है कि ये अपनी मर्जी से यहाँ पे बैठे हैं या फिर डॉक्टर सना या आपके हेड ऑफ डिपार्टमेंट की वजह से यहाँ पे बैठे हैं. मर्जी से बैठे हैं. आवाज नहीं आ रही, इसका मतलब है. अच्छा बेटे, वे बैक जब मैं ग्रेजुएट स्टूडेंट था तो हमें कभी भी इस किस्म की इंटरनेशनल कॉन्फ्रेंसेस का एक्सपोजर नहीं था. This is very good on the part of the University of the Faisalabad कि वो अपने स्टूडेंट को इस किस्म का एक्सपोजर दे रहे हैं. किसी बंदे ने कहा था कि अगर आप बहुत सी किताबें बहुत शॉर्ट टाइम के अंदर पढ़ना चाहते हैं तो आप कॉन्फ्रेंसेस अटेंड करें. ठीक है, तो यहाँ पे जो कॉन्फ्रेंसेस में बहुत शॉर्ट टाइम की प्रेजेंटेशंस दी जाती हैं तो वो यूजुअली किसी भी रिसर्चर का या स्टूडेंट का वर्क होता है जो उसने 1 साल 2 साल में किया होता है. तो आपको बहुत अच्छी कंक्लूजन्स और फाइंडिंग्स मिल रही होती हैं. अब डॉक्टर आतिफ रजा साहब हैं, ये मेरे टीचर भी हैं. इन्होंने जो 10-15 मिनट में दिया, ये इनके पूरे कैरियर का निचोड़ है आपके सामने. तो आप इन कॉन्फ्रेंसेस को जितना अटेंटिवली आप अटेंड करेंगे, आप लोगों के लिए बहुत ज़्यादा फायदा होगा. Anyhow, coming to my topic, which is current trends and innovative technology for the management of wounds. तो आपकी यहाँ पे जो कुछ आपके स्टूडेंट्स हैं, आपके जो टीचर्स हैं, डॉक्टर सना है, डॉक्टर आयशा हैं, डॉक्टर नाइला है, दे हैव कंप्लीटेड देयर डिग्रीज अंडर माय सुपरविजन, और उनका काम भी इसी वुंड हीलिंग के ऊपर ही था। तो सबसे पहले देखते हैं व्हाट इज अ स्किन। स्किन आपके बॉडी का लार्जेस्ट ऑर्गन है जो मल्टीपल फंक्शंस परफॉर्म करता है, जो यहाँ पे मेंशन है। ठीक है, ये हमारी बॉडी को प्रोटेक्शन प्रोवाइड करता है। एक्सटर्नल जो थ्रेट्स हैं, माइक्रोब्स हैं, केमिकल्स हैं, टॉक्सिन्स हैं, उनसे प्रिवेंट करता है। टेम्परेचर रेगुलेशन के अंदर काम करता है। सबसे इंपॉर्टेंटली इट एक्ट्स एज अ सेंसरी ऑर्गन। ये कुरान के अंदर भी मेंशन है कि व्हेन देयर स्किन्स आर रोस्टेड दे विल बी रिप्लेस्ड। ठीक है, तो उसके बाद ये कि ये जो स्किन है हमारा एक प्रोटेक्टिव बैरियर है, और ये प्रोटेक्टिव बैरियर कब ब्रीच होता है? व्हेन वी आर एक्सपोज टू एनी काइंड ऑफ एक्सीडेंट्स, बर्न्स, या किसी डिजीज में, जैसे कि अल्सर है या बेड सोर्स वगैरह है। तो वर्ल्ड वाइड ये जो जो मैनेजमेंट है वुंड की, वो बहुत ज्यादा क्रिटिकल है। अगर आप इसको प्रॉपरली मैनेज नहीं कर पाते, देन द एक्सपेंसेस कुड बी हायर और द स्टेक्स कुड बी हायर। Often untreated wounds could lead to amputation as well in severe cases. तो हमारे पास जो ट्रेडिशनल आपके पास ऑप्शंस हैं, वो आपके पास सिंपल बैंडेजेस, ऑइंटमेंट्स, क्रीम्स हैं, जिनकी बहुत ज्यादा लिमिटेशंस, देयर आर सेवरल लिमिटेशंस। ठीक है, तो ये लिमिटेशंस की वजह से वी आर मूविंग टुवर्ड न्यू ट्रेंड्स, और उन न्यू ट्रेंड्स के अंदर जो ज्यादातर जिन पे मैं फोकस करूंगा वो आपके हैं हाइड्रोजेल फिल्म्स हैं और कंपोजिट जेल्स हैं। इसके अलावा माइक्रो नीडल्स भी हैं, नैनो पार्टिकल्स भी हैं, नैनो फाइबर्स भी हैं। First of all, let us understand what are the hydrogels. Hydrogels आपके 3-dimensional cross-link structure है that can absorb large quantity of exudates or the liquids without dissolving. ठीक है, अब ये जो आपके हाइड्रोजेल पैचेस हैं या फिल्म्स हैं, ये डिफरेंट काइंड्स ऑफ वुंड के अंदर आप लोग इनके ट्रीटमेंट के लिए यूज कर सकते हैं, बट दे हैव देयर ऑन इनहेरेंट ड्रॉबैक्स। वो इनहेरेंट ड्रॉबैक्स क्या है मैकेनिकली? क्योंकि आपका हाइड्रोजेल पैच अगर फिल्म देखेंगे, दे आर वेरी थिन, सो दे आर मैकेनिकली वीक, और थिन स्ट्रक्चर होने की वजह से इनके अंदर आप लोग मल्टीपल इंग्रेडिएंट्स को इनकॉर्पोरेट नहीं कर सकते। यू कैन नॉट इनकॉर्पोरेट दैट। सो व्हाट इज द सोल्यूशन? तो सोल्यूशन है बायलेयर की तरफ आप जाए। बायलेयर जो आपके पास पैचेस है, उनकी कुछ कैरेक्टरिस्टिक मैंने यहाँ पे मेंशन किए। वो कैरेक्टरिस्टिक्स क्या है? दे मिमिक योर स्किन। जैसे हमारे स्किन है, स्किन की मल्टीपल लेयर्स है, तो आप अगर मल्टीपल जो लेयर्स आप या फिल्म्स यूज करोगे, दे विल बी मोर बेनिफिशियल। मैकेनिकली वो बहुत ज्यादा स्ट्रांग होंगे एज कंपेयर टू द सिंगल फिल्म्स। ठीक है, इसी तरह फिर आप इनको मल्टी फंक्शनल बना सकते हो। एक लेयर के अंदर आप एक कंपोनेंट डालें, सेकंड लेयर के अंदर सेकंड कंपोनेंट आप लोग ऐड कर सकते हो। अपनी फिल्म्स को मल्टी फंक्शनल आप लोग बना सकते हैं। ठीक है, इसी तरह आपके ये जो बेटर प्रोटेक्शन प्रोवाइड करेगी, बेटर प्रोटेक्टिव बैरियर प्रोवाइड करते हैं एज कंपेयर टू द सिंगल लेयर्स। उसके बाद ये देखा गया कि एज कंपेयर टू द सिंगल लेयर, जो एक स्कारिंग का इश्यू हमारे साथ सिंगल लेयर्स के साथ या जनरली ऑइंटमेंट क्रीम के साथ आता है, वो मल्टीपल लेयर के साथ नहीं आता, क्योंकि वहां पे बेटर आपकी कोलेजन की डेपोजिशन आपकी होती है इन केस ऑफ द मल्टीपल लेयर्स में। ठीक है, तो इसी तरह ये जो आपके ये बाइलेयर्स हैं, दे प्रोवाइड अ बेटर माइक्रो इन्वायरमेंट, जिसके अंदर क्या है, द ऑक्सीजन फ्लो है, फिर इसी तरह मॉइस्चर प्रेजेंस है, जिसकी वजह से वूंड हील ज्यादा बेहतर तौर पे आपका होता है। अब ये एक प्रोजेक्ट है जो मेरी एक एमफिल के स्टूडेंट ने कंप्लीट किया था, वेयर वी डेवलप्ड अ बाइलेयर पैच। अब इस बाइलेयर पैच के अंदर जो सस्टेन रिलीज लेयर है, उसके अंदर आपके पास एक एसेंशियल ऑयल है, बर्गेमोट ऑयल है। ठीक है, और दूसरे जो आपके पास इन विट्रो और इन विवो कैरेक्टराइज किया। ठीक है, और ये जो आपका प्रोजेक्ट था हमारा, ये आपके इंटरनेशनल ये फार्मास्यूटिक्स जर्नल है, इसके अंदर पब्लिश हुआ, जिसके अंदर जिसका इम्पैक्ट फैक्टर अराउंड 5.5 था। अच्छा, इसके इनिशियली कुछ मेथडोलॉजी को देख लेते हैं कि इसको हमने बनाया कैसे, हाउ वी मेक इट। तो इसके लिए सिंपल मेथड है, डबल कास्टिंग मेथड है। तो डबल कास्टिंग मेथड के थ्रू आप हम लोगों ने इसको डेवलप किया। फर्स्ट वी डेवलप द सस्टेन रिलीज लेयर which was made by using sodium alginate and the essential oil. ठीक है, जब ये क्रॉस लिंक हो गया देन वी कास्टेड द इमीडिएट लेयर, और इमीडिएट लेयर के अंदर क्या था, HPMC और HEC था और प्लस ओफ्लॉक्सासिन। फाइनली इसको एयर ड्राई किया और जो आपके पास फाइनली प्रिपेयर्ड लेयर है इसको फर्दर कैरेक्टराइज हम लोगों ने किया। ठीक है, ब्रीफली अब ये कुछ आपको जो स्टेप बाय स्टेप के आपके पास जो डिफरेंट लेयर है इनके अंदर कौन कौन से कंपोनेंट थे और कैसे हम लोगों ने इसको फॉर्मुलेट किया। तो फर्स्ट वन आप देखेंगे ये आपके पास प्राइमरी लेयर है जो सस्टेन रिलीज लेयर है। इसके अंदर हम लोगों ने इनिशियली वी टेस्टेड 3 डिफरेंट काइंड ऑफ ऑयल्स। तो उसमें से जो सबसे इफेक्टिव था ये बर्गमट ऑयल था। ठीक है, और उसके बाद ये जो आपके पास सेकेंडरी लेयर है, सेकेंडरी लेयर के अंदर अंदर भी हम लोगों ने ड्रग को यूज किया, और ये जो ड्रग थी 3 डिफरेंट लेवल्स के अंदर। जैसे कि सर ने आपको बताया था कि बहुत सी चीजें हम लोग प्री फॉर्मुलेशन लेवल पे मल्टीपल टेस्टिंग करते हैं। जैसे ऑयल्स को मल्टीपल लेवल्स पे टेस्ट किया, यहाँ पे आप लोगों ने ड्रग को भी मल्टीपल लेवल्स के अंदर या मल्टीपल कंसंट्रेशंस के अंदर हम लोगों ने टेस्ट किया। और उसके बाद ये आपके पास एक ऑप्टिमाइज आपके पास बाइलेयर फॉर्मुलेशन हम लोगों ने बनाई, जिसमें हम लोगों ने ऑप्टिमाइज कंसंट्रेशन ऑफ द ऑयल और ऑप्टिमाइज कंसंट्रेशन ऑफ द ड्रग हम लोगों ने ऐड की उसके अंदर। और उसके अंदर ये हमारी 4 डिफरेंट फॉर्मुलेशंस बनाई थी। एक ब्लैंक फॉर्मुलेशन, सेकंड वन वाज फॉर्मुलेशन व्हिच कंटेन्स ओनली bergamot ऑयल, और दूसरी जिसके अंदर सिर्फ आपके पास ड्रग प्रेजेंट थी, और लास्ट वन जिसके अंदर कॉम्बिनेशन आपका प्रेजेंट था। और ये कुछ उनकी करेक्टराइजेशन है। फर्स्ट वन वाज प्री फॉर्मुलेशन में वेट वेरिएशन एंड द थिकनेस, एंड वी ऑब्जर्व दैट as the concentration of the oil and drug was increased, the weight and the thickness of the films also increase. ठीक है, उसके बाद ये मोस्ट इंपॉर्टेंटली फॉर द हाइड्रोजेल मेम्ब्रेन द स्वेलिंग इज वेरी इंपॉर्टेंट। In case of the swelling experiment, we found that as the oil concentration increased, the swelling decreased. आपके जो सबसे ज्यादा स्वेलिंग दे रही थी वो आपके ब्लैंक फॉर्मुलेशंस आपके थी। तो रीजन बिहाइंड इट इज दैट एसेंशियल ऑयल आर हाइड्रोफोबिक इन नेचर। तो हाइड्रोफोबिसिटी की वजह से वो ज्यादा वाटर को इनग्रेस होने नहीं देते, या आपकी जो हाइड्रोजेल मेम्ब्रेन है इट कैन नॉट एब्जॉर्ब लार्ज क्वांटिटी ऑफ द वाटर इन दैट। उसके बाद इट इज वेरी इंपॉर्टेंट बिकॉज वी आर यूजिंग देम फॉर वुंड एप्लीकेशन, इट शुड शो एन एंटीबैक्टीरियल इफेक्ट। तमाम फॉर्मुलेशन को एंटीबैक्टीरियल इफेक्ट इसका चेक किए गए। 2 डिफरेंट स्ट्रेन्स किए गए जो कॉमन ग्राम पॉजिटिव और ग्राम नेगेटिव कॉमनली वुंड्स के अंदर प्रेजेंट होती हैं। तो उसमें से जो सबसे ज्यादा हमारी ऑप्टिमाइज्ड फॉर्मुलेशन थी, जैसे यहाँ पे D2 है जिसके अंदर आपके पास ड्रग आपके पास 5% ड्रग थी, और दूसरी जो नीचे फिल्म में से बर्गमट ऑयल जिसके अंदर 25% ऑयल था, वो हम लोगों ने सिलेक्ट की ऑप्टिमाइज हुआ। और उसके बाद बेटा वन ऑफ द इम्पॉर्टेंट प्रॉपर्टी विच इज रिक्वायर्ड फॉर अ फॉर्मुलेशन टू हील अ वुंड इज द एंटीऑक्सीडेंट एक्टिविटी। जितनी ज्यादा एंटीऑक्सीडेंट एक्टिविटी वो शो करेगा, वहां पे आप वुंड के अंदर स्ट्रेस लेवल उतना ही रिड्यूस होगा। ठीक है, तो हम लोगों ने यहाँ पे ऑब्जर्व किया कि प्योर कंपाउंड एंड आफ्टर इनकैप्सुलेशन द एंटीऑक्सीडेंट एक्टिविटी वाज कंपैरेबल। That means our process which we adopted to make this bilayer film, they haven't affected the activity of our oil, encapsulated oil. So based on the various parameters, आपकी जो formulation D2 और B2 थी, इनको combine करके हम लोगों ने bilayer patch develop किया। ठीक है, एंड देन
का हो गया फेस अपनी नौकर गई थी
हम लोग
ये
जो
मैं
आपके
नीचे
पास
खड़ा
फॉर्मुलेशन
तीन
इंग्रेडिएंट है
छलांग
और
मारी
जो
हमने
आपके
मेरे
एक्टिव
ऊपर ये
इंग्रेडिएंट इनके दरमियान कंपैटिबिलिटी को
चार
चेक
उनसे
check the
उनसे
compatibility, we used
अब वो
FTIR.
बेचारे भाई ने कि वो समझ रहे हैं
FTIR indicated that there is no interaction between the encapsulated oil, drug, and the components. Next, to confirm that whether this bilayer patch have been developed or not. तो आप यहाँ पे फिगर में देख सकते हैं एक टॉपिकल व्यू है, एक क्रॉस सेक्शनल व्यू है। टॉपिकल व्यू में नजर आ रहा है कि जो आपके पास सिंपल ब्लैंक फिल्म थी देवर मच स्मूथ। जैसे जैसे इनका ड्रग या कोई और कंपोनेंट ऐड होता गया दे बिकम लिटिल बिट रफर। और लोअर साइड पे आप देख रहे हैं कि वो आपके क्रॉस सेक्शन है। इन क्रॉस सेक्शन यू कैन क्लियरली सी द 2 लेयर्स। ठीक है, और इनमें यह है कि जो ब्लैंक लेयर ब्लैंक फिल्म थी दे इट वाज मोर कॉम्पैक्ट, but as the oil and the drug was added, it gives some porosity which indicates that the oil or the drug have been entrapped inside that. उसके बाद then we carried out the drug and the oil release, and it was found that from the single layer as well as the bilayer, the ofloxacin was released immediately, but the oil was released in a sustained release pattern. Finally, we came to wound healing studies where these different formulations were applied to rat wounds. And we found that the optimized formulation, which contains ofloxacin and the oil in optimum concentration, it was able to contract the wound almost 100% within 12 days. Then where there is a wound, there is an inflammation. And inflammation can be detected by using various markers. Like here we have used interleukin-6 and TNF-alpha. And you can see that in the final stages, when the study was completed, the levels were comparable with the normal. That means that inflammation have been reduced. Then skin texture was checked by using two different techniques, H&E staining and Mesenchymal. Here also, the optimized formulation showed a better skin architecture in case of our optimized formulation, that is epidermis, skin appendages, hair follicles, etc. And this next slide is about the mesenteric staining, which shows the more intense, and the blue color shows that the high deposition of the collagen fibers. And in case of the optimized formulation, this concentration was high. Hey, just as the time is very short, so I will just briefly tell you about another project which is completed by my PhD student, and this project is also funded by HEC. Here we develop composite gels. For developing these composite gels, first we developed the lipid-based nanoparticles that contains two type of oils, clove oil and then the Capris spinosa seed oil. These lipid particles were dispersed in gel structure along with the free ofloxacin. So here you can see this is the composition of four different formulations of the lipid. That first one was blank, and then second one only contains clove oil, third one contains only Capris oil, and the last one contains the combination of these two oils. And this project is also published, and it is published in Journal of Drug Delivery Science and Technology. So finally, these lipid particles were dispersed in a gel structure, and then they were carried out in a wound healing study. We carried out wound healing studies in the rats. Here we also found that the optimized formulation that contains our optimized nanoparticles plus ofloxacin, it was able to contract the wound very fast as compared to the control and the other groups. And inflammatory markers also support our studies. That is two of them, that is TNF-alpha and interleukin-6 as well. So coming to the conclusion, both bilayer films were successfully developed for extended release of oil and immediate release of ofloxacin. Lipid nanoparticles were successfully prepared in optimum size, range, and later incorporated into the gel. Inflammatory markers such as TNF-alpha, interleukin-6 were substantially decreased in serum of the rat treated with optimized formulation, that is SH3 in case of films and GP5 in case of the composite gel. Regeneration of connective tissues and epithelium provided evidence of healing potential of the bilayer films and composite gel. Hence, it is concluded that novel bilayer patch and composite gels could be used for the treatment of cutaneous wounds. So thank you very much for your kind attention. जैसे कि सर ने एक मेरे बाद में सर जहन आ रही थी कि आपने कहा कि एआई को बहुत ज्यादा यूज किया जा रहा है आजकल, तो यहाँ पे ये वुंड हीलिंग के अंदर भी अब लोग एआई को बहुत ज्यादा यूज कर रहे हैं, स्पेशली आपके जो क्रॉनिक वुंड्स हैं जो हील प्रॉपरली नहीं होते, उनकी प्रॉपर मॉनिटरिंग के लिए आप एआई को यूज कर सकते हैं। जो उनके इमेजेस हैं, इमेजेस आप लेंगे और उनको प्रोसेस करेंगे, और एआई जो आपके टूल्स हैं वो आपको बताते जाएंगे कि इसमें आपकी प्रोग्रेस कितनी है, कितनी सिग्निफिकेंट आपकी प्रोग्रेस आपकी ट्रीटमेंट के साथ आ रही है। सो थैंक यू वेरी मच फॉर योर काइंड अटेंशन। इफ देयर इज एनी क्वेश्चन यू कैन आस्क। थैंक यू वेरी मच।
Thank you, Dr. Ikramullah Khan, for your highly informative and thought provoking presentation. Now we have Dr. Syed Haroon virtually with us, Associate Professor at Government College, University, Faisalabad. He is a specialist in pharmaceutical sciences with extensive research experience in pharmaceutics and pharmaceutical technology. He will be presenting on design and optimization of curcumin-based nanoemulsion with glucosamine sulfate for improved topical delivery and wound healing. Due to some technical issues, we are not able to take them with us virtually. Now I'm giving the stage to my fellow Seher Fatima.
Good, Good afternoon, everyone. I'm Sahar Fatima, IT head for the Society of Skincare, and I'm pleased to continue with scientific session 2 of the 5th International Conference on Dermal Sciences. Without further delay, let us proceed. Now I'm pleased to invite Professor Dr. Sadia Rafiq. Professor Dr. Sadia Rafiq is an associate professor and head of Department of Pharmacy at the University of Faisalabad. She holds a PhD in pharmaceutics from the Islamia University of Bahawalpur and has 12 years of academic and research experience. She is an HEC approved supervisor and has contributed extensively to pharmaceutical sciences through her research, publications, and postgraduate supervision. Her talk title is Formulation and Evaluation of Herbal-based Nanogels for Wound Healing Application. I request Professor Dr. Sadia Rafiq to kindly come on stage and deliver her presentation.
Assalamu alaikum. Rabbi shrah li sadri wa yassir li amri wahlul uqdatam min lisani yafqahu qawli. I am no associate professor, currently not professor. Thank you very much for giving me honor. Today I am going to present nanoparticles or nanomaterials which will be used in wound healing. These are three types of materials which I am going to discuss: marine biomaterials, fruit-based, and green technology materials. These are the contents of my presentations. First of all, I will discuss the abstract and introduction, research objectives, methodology, and novelty, conclusion, and future perspectives. First of all, wound healing is a complex biological process involving inflammation, proliferation, and remodeling phases. Nanotechnology combined with marine biomaterials and fruit-derived nanomaterials often advanced therapeutic strategies. The safety and effectiveness of nanomaterials depends on further investigations into their design interaction with biological systems and the results of rigorous preclinical and clinical trials. Basically, the nanotechnology enables targeted drug delivery, antimicrobial action, and tissue regenerations and marine and plant-based green nanomaterials improve safety and sustainability. These were the objectives of our study. And recently, bioactive flavonoids containing rutin, diosmin, and hesperidin improve microcirculations and wound repair. Why we have chosen nanomaterials? These are best in because these are targeted drug delivery systems. These are controlled release formulations, and these are used for skin repair and tissue regenerations. They have play a major role, and for chronic wound managements and antimicrobial therapies, and for the advanced wound dressings, these are used. But there are certain challenges which we have to face in the chronic inflammation. If the inflammation is the chronic type of wound healing, and oxidative stress and biofilms also are the major challenging role in this type of formulations, and impaired fibroblast activity and ECM degradations. If we talk about the stages of wound healing, there are 4 stages: hemostasis, inflammation, proliferation, and remodeling. Each phase involves coordination, cellular and molecular events. The research objectives of the study are the formulation development of hybrid nanogels and biocompatibility studies and enhanced skin rejuvenation effects and wound healing, which was our ultimate target. There are 3 types of materials which we have used. Type 1 are the marine biomaterials. Sources were algae, fish, and sponges and crustaceans. The major components were used: collagen, chitosan, alginate, and functions. Their main used for the functioning of the antimicrobial activity for angiogenesis and ECM regenerations. Type 2 were the fruit-based nanomaterials, in which avocado, kiwi, and lemon extracts were used. They were rich in flavonoids, antioxidants, and vitamins A, C, and vitamin E. Enhanced collagen synthesis and reduced oxidative stress. Type 3 bioactive flavonoids contain rutin, diosmin, and hesperidin. They have major role in anti-inflammatory effects, antioxidant, and immunotonic effects, which is the tightening, strengthening, and increasing tone of skin wall veins, and improve microcirculations and wound repair. The marine biomaterials from algae, fish, sponges, and crustaceans enhance wound healing through multiple-step biological actions. They produce hemostasis, anti-inflammatory effect, antimicrobial effect, cell proliferation, angiogenesis, ECM remodeling, and drug delivery support. They play major role in all the stages of wound healing. And fruit-based nanomaterials are derived from natural fruits: citrus, kiwi, avocado, pomegranate, banana, and apple. And their bioactive compounds formulated at the nanoscale, they enhance wound healing through multiple mechanisms. They have strong antioxidant activity. Avocado or kiwi have more than 80% of antioxidant activity through DPPH method. And they also shows effect in anti-inflammatory effects, antimicrobial cell proliferation and migration, and collagen synthesis, angiogenesis, and nanocarrier functions. They play a major role. Hybrid nanoplatform form the marine biomaterials and fruit materials and flavonoids were combined. They produce the synergistic effect: control, release, stability, infection control. In organic nanomaterials, for example, the silver nanoparticles were formulated. The source of silver nanoparticles is the neem, aloe vera, green tea, E. coli, algae, and fungi. And gold nanoparticle source is aloe vera, tulsi, pseudomonas aeruginosa, Aspergillus niger, and brown algae. Zinc oxide, the major source of zinc oxide nanoparticles are the lemon, seaweed, marine algae, and copper nanoparticles. Main source is the neem, algae, and marine animals. Titanium dioxide, main source are the coconut, fungi, and silicon dioxide nanoparticles were obtained from the rice husk, sugarcane, and shells of marine animals. The nanoparticles silver, gold, zinc oxide, copper, titanium dioxide, and silicon dioxides are synthesized using plant extract microorganisms and marine species, enabling eco-friendly green synthesis for biomedical wound healing applications. Polymeric nanoparticles, the chitosan, PLGA, alginate-based systems are highly effective because They provide controlled drug release, they enhance stability of bioactive compounds, improve wound penetrations, and show antimicrobial activity, especially chitosan-based system, reduce infection risks, promote cell proliferation, maintain moist wound environment, and enable targeted therapy. But in the case of lipid-based nanocarriers are used, they can be formulated in the form of liposome, solid lipid nanoparticles, targeted drug delivery, and sustained release. And they also produce antimicrobial activity, inflammation, modulations, angiogenesis, ECM, remodeling, and controlled drug delivery system. The nanocomposites in the form of scaffolds provide 3D structure for cell growth, enhance angiogenesis and collagen depositions, and improve mechanical strength. But the formulations of bio-nanogel combines marine polymers, plant fruit extracts, and nanoparticles into a single wound healing system. Hybrid bio-nanogels offer a sustainable, multifunctional approach for faster and more effective wound healing. The novelty of this study is the integrations of nanotechnology with marine and fruit-dried biomaterials in a single therapeutic approach, green synthesis of nanomaterials using eco-friendly plant and marine sources, dual functionality, combining antimicrobial activity with tissue regenerations, dual functionality, combining antimicrobial with tissue regenerations and targeted delivery system for site-specific wound treatment and enhanced biocompatibility, sustainable release, multi-phase healing support, and use of natural bioactive materials, and improve efficacy in chronic and hard-to-heal wounds. Translational potential towards advanced wound dressings and clinical applications. These are the conclusions of the study. Marine-dried biomaterials provide biocompatible and regenerative supports, while plant or fruit-based nanomaterials offer eco-friendly and sustainable therapeutic options. Nanosystems exhibit strong antimicrobial, anti-inflammatory properties, improve tissue regenerations, and faster healing outcomes compared to conventional dosage form. The future perspectives of this study are the smart nanomaterials. These are real-time monitoring of wound healing, combination therapies, antimicrobial and growth factors, and integration with tissue engineering, scaffolds, hydrogels, and nanofibers, eco-friendly and sustainable green technology in the base of fruit extracts, plant materials, marine biomaterial utilizations, and immune modulations, more in vivo and clinical trials, and interdisciplinary research in the form of pharmacology, nanotechnology, and genetic engineering play a major role in the future. Thank you. If you have any question, then you can ask me now. Otherwise, thank you very much.
Thank you, Dr. Sadia Rafiq, for that thought-provoking presentation. It was truly insightful. We now move towards our next speaker. I'm pleased to invite Dr. Naila Ijaz. Dr. Naila Ijaz is an assistant professor in the Department of Pharmacy at the University of Faisalabad. Her research interests include interpenetrating network hydrogels, drug delivery systems, and polymeric systems. She has multiple scientific publications to her credit and has taught various courses. Her talk title is Transferring Wound Care Management from Bandages to Bites. I request Professor Dr. Naila Ijaz to kindly come on stage and share her valuable insights.
Assalamu alaikum. Thank you very much, ICDS 2026 team, for inviting me. Talk of the today is transforming wound care management from bandages to bites. First of all, you all should know that what are the wounds? Wounds are disruptions to the structure and function of tissues in the human skin. Every year, many people worldwide suffer from various tissue injuries, which includes the skin wounds, muscle injuries, corneal wounds, cardiac injuries, as well as lung damages. Corneal wound affects almost 6.5 million patients in the US alone. So this conventional wound care burdens the community in many different ways, such as fail to maintain the optimal moisture balance, a lot of minimal antimicrobial infection risk. Frequent changes may disrupt the healing process, and no real-time feedback monitoring are associated with conventional wound care drug delivery system, as well as it also burdenizes the economic impact. And lastly, a single dressing type cannot address the diverse needs across the wound healing system. These are different wound healing phases. Current practices in wound management include the focus on systematic approach to assess, treat, and monitor wounds. Then individual assessment, which is based on the type, which is based on the size and depth of the wound. Then assessment of primary care and any risk factor associated with the wound care. Historical background comes from the use of honey, bandages, then hydrogels, alginate-based, and then advanced care of the advanced care hydrogel system. So we will discuss one by one. The first one is the microneedles and microspheres. These are the dissolving microneedles or hydrogels microneedle patch, or you can say this is the combination of microneedles and microsphere patch, which are used in the moist wound delivery, which are used in the local drug delivery also. After that, nanocarriers, nanofibers, and solid lipid nanoparticles. These are different types of these nanocarriers, included liposomal nanocarriers, polymeric nanocarriers, solid lipid nanoparticles, electron spun nanofibers, and nanohydrogel composites. These are used with the combination of different types of polymers and have applications in encapsulating the hydrophilic and hydrophobic drugs, biodegradable, or which is used in enhanced skin penetration. There is a lot of work ongoing on the hydrogel system. These are some of the latest paper of 2025, which are publishing the latest trends for the management of wounds. First of all, the self-oxygenating, anti-freezing, antioxidant, and UV-resistant lignin hydrogels for wound healing at high altitudes. As you all know, at high altitudes, there is very less chances to treat the wounds, or wound healing process is very low, which is due to the low oxygen species and low reactive oxygen species and high temperature. So the dual responsive anti-freezing hydrogels are developed, which are composed of dopamine modified calcium peroxides nanoparticles with lignin and polyacrylamide. So these dual responsive anti-freezing with high temperature hydrogels used for the wound healing process at high altitudes level where the conventional hydrogel systems are not working. So they have promising solution for wound care in high altitude setting. Then dynamic covalent hydrogels for wound healing process are research is ongoing on dynamic hydrogel wound healing process, where the dead space between the wound bed and dressing is the major factor which may reduce the process of wound healing. So to minimize the dead space between the wound bed and its dressing is the need of the hour, which is fulfilling with the dynamic covalent hydrogels for wound healing. And this has the applications in shape adaptability, stimuli responsiveness, self-healing capability, and antibacterial properties. Lastly, self-powered thermoelectric hydrogel accelerates wound healing. The wound healing process is electric wound healing process is the self-defense mechanism, but in case of the diabetic wounds, the self-healing mechanism is reduced, which may lessens or which may decrease the wound healing process. But with the combination of silver gelatin, methacrylate, thermoelectric hydrogels, we may increase this self-defense mechanism of wound healing. After that, latest foam drug delivery system is used. These are also the latest researches, which is the rapid synthesis of degradable ester thioester monomers with the incorporation into thermoset polyurethane foams. So they have significantly improved the bleeding control in the traumatic wounds. After that, a 3-layer foam with thermal management performance for hemorrhage control and wound healing are under study in 3 layers. The first, the hydrophobic layer, and then the last one is the thermostatic layer, and inner layer is releases the drug and treat the wounds. So after that, there are various AI integrated techniques are under study, which may increase the wound healing process, and they are the great breakthrough in the wound management. These techniques may include the wound imaging and assessment, healing prediction, robotic assisted therapy, and smart dressing. So if we talk about the image processing technique, so we can use the AI technique for taking the images of the wounds, and these images can easily detect the depth of the wound. It can easily detect the length of the wound, or you can say nature of the wound, and it will lead towards the a great healing process in the wound management. After that, smart bandages. These smart bandages these are the bioelectronic system with wireless powdered closed loop sensing stimulation circuits. These smart bandages will continuously monitor the wound healing process with the skin resistance or temperature, or deliver electric stimulation, which may show the continuous process of the wound management. After that, computer stimulation is the very latest technique, which included finite element, or you can say computational fluid dynamics. These techniques are used to improve the prototype before it goes to the market. These are used to check how dressings behave under different physiological conditions without needing to stimulate with the real world setting. So these are very latest techniques. These are used to detect unexpected performance issues, point to exudate leakage or mechanical failure to the dressing, loosening of the adhesion of the dressing to the skin, and over adhesion long before materials, and these are used before reaching to the clinical trials. So that are some latest AI-oriented research papers which may be used for the wound management. So, conclusively, the field of wound care has undergone a profound transformation from passive linen bandages to the intelligent, multifunctional AI-oriented systems, which may be changed from the normal conventional drug delivery system to specifically AI-driven image analysis or computer stimulation. The future lies in personalized, closed loop or regenerative wound care ecosystem that address the full complexity of chronic wound pathophysiology. Thank you so much.
Thank you, Dr. Naila Ijaz, for such an educational and engaging presentation. Now, I am pleased to call upon our next speaker, Dr. Maham Ashraf. Dr. Maham Ashraf is a lecturer in the Department of Pharmacy at the University of Faisalabad. Her research interests include nanoparticles and nutraceuticals. Dr. Maham Ashraf has received several awards for her academic excellence, including a bronze medal for securing third position in her Doctor of Pharmacy program. Her talk title is Role of Nanoparticles in Diabetic Wound Management. I request Dr. Maham Ashraf to kindly come on stage and deliver her presentation.
Assalamu alaikum to all of you. Firstly, I would like to say thanks to the ICD organizing committee for giving me an opportunity of hearing. So today the topic of my presentation is role of nanotechnology or nanoparticles in diabetic wound management, current advances and future perspectives. So firstly, we will discuss the contents of the topic, which includes firstly the introduction. Then we will discuss the type of nanoparticles, nanoparticle-based drug delivery system strategies, smart wound dressing incorporating the nanoparticles, challenges which are we facing in the clinical translation of these nanoparticles, and lastly, the future directions and the conclusions. So firstly, we will discuss the burden of the diabetic foot ulcers, 463 million patients worldwide, rising with the aging demographics. Clinical consequences include the non-healing wounds, neuropathic pain, increased amputation risk. Healing impairment, chronic hyperglycemia disrupt all phases of normal wound repair and economic impact. For the students, which are majority of the students are here from undergrad, for your understanding, the topic basically is about the diabetic wounds. You have seen in our surroundings that number of patients are suffering from the diabetes, and a small scar can lead to a larger wound or the non-healing wound because of immense pathophysiology involved in the diabetes. Pathophysiology of diabetic include these 10 different things because there is a hyperglycemia which involves obviously low healing, then the vascular dysfunction is there, chronic inflammation is there, impaired nerve impulses or the neuropathy is also a major problem, and simultaneously the last thing is the wounds never heals or heals very lately. Okay? So this is the limitations of the conventional therapies, the normal wound dressings, and the promise of nanotechnology that it could be served for the targeted delivery, controlled release, and multifunctional action. We will discuss the types of nanoparticles in journal, that we have silver nanoparticles, gold nanoparticles, zinc oxide, serum nanoparticles, and the Persian blue nanoparticles, which are used for their antibacterial, anti-inflammatory, antioxidant potential, and radical oxygen scavenging action. Polymeric and lipid-based nanoparticles are also served as a potential for wound healing. First one, the chitosan nanoparticles, PLGA nanoparticles, solid lipid nanoparticles, liposomes, or gallocatagen silver nanoparticles. These nanoparticles also show a potential for anti-inflammatory effects. Also, they carry the drugs or the growth factors. Then the nanoparticle-based drug delivery strategies include the nanoparticles are basically used as a carrier for carrying the various drugs, including the antimicrobial drugs or the growth factors. And next, we will discuss about the smart wound dressing incorporating the nanoparticles, in which the nanoparticle are doped hydrogels, which help in the angiogenesis, radical oxygen removal, or mitochondrial function. Second one is the electrospun nanofiber scaffolds, chitosan-coated nanoparticle dressings, multifunctional nanocomposite scaffolds, and gallocatagen nanoparticles, which help in the inflammation control process. They can start the angiogenesis and ultimately the wound healing. Lastly, we will discuss a case study from a recent research conducted in 2026, which carrying a trifunctional nanoparticle platform containing the heme BSA nanoenzyme core, BFGF payload, and pH responsive magnesium sulfide shell, which demonstrates the three-step involved in the wound healing, the inflammatory control, vascular regeneration, and the tissue restoration. These are the challenges in the clinical translation, which include biocompatibility and toxicity, stability, scale-up manufacturing, drug loading efficiency, wound microenvironment complexity, and regulatory pathways. Emerging research frontiers could be this. And lastly, we will conclude this topic that nanoparticle-based strategies represent the transformative paradigm shift in the diabetic wound management, and smart wound dressing incorporating the stimuli-responsive nanoparticles further advance the field toward the precision and the wound management. Thank you very much. If you have any questions, you can ask.
I'm Dr. Cyrus Slim. I want to ask one question.
Yes, please.
I'm professor of surgery and head department of breast surgery at Medina Teaching Hospital. So my question is that I have learned I have seen very impressive presentations about nanoparticle delivery, drug delivery system. So what about the cost and availability of these preparations?
Okay, ma'am. Thank you very much for the question. Actually, nanoparticles are still under research, as I have already discussed in the challenges, that these things need a bit time and a lot of clinical gap is there. Clinical studies need to be conducted further to incorporate these nanoparticles in the clinical practice or clinical use, you can say. As I already discussed one of the slides where there is a trifunctional nanoparticles, but still they are under research. These are the research papers we are presenting here based on the clinical preclinical trial data, not the clinical trials are there. I
So
hope the question is clear.
we can't use this on our patients with diabetic foot complex wounds.
Ma'am, currently we are conducting the researches. The
Okay.
clinical trials needed to be done further to carry these dressings and these drug delivery systems to the human population.
Okay, thank you.
Thank you. Thank you so much.
Thank you, Dr. Muhammad Ashraf, for such an amazing presentation. We now proceed to our next speaker, Dr. Razia Kausar. Dr. Razia Kausar is a distinguished academic researcher serving as Associate Professor and Chairperson of the Department of Anatomy at the University of Agriculture, Faisalabad. She holds a PhD in anatomy and has made significant contributions to the scientific community with over 60 peer-reviewed research publications in esteemed national and international journals. Her talk title is Elucidating the Comparative Therapeutic Potential of Copper Nanoparticles and Polymyxin B, a histological analysis of skin wound healing in Vista rat. I request Professor Dr. Razia Kausar to kindly start her presentation.
Okay,
Ma'am,
Assalamu alaikum. Yes, I can.
we are kindly running a little bit short on time, so can you keep it like to 10 to 15 minutes?
Okay,
Thank you so
okay. I
much.
will. You will share my or I will share my presentation. Okay, Bismillahirrahmanirrahim. First of all, good evening because क्या अब evening ही हो गई है. So the topic of my presentation is copper nanoparticles, which enhance tissue regeneration and accelerate skin wound. Wound. Most of the I was listening the rest of the presentations and they all talk about the wound healing. So my presentation is also, but my work is based on preclinical research that my students have performed this research in their MPhil studies. So the problem is that skin wound healing is a complex multi-stage process and the chronic wound fail to heal within 6 weeks, so leading to serious complications, prolonged hospitalization and sustainable healthcare costs. So the current therapy limitations is traditional treatments focus primarily on disinfection and wound management, but don't actively promote tissue regeneration or accelerate the healing cascade. So what is the clinical need to perform this? It is an innovative therapies are required that both prevent infection and stimulate active tissue repair through angiogenesis, collagen deposition, and reepithelialization. So why we choose the copper nanoparticles? First of all, what is the study objectives to elucidate the therapeutic potential of copper nanoparticles on skin wound healing through histological and biochemical assessment and to determine the rate of wound healing, which means that contraction rate and healing time as compared to the standard treatments. To compare the effect of copper nanoparticles versus polymyxin B on tissue regeneration and functional recovery. So copper nanoparticles, they have demonstrated known as antimicrobial properties, their comparative efficacy in promoting full thickness tissue regeneration versus standard polymyxin requires further investigation on controlled animal models. So in vivo wound healing model, we use for 24 male Vista rats were used, which are divided into treatment groups and 8 rats per groups.
Then wound, we create the wound 10 mm full thickness skin wound created on the dorsal region using sterile biopsy punch. And then topical application was applied twice daily for 28 days with photographic demonstration. एंड इसके साथ साथ ये ऐसे भी किया कि हमने उसको वूंड को उसकी मेजरमेंट भी ली, उसकी थिकनेस भी ली, ठीक है। और फिर हमने जो उसके ग्रुप्स बनाए, फर्स्ट ग्रुप नो ट्रीटमेंट, वी जस्ट लीव दैट वूंड, and then T1 we applied polymyxin, and group 2 we applied copper nanoparticles. So what is the physiochemical properties of synthesized copper nanoparticles? Their chemical, I think I skipped this slide because it have no such. Now these copper nanoparticles, they show broad spectrum antibacterial effects which are done in our microbiological lab. So after that, the copper nanoparticles, they improve the wound hydration, color, and scar formation, and we all measure these parameters in the wound hydration score, then wound color score, and then wound scar score. So the interpretation of these use of these copper nanoparticles, polymyxin B, and control group. By day 25, the copper nanoparticle group achieved 90% wound contraction, which is significantly faster than the control, in which it shows 40%, and then approaching the rate of polymyxin B treatment. A copper nanoparticle treatments resulted in better tissue quality and reducing scars compared to antibiotic only therapy, demonstrating dual antimicrobial and regeneration properties. Then the next step is that we also produce stronger, more elastic healed skin copper nanoparticles, and this is measured with tensile strength analysis. And it also shows that the group which was treated with copper nanoparticles, they show the more strength as compared to the other two groups. And now promote copper nanoparticles, they also promote true tissue regeneration. Reepithelialization means complete thick, no epidermis was normal, satisfaction, then granulation tissue, well-formed tissues with abundant fibroblast and organized matrix, and neovascularization, abundant new capillaries and venules of demonstrating angiogenesis. So reduced, you can say that conclusion is that copper nanoparticles, they induce regeneration of the skin appendages and matrix, not just wound closure but also regeneration of the tissue. So the key conclusions are that copper nanoparticles are successfully synthesized and exhibit potent antibacterial activity, and they accelerate the wound closure, and improve the quality of the healing, means regenerated skin shows superior tensile strength, elasticity, and histological architecture. And they are safe for topical use with no detectable synthetic toxicity in liver or kidney function. And they can control and match or suppress polymyxin in certain regeneration parameters like new vascularization, scar, and quality. Now, future perspective and clinical translation. Next step for research is combination therapy to investigate the synergistic effect of copper nanoparticles and polymyxin B, then their delivery system in hydrogels or nanofibers or sustained controlled release. Chronic wound models test efficacy in diabetic or infected wound models. And then mechanistic studies elucidate the precise molecular pathway role of copper to ions of specific growth patterns. So in my clinical potential, we can say that it is a novel cost-effective wound dressings for acute and chronic wounds, and they also reduce the reliance on systemic antibiotics, thereby combating and antimicrobial resistance, which is the most prevalent, most you can say a hot topic of the days. So I I acknowledged this study to Auric and Department of Fiber Textile Technology, all co-authors and lab staffs. And one thing which I want to add that my other student, he also work on diabetes induced. We induced diabetes first in rats, and then we applied copper, silver, and gold nanoparticles on and they give very much effective healing process and very quick recovery. Dr. Saira Slim is asking about their formulations. Same, we have to done this work on large scale, and then from the drap we have to you can say कि ड्रैप से हमें इसको सबको जो है अपनी जितनी भी हम करते हैं इसको करवाना पड़ेगा. सो ये बहुत इफेक्टिव होती है, कॉस्ट इफेक्टिव भी है, और ये इजीली अवेलेबल भी है एज कंपेयर टू द पोलीमैगजीन. जब हमने उसकी और उसकी दोनों की कॉस्ट को हमने चेक किया था, बिकॉज माय 3 स्टूडेंट्स आर वर्किंग ऑन दिस, on diabetes wound healing and on simple wound healing. So it is very cost effective. So need is more, which I have already told you in the gap, research gap. So welcome. Thank you so much.
Thank you, Ma'am Razia Kausar. It was truly a thoughtful and insightful presentation. Moving ahead, I am going to introduce Dr. Faisal Usman. Dr. Faisal Usman is an assistant professor in the Department of Pharmaceutics at Bahauddin Zakria University in Multan, Pakistan. He holds a PhD from Prince of Sokla University, Thailand, and has research interests in aerosols drug delivery, topical drug delivery, and antifungal therapies. His talk title is Xantham Gum Guagum Loaded Silver Sulfadiazine Hydrogel Films for Wound Healing. I request Dr. Faisal Usman to kindly start his presentation.
बिस्मिल्लाहिर्रहमानिर्रहीम. थैंक यू फॉर योर काइंड इंट्रोडक्शन. मैं पहले एक आंसर करूंगा. अभी एक क्वेश्चन
Sir,
वगैरह
I
था.
am going to interrupt you a bit. We are running kind of short on time, so you'll only be given 10 minutes. Thank you so much.
श्योर. बहुत सारी प्रोडक्ट्स ऐसी कौन की अवेलेबल हैं जो कि डायबिटिक फूड के लिए यूज की जा रही हैं. दे आर अवेलेबल इन द मार्केट. So you can search for that. और उसकी basic theory या mechanism यही है. Okay. Coming to my topic, my talk of discussion is xanthan gum gargum loaded sulfadiazine hydrogel films of wound healing. ठीक है. Generally, अगर हम
Excuse me, sir. You have joined from 2 places. Can you mute the mic of one, please? Thank you so much. Sir, kindly unmute one place and mute the other one.
Okay. Okay, if we come towards the wound, we can classify it into 4 classes. Okay, and the classification is based on the time of occurrence, appearance, as well as thickness of the wounds. If we look towards the process of remodeling of the skin, it starts from hemostasis followed by inflammation, repair, and remodeling of the skin. There are a lot of microorganisms that affect wound, especially the burn wounds. That may include gram-positive bacteria, especially the issue nowadays is MRSA strains, as well as gram-negative bacteria, some fungi, as well as viruses. Now, if we look towards the transdermal drug delivery system, it has a lot of benefits. So more focus nowadays is on developing hydrogels or polymeric films that can modulate the process of wound healing. So a lot of benefits you can see like that are associated with transdermal drug delivery system. And a lot of topical antibiotics are available as well. One is very famous, like quench cream, you all have heard of that is used in emergency conditions if you get like burn injury or something like that. So we use that silver sulfadiazine, that is the part of that quench cream, and we formulate it into the hydrogel matrix. This is basically a silver salt of sulfadiazine, and it is a broad spectrum antibiotic that has activity against both gram-positive as well as gram-negative bacteria. A lot of factors are important if we look towards the process of wound healing. That can be some local factor as well as systemic factor. In systemic factors, immunocompromised conditions are very important, as well as the medication history of the patient. Whereas in local factor, infection and foreign bodies, they are extremely important. If we look towards the wound dressing, a lot of things affect it, especially the pH, the humidity present, the particulate matter that is available or not, gaseous exchanges. A lot of factors are important. 2 basic gums were used. One is xanthane gum. You can see structure. It's basically a hydrophilic macromolecule heteropolysaccharide, and it's obtained from gram-negative plant pathogenic bacteria, Xanthomonas campestris. It's soluble in water, whitish in powder. And the basic advantage of using this gum is that it is biodegradable as well as biocompatible. If we look towards the second gum, that is gar gum, it is a non-ionic hydrophilic polysaccharide, and it contains mannose and galactose sugars, and it is also obtained from the seeds of leguminous plant Synopsis tetragonolobus, and it is also biodegradable. So both have that advantage that they are biodegradable. So if we look towards the objective of study, we have four basic objective. One was to formulate our hydrogel formulation using sulfadiazine as API with the aid of xanthine gum and gar gum. Second was is microbiological testing, then cell lines, and then in vivo studies. This is the formulation table we used. We used xanthine gum in 1% concentration. Gar gum was used from 0.7 to 1.2%. Silver sulfidazine was used 1%, and borax was used as cross linker from 3 to 7%, as well as glycerol that was 5 ml. This is basic scheme of manufacturing. You can see like both the gums were dissolved, there were aqueous dispersion, and the mixture was heated and stirred at 40 degree. Then sulfur sulfidazine was incorporated in ammonia solution. Then cross-linking was carried out using the borax, and the final hydrogel were dried in the oven at 40 degree for 48 hours. If we see the results, the most important thing for gum is swelling, because we call it as a hydrogel. So swelling is most important. The swelling actually indicates the drug release pattern through the polymer fluid and drug interaction. So structural changes normally occur, especially during the swelling process, because the polymeric chain of hydrogel film uptakes the fluid, and it controls strong diffusion and water penetration due to hydrophilic nature of the polymer. You can see like the swelling in most of formulation is very good and more than 90%. We use two optimized formulation on the base of their physical and chemical properties and stability issues. And if we see like some of this film, you can see like it's a smooth film indicating the aggregation, and it is somewhat like a porous structure. This porous structure will help in liberating the drug release in a sustained fashion, because when it will come in contact with water, it will swell the matrix and the drug will release in a sustained fashion. In vitro permeation was carried out using transdiffusion cell for both the optimized formulations, and it resulted in about 30 to 40% release in 10-12 hours, and overall release after 48 hours was about 70%. The release data was also fitted in pharmacokinetic models. Different models were used, and Hikichi model was found like the best model on the base of release data. Antibacterial antibacterial activity was the second basic purpose, because I told you that a lot of bacteria act at the wound side, especially gram-positive and gram-negative. So we studied against Staph aureus, epidermidis, and Pseudomonas. And you can see like the zone of inhibition was better than the control that was used in the formulation. And all the optimized formulation gave the zone about more than like 20 mm, that indicates good sensitivity. Third was like doing cell line studies. In cell line, actually, we see like that our formulation is non-toxic to the cells of our skin. So for that, we go for HACAT and BJ cells. We use raw cell lines, RAW264.7, and also we did migration capability, percent migration rate. If you see like here, the MTT assay, in case of optimized formulation, the cell count was almost near 100%, that indicate very little damage to the cells, indicating the safety of the formulations against raw and HACAT BJ cell lines. Second was the scratch assay that is normally carried out on keratinocyte and fibroblast. In this, we scratch the cell line by a sterile pipette, and then we apply a formulation. You can see like that in case of our formulation, that was almost a complete closure after 48 hours, whereas in case of the market product, the gap was very large. That indicate the formulation was better in performance than the market or control. Fourth was like the clinical studies on experimental animals, we use Sprague-Dawley rats. These are the conditions that were used. 1 centimeter patch was applied on the skin of the experimental animals, and they were anesthetized using pentobarbital sodium. This is the sequence of events of 14-day studies on the animals. We use 2 formulations along with a positive control and a negative control. In positive control, we use market formulation, and in negative control, we use blank gel. You can see like in case of a formulation, we see about maximum wound healing occurring in 11th and 12 days, whereas in case of control, 100% wound healing wasn't observed even after 14 days. So you can see like when we are using the gums as a matrix for delivering the drug, it increased the wound healing as well. This is the wound size measurement or morphological evaluation graph. The wound contraction, you can see like in our formulation, it was almost 100% wound contraction after 14 to 28 days, whereas in case of market product, it was about 90 to 95%. In case of histopathology studies was also carried out. The histopathological studies represent the complete re-epithelialization and reduction in wound dimensions. Some variations were observed in scar formation and tissue remodeling. The control and blank groups also had some inflammatory cells, edema, and dilated blood vessels, whereas the animal group treated with our formulation showed disrupted epidermidis with underlying edema, sebaceous glands, and a marked number of hair follicles. The wound treated with our formulation resulting with focal areas of increased thickness observed in the dermis. So definitely that also increased the wound healing that was also confirmed in histopathological studies. If you see like the conclusion of the talk, the formulation developed, they were stable with high swelling index. No interactions were observed using FTR studies. Cytotoxic studies showed the safety of formulation against HACAD, BJ, and raw cell lines. Inflammatory mediator also confirmed the healing of the wounds, whereas in vitro wound healing was also superiorly observed in the cell line. Equichi release kinetics was observed in the release data, and efficacy and safety was also observed in the rat skin. And complete wound healing process was observed within 14 days with desired outcomes. And non-healing and inflammatory wound markers also were lower in case of formulation. We can say like that if we use this drug using natural gum as a carrier, it can modulate the process of wound healing, decrease the toxicity, and increase and can also decrease the rate of infections at the wound site. Thank you very much for your listening. If any question, you can ask. Thank you.
Thank you so much, sir, for your thought-provoking presentation. Now I'm pleased to invite Dr. Sana Shehzad. Dr. Sana Shehzad is an assistant professor in the Department of Pharmacy at the University of Faisalabad. She brings over 15 years of teaching experience and is widely regarded as an expert in her field, with multiple research publications to her credit, reflecting her strong contribution to academic and scientific advancement. Her talk title is Modulatory Inflammatory Microenvironment Alpha-Mangostin Hydrogel Film for Accelerated Open Closure.
Assalamu alaikum. I will not take your much of time because you are already from the session 1 you are learning about that. What is this wound? Various presenters that presented here the very efficiently the wounds, their environment, and even the Dr. Sadia Rafiq presented the phases as well, that what are the phases that are involved in this all the wound process. I will just tell you about my experience in your thematic area, the wound management and skin repair, by giving you the information about my PhD and the published work, that the natural extracts, they are not only the traditional remedies. You learn that aloe vera is a traditional remedy. Alpha mangosteen I'm going to present today, but it's not too much time here, that it's a traditional remedy. Actually, these natural extracts, they have their scientific values. They have their scientific options that you can use for your thematic area, for wound healing as well as for the skin repair. By using the natural extracts, when you start your journey, you may say that you have to see about their antioxidant, anti-inflammatory, and antimicrobial properties as well. Then you have to pass through the different testing that's presented here, the different in vitro and in vivo testing. Here you can see all these, that how I extract, what the methodology is used that is discussed, then the different tests are performed, and different hydrogel films we produce by using this natural extract, that is the alpha mangosteen. And again, after all these testing, after all the SAM-XRD, the animal study, the histopathological studies, we conclude that this is the last, that when we presented the posture. And again, from my presentation, I will come to the conclusion that you can use these natural remedies for the scientific transformations, that they can helpful for the wound management as well as for the wound healing. Thank you.
Thank you, Dr. Sana Shehzad. Now I invite our next speaker, Dr. Sana Javed. Dr. Sana Javed is an assistant professor in the Department of Pharmacy at the University of Faisalabad. She has completed her PhD in pharmacology and her postdoctoral research from Germany. Over 10 years of experience, her research focuses on pharmaceutical sciences, particularly in the areas of pharmacology, immunology, immunotherapy, molecular and cellular mechanisms, inflammation, and disease models. Her talk title is Bridging Efficacy and Resistance in Immunomodulatory Approaches to Wound Healing and Cutaneous Repair. I request Dr. Sana Javed to kindly come on stage and deliver her presentation.
Assalamu alaikum. I'm Dr. Sana Javed. Thank you for the opportunity to present at the ICDC Conference 2026. As we are running out of time, I will briefly talk about the bridging efficacy and resistance in immunomodulatory approaches to wound healing and cutaneous repair. So during this session, we talk a lot about the wound and also what are the treatments we can use to treat the wounds. So my focus is mainly on the chronic wounds. In case of the acute wound, it goes to the inflammation and then healing and remodeling. But in case of chronic wound, there is excessive MPPs accumulation as well as decreased growth factors and cell migration, which can also lead towards the inflammation and infection. And the process is stuck in the inflammation phase. That's why it is difficult to treat, and it leads to also causes the resistance to the available therapies. So in persistent inflammation, actually there is dominance of M1 macrophages, which do not convert to M2 phase, as well as there is excessive accumulation of TNF alpha and IL-1 beta. There's also high levels of MPPs, which causes the tissue damage. The other major cause that leads towards the resistance is the formation of the biofilms by the bacteria. During the infection, the biofilms make the defensive process, which that's why there is no antibiotic or other treatments are effective. Or there is also the reactive oxygen species accumulation, which leads towards the worsening or the chronic inflammation. So to deal with this chronic inflammation, we can focus on macrophage polarization, the conversion of M1 to M2, innovative biomaterials, which we have Dr. Ikramullah as well as Dr. Sana Shehzad talked about the hydrogels. We can also focus on the microneedle arrays like enhanced drug delivery as well as improved bioavailability of the available therapies. And we can also lead towards the gene treatments and mRNA techniques. We can also improve or overcome the resistance by antimicrobial peptides, which breaks the biofilms and help to manage or kill the bacteria. So with this, I will conclude my presentation. So we can treat the persistent inflammation or chronic wound healing by restoring balance and using the biomaterial design. Thank you very much. If you have any questions, I will be happy to take them. Thank you.
Thank you so much, ma'am. Now we are going to introduce Dr. Syed Haroon, who is an associate professor at Government College University, Faisalabad. His talk title is going to be Development and Evolution of Herbal-Based Nanogels for Wound Healing Applications.
Bismillahirrahmanirrahim. Good afternoon, everyone. I'm Dr. Syed Harun Khalid, working as an associate professor in Department of Pharmaceutics, Government College University, Faisalabad. So I'm very thankful to the organizers of the 5th International Dermal Conference, especially Dr. Shana Shahzad, who invited me again for this honorable conference. So today I'm going to present my work on the curcumin-based nanoemulgent system with glucosamine sulfate for wound healing. So this study basically focuses on improving topical drug delivery and therapeutic efficacy. So background of this basically is that when you are going to use the curcumin orally, it is going to degrade rapidly. So the topical route, so in spite of using the oral route, topical route is an effective alternative to oral and parenteral delivery. So it can avoid the first pass metabolism and GIT side effects. It is easy to apply and provides localized action. So, and however, drug penetration through skin remains a challenge. So the model drug I'm going to use is a curcumin. So what is curcumin? So curcumin is basically a BCS class 4 drug with poor solubility and permeability. It has an excellent pharmacological activities like anti-inflammatory and wound healing, but its clinical use is limited due to its poor bioavailability. So we need an advanced drug delivery system to improve both these properties of this curcumin. So the next active additive that I added in this nanoemulgel is glucosamine sulfate. Because glucosamine sulfate, why we need to add in this? Because in my opinion, we think that glucosamine can support the wound healing activity of curcumin synergistically. As glucosamine sulfate is a natural compound that is present in the connective tissues. It plays an important role in tissue repair and regeneration. It also has anti-inflammatory and wound healing properties. So at the end, when we are going to combine this with the curcumin, it may provide a synergistic effect as well. So the major issues, the problem statement of this project was basically the poor solubility and stability of curcumin. Because of its rapid degradation, it can reduce its effectiveness. So skin penetration is limited as well. So targeted delivery to the wound site is very difficult. So what to do now? At this stage, we need an advanced nano drug delivery system like nanoemulgel that can enhance the solubility, stability, and penetration of the curcumin. The objective of this present study were, the basically aim was to develop a first. Okay. So how we have to prepare the nanoemulsion system, because the optimized nanoemulsion formulation we took, and then after this, we have to prepare the gel phase as well. For this, the combination with the glucosamine enhanced wound healing system is effective for the topical delivery of the hydrophobic drugs. So as you can see, the optimized formulation demonstrated the superior in vitro and in vivo performance. So it is also a promising strategy for advanced topical drug delivery for clinical trials as well. Thank you so much. At the end, I'm very thankful again for the organizers of this Dermal conference. I'm unable to attend physically, so hope to see you next time physically for attending this conference, inshallah. Thank you. Thank you so much.
Thank you so much, sir. We now conclude.
Bismillahirrahmanirrahim. Good afternoon.
We now conclude Scientific Session 2, Pharmacological Frontiers in Wound Healing and Tissue Regeneration. Now, I'd like to invite the chair of this session, Dr. Atif Raza, to kindly come on the mic and share their remarks about the presentations.
Right, ji. Bismillahirrahmanirrahim. Let me first congratulate the organizers for organizing such a wonderful and successful conference today. And the session we have witnessed is definitely, I'm very convinced and like to appreciate the organizers that the quality of the presenter and the work they have presented is marvelous. And because I have been for quite a few years a regular participant of this conference, and I can well imagine that the way this conference has now emerged as one of the leading conferences, especially in this part of the world, is that eminent scholars, not only from Pakistan, but rather international speakers, they are now being preferably presenting their work at this conference. So I congratulate once again the organizers for organizing this very fruitful and very knowledgeable conference here at University of Faisalabad. As far as the speakers are concerned, there is no doubt that every speaker has not only presented a very thoughtful and new information to the participant, but the quality I would like to mention here, that the quality and the paper presented here, that was definitely they are of international standards, and we have learned a lot from their experiences and their research work. So once again, because the number of presenters were here, so it's very difficult to conclude. But whatever I would like to conclude here, that the pharmaceutical sciences with pharmacological sciences, now they are being integrated in such a way that this is the platform where the researchers can meet and can develop new knowledge as well as new product to the healing community, particularly in this wound healing segment. So my congratulations to all of the presenters, and thanks a lot to everyone for being here and being a part of this such a wonderful gathering. Thank you very much once again.
Thank you, sir, for your valuable remarks. We now proceed to the souvenir distribution ceremony, where we acknowledge and appreciate the valuable contributions of our esteemed speakers and respected session leadership. I request Dr. Sadia Rafiq, Dr. Rabia Mahmood, our session chair, Dr. Atif Raza, and our session co-chair, Dr. Ikramullah Khan, to kindly come on the stage to distribute the souvenirs to the speakers. We will begin the souvenir distribution ceremony with our distinguished speakers. I request Professor Dr. Muhammad Ishfaq to kindly come on stage and receive his souvenir. We acknowledge his insightful contribution to this session. Now I request Dr. Naila Ijaz to kindly come on stage and receive her souvenir. We sincerely appreciate her valuable research and engaging presentation. Now I request Dr. Sadia Rafiq to kindly receive her souvenir. We acknowledge her significant contribution and insightful presentation. Next one. Now I request Dr. Maham Ashraf to kindly receive her souvenir. We acknowledge her informative contribution and dedication to research. Now I request Dr. Sana Javed to kindly receive her souvenir. We are grateful for her enriching presentation and expertise. Now I request Dr. Sana Shehzad to kindly receive her souvenir. We appreciate her insightful research and meaningful contribution to this conference. Now we request our session co-chair Professor Dr. Ikramullah Khan to kindly receive his souvenir. We extend our sincere gratitude for his guidance and support throughout this session. Now we request our session chair, Professor Dr. Atif Raza, to kindly come forward and receive his souvenir. We are truly grateful for your presence. This concludes the souvenir distribution ceremony. With this, we conclude day 1 of the 5th International Conference on Dermal Sciences. Now, we would like the guests, they are invited for lunch. We would like for them to proceed forward for that. Thank you so much, everyone. Have a great day.